you reach 35. If your RR is still, if your pH is still low after increasing the RR, now you might have to increase your tidal volume uh, uh, till your pH improves to more than 7.15. So, like we discussed in asthma COPD, here in ERDS also uh, you choose a strategy known as a permissive hypercapnia. There's some amount of CO2 retention or respiratory acidosis is allowed because you are ventilating a patient with low tidal volumes. Now comes setting peak. Now, this is also a long question. Strategies of how to set PEEP on mechanical ventilation. Your possible approaches over here are using ARD. First is using a standard ArtsNet escalation tables. Second is as per the compliance. Third is using PV curves. Fourth is staircase recruitment, or fifth is using an SVO2 monitoring. Next is ETCO2 monitoring or measuring transpulmonary pressures or focus EIT CT scans. See, all of these are possible strategies of deciding of what PEEP will be optimal for your ARDS patient. So the first is a ArdsNet PEEP FiO2 table. Okay, this was used in the ARMA trial, and it did show mortality benefit with these settings. The so the table, if you see on this side of your screen, you have a low PEEP FiO2 table and a high PEEP FiO2 table. Depending, so as and when you decrease the FiO2, that you increase the PEEP to the corresponding level. But problem with this, it is based on just consensus of the investigators. Okay, there was no scientific basis to this chart, and hence it cannot guarantee success. If you go for a high PEEP strategy, or increasing the lung stress and risking hyperinflation, also it will cause shunting. So your blood won't get oxygenated, which will not be very well tolerated in patients with pulmonary hypertension and a poor RV function. So these are the drawbacks of using a ready-made ArtsNet PEEP FiO2 table. The next strategy of setting PEEP is looking at the PV loop. So your PV loop, if you see, this is your inspiratory limb. Okay, so in the inspiratory limb, there is initially it is a curved shaped, and at one point it becomes steep and it becomes like a slope. So the point at which this transition occurs is known as your lower inflection point. Okay, so the lower inflection point is supposed to be that point required to open up the alveoli, and the other end on your expiratory limb, you will have an upper inflection point. So that it is that point where beyond which over distension will occur. So to the optimal PEEP is to be above the lower inflection point. So if you keep it just above, you keep your PEEP just above this point, most of your alveoli will remain open. Third is a compliance driven strategy. So the compliance. So for here you measure your P plat. Okay, driving pressure. Your delta P is basically P plat minus PEEP. So by this logic, if you purely look at this formula, if you increase the PEEP, you are actually requiring a lower driving pressure. Okay, but so how do you do it? You go on increasing the PEEP and you keep on measuring your delta P. All right, if your delta P is going above 14, it is associated with reduced survival. So that point at which your delta P doesn't go up is the point where your PEEP is optimal. Okay. Next is your intrapulmonary shunt monitoring. Okay. So what is the shunt fraction? The shunt fraction is the volume of blood that is passing through de-recruited, poorly ventilated lung. Okay. So if your lungs are not, if there is, so what your shunt fraction, it will decrease with recruitment and it will increase with over distension. All right. So how do you measure this? This is given by the equation of QS by QT, where QS is the shunted blood. QT is your total cardiac output, and the formula is this is your content, oxygen content in the capillary minus arterial oxygen content upon again oxygen content in the capillary minus venous oxygen content. Okay. CaO2 over here, this part is obtained by ABG. CvO2, this part might can be obtained by either a PAC or a mixed venous sample from a central line. And your CCO2 is calculated using the alveolar gas equation plus where hemoglobin, assuming your saturation is full, matlab your capillary saturation is 1. So when you put these values in this, you will get a shunt fraction. Now look at this graph, okay? So when your PEEP is low uh, versus your PEEP being high, so this graph is like a U-shaped graph. Okay, as you go on increasing the PEEP at one point, the shunt fraction will be the least, and beyond this, the shunt fraction will increase. So before this, there's all de-recruited lung, and beyond this, it's all over-distended lung. So this is the optimal point where you should set your PEEP. So you target your PEEP to achieve a shunt fraction of less than 20%. The next strategy is end arterial and end tidal CO2 gradient. Okay, so the difference between your arterial PaCO2 and your end tidal EtCO2 is what reflects the degree of dead space ventilation. So when this gradient is less, there is less wasted ventilation, and that means there is better alveolar recruitment. So you simply have to take an arterial blood gas, CO, PaCO2, subtract it with the EtCO2 on your monitor, and that will give you a dead space ventilation. So you titrate your PEEP at which this gradient is the lowest. Next is CT guided. This was done by Cressoni. They did, you take CT scans at two pressures. One is at 5 centimeter of water and one is at 45 centimeter of water. If your CT improves like this, that means the lung recruitability is good. You can go up on a high PEEP. But if your CT does not show any change, there is no much difference in the recruitment or in the aeration of the lung, then your your lung is not it's a poorly recruitable lung. So optimal PEEP required to keep uh, so what in this study what they eventually saw is that the optimal PEEP required to keep the lung open was the same despite low or high recruitability, so it's not very well used. Next is your transpulmonary pressure gradient. So your transpulmonary pressure is measured with the help of your esophageal balloon manometry. So it is, we'll discuss TPP in detail. In that you'll see that what they say is your PEEP should be set that your transpulmonary pressure is 0 to 10 at the end of expiration, and your tidal volume or driving pressure has to be set that your transpulmonary pressure is less than 25 centimeter water at end inspiration. Okay. What is the advantage of using this? It will, so over here you're measuring PEEP flat minus PEEP pleura, the pleural pressure. So you are actually separating the chest wall compliance from the lung compliance. So this is the pressure actually required to distend the lung. So whatever some patients, who are obese or who have a higher chest wall, have a most of your sorry, they have some chest wall deformity. Most of your pressure that you're applying is actually uh, going to work against this pleural pressure. So in that case, in such patients, you might be able to give better increase your driving pressure in order to get a good ventilation. So this is the advantage of TPP. It separates the chest wall compliance from the lung compliance. All right. For that, but what are the you need an esophageal manometry which is placed in the esophagus. There's an cuff inflated catheter over here, and the problem with this is that it is affected by a lot of other things. One is the elastic recoil of the esophagus muscle tone, pressure transmitted from the pleura, mediastinum, position and gravity also will have an effect on this, and it is closest to the left lower lobe of the lung, so it might not reflect pleural pressure in other better aerated regions of the lung. So these are the problems of using an esophageal pressure in order to measure your TPP. The next is ultrasound guided. You can just bedside do this. If you see these diagrams, First, you see if you apply a certain PEEP. Suppose your initial picture of the lung looked like this, where they were well separated B lines, and the same thing after application of PEEP. You see your B lines have gone more, A lines have come. So this is a more better aerated lung. So this means your PEEP is doing a good job. And the next picture, if you can see over here, there are multiple coalescing B lines. And when you uh, uh, apply a PEEP, the coalescing B lines now become more well spaced. So that means there is more aeration. Now, if you see in the last picture, you see it's more like a consolidation, tissue-like ecotexture of the lung. And after application of PEEP also, it remains the same. So there is no much difference by application of PEEP. So over here, the PEEP might not give you any benefit. At the same time, if you're using an ultrasound, look at the heart, look at RV dilation as a safety limit. And the last strategy is an EIT. It's a non-invasive technique. It has a poor spatial resolution. You can apply different PEEPs and see how much aeration is improving and then decide which PEEP you want to set. Now coming to the role of steroids in ARDS, early ARDS and late ARDS. Okay. So steroids have been studied in early ARDS by Meduri. Early meaning he had studied as less as 3 days. Within 3 days, he gave methylprednisolone 1 milligram per kg per day for 26 days. And what his study proved that there was an improvement in the pulmonary and extrapulmonary organ dysfunction. There was decreased inflammation. There was decreased mechanical ventilation duration, decreased length of stay. But all of this did not translate into a mortality benefit. So in early ARDS, there is some benefit of using steroids, but not a mortality benefit. In late ARDS, this was studied by the ArtsNet trial, and they did it in around 180 patients. Over here, it was the effect of steroid was studied between 7 to 28 days. Methylprednisolone versus placebo over here. So the effect of steroid was studied between 7 to 28 days. In COVID ARDS specifically, we have the recovery trial, which has shown improved survival with the use of dexamethasone 6 milligrams a day for 10 days. And then lastly is the DEXA ARDS trial done by Willer et al. It was published in Lancet. Over here, they studied moderate to severe ARDS patients on mechanical ventilation, and they found that the DEXA group had 4.8 more ventilator-free days and a 15% absolute risk reduction in mortality. Okay, though it was a positive study, there were a lot of issues with this trial, methodological issues. There was no proper masking. Patients had used steroids even before enrollment, so that is why it's not really none of not really found its place in practice. So when you're describing an exam, you can just write the effect in early ARDS, late ARDS. Definitely beyond 14 days, it worsens mortality. In the early stages, it has some improvement in oxygenation and organ dysfunction and duration of mechanical ventilation, but none of this causes any mortality benefit. So you have to tailor the use as per your case. The next is the role of neuromuscular blockers in ARDS. Neuromuscular blockers, this itself is a question. There are two trials that you have to know. One is the Accuracy trial, which was done in 2010. Okay. Why do you need to know both these trials? Because both of these trials produced contradictory results. The Accuracy trial said that there was mortality benefit with the use of neuromuscular blockers, whereas the next trial, that is the Rose trial, showed that there was no mortality benefit. Okay. So let us go a little into the details of these two. So what did the Accuracy trial did? It studied 340 patients. 340 patients may say half of them received cis atracurium with deep sedation and half of them received only placebo with deep sedation. What was the primary outcome measured was mortality before discharge or at 90 days, and it was significantly lower in the cis atracurium group, and secondary outcomes also showed some benefit. 28-day mortality and number of ventilator-free days were better in the cis atracurium group versus that in the placebo group. Okay, this was done in 2010. After this came the Rose trial. Almost 9 years later, in 2019, the Rose trial came up. Okay, here they studied 1,000 patients. Okay, this was an unblinded trial, but mind you, if you're using a neuromuscular blocker, the blinding, even if you are blinded, the effects are very obvious. Okay, so this was done for the earlier trial. We saw only 340 patients. So this was a larger study done in 1,000 patients. What they did is they compared cisatracurium for 48 hours with deep sedation versus only light sedation. So this is another difference over here. Okay, over here they compared it with deep sedation, over here it was compared with light sedation. Uh, and what did they find? So this trial was stopped in the second interim analysis due to futility, and they said that it has no mortality benefit and it may actually worsen your ICU acquired weaknesses as compared to light sedation. Okay, so obviously you're comparing arm is light, over here is light sedation. That so what are the limitations of this trial? Around 10% of both arms received neuromuscular blockade between inclusion and randomization. Okay, so you can't say this studied, it purely studied the effect of using versus not using. Also, a lot of patients in the control arm did receive neuromuscular blockade boluses. And another major difference is this proning. Okay, over here only 15 to 8% patients were prone, whereas in your accuracy trial, almost total almost 50% patients were prone. Okay, so though this trial came very early that time, even then most of the patients had proning, and proning we know is a strategy which has definitely definite mortality benefit. Okay, so that was one of the differences thought of as to why one trial showed benefit with neuromuscular blockades and the other did not. So what are the key differences? I've already studied this. I've just put them in points for you to revise in exam. Sedation strategy in each arm that we have already discussed. Timing of enrollment. In the rows, they were enrolled earlier, around 8 hours, whereas in the accuracy is around 16 hours. PEEP level. Okay, the average PEEP level in the Rose trial, they used a higher PEEP, was higher mean PEEP versus that in the accuracy trial. Prone positioning rates we have already discussed. Pre-randomization, neuromuscular blockade use we have already discussed, and trial size and power. Okay, so that also we have seen. Rose, the number was lower, and the power they used. They used an adjusted and unadjusted mortality analysis in the accuracy trial. In the Rose trial, though the strength was more, it was stopped for futility. So ultimately, it was underpowered. So what should you do? Should you use it or should you not use it? So what does your guidelines say? It does not recommend the routine use. Okay, the keyword being routine. In selective patients and selective scenarios, it can be used uh, uh, if there is a high risk of barotrauma or persistent patient ventilator dysynchrony despite optimized ventilation, and the use should be only short term for 48 hours, and patient should be monitored closely to avoid complications of critical illness myopathy. So how do you do the monitoring? It should be checked with peripheral nerve stimulation using a train of four response, targeting it to be 0 to 1. Avoid prolonged use, and no routine recommendation for on demand bolus versus continuous infusion. Whether you should just give simple boluses whenever needed or whether you should give a continuous infusion is really not studied. So there is no specific recommendation on that. Next is the prone ventilation. Prone ventilation, physiological benefits of prone ventilation. So now I'm going to discuss three major mechanisms by which prone ventilation has proven to have benefit. These are very specific, so you please make sure that you write your answers like this. This is also a frequently asked question. Okay, just don't simply try to attempt in prone, the posterior lobes open up or gravity effect or so. Be specific with the with the physiology of it. So the first physiological benefit is transpulmonary pressure. Okay. So what happens when the patient is supine? The dorsal pleural pressure is much more than the ventral. Okay. So we know na transpulmonary pressure is your alveolar pressure minus pleural pressure. Okay. So when the patient is in the supine position, the pleural pressure in the dorsum is more. Okay. So now the transpulmonary pressure, the pressure applied in the dorsal regions will be less as compared to those applied in the ventral regions where the alveolar where the pulmonary pleural pressure is lesser. So there will be regional over distension. Anterior part, ventral part will get over distended, and the lesser TPP applied in the dorsal part, meaning the alveoli will collapse further over here. Okay. So the same thing when you prone the patient, now the pleural pressure in the dorsal part is less. Okay. So most of your transpulmonary pressure, most of the pressure applied is delivered to the dorsal regions. Okay. And we know that the dorsal region is the region where maximum alveoli or more lung volume is there. So there is more recruitment. Okay. This is one, but for this is the first mechanism. The second mechanism is mediastinal and diaphragm pressure. Okay, so in the supine position, the pressure exerted on the lungs, the lung gets compressed by mediastinal structures, diaphragm comes up. There are so the abdominal structures increase the compression, and because of this, when you prone the patient, all of this is relieved, and that allows better lung expansion. The last mechanism by which proning benefits is VQ mismatch. So when the patient is in the in the supine position, though the dorsal area is better perfused, it is poorly ventilated. Now, when you make the patient prone, remember now the perfusion is still better in the dorsal areas only, okay? But your ventilation is better, so your VQ mismatch decreases, and that is how your oxygenation improves. So, these 3 points you should write an exam. What happens to the transpulmonary pressure, mediastinal and diaphragmatic pressures, and VQ mismatch. So, what is the indication of proning patient? Any ARDS patient who fails to improve with lung low tidal volume ventilation early in the disease. Key point being early in the disease. Contraindications to proning. There's only one absolute contraindication to proning is when you have an unstable spine fracture. Other all contraindications relative. You can still prone your patient if the benefit is going to be greater than the risk. These are open abdominal wounds, raised ICP, pregnancy, severe facial trauma, or an open chest. Duration 12 hours per session. The ProSeva trial did 16 hours. And the evidence for proning. Okay, so now proning has been described right since 1970s. But all the initial RCTs did show that oxygenation improved, but they did not show that mortality benefit was there. ProSeva trial was the first trial to say that there was a mortality benefit, and further meta-analysis also showed mortality benefit. So, like I said, low tidal volume ventilation and proning. These are the only two strategies which have a proven mortality benefit. Okay, a brief about the ProSeva trial because again, it is one of the potential questions. It was studied in around 800 patients in ARDS. It was published in 2013 in NEGM. What they did is proning sessions of at least 16 hours, and in the control arm, the patients were left in supine position. What they saw is that the prone group had 16% mortality versus supine group had 32% mortality, almost half. Okay, so there was such a significant improvement in mortality, and hence it has been recommended. Next come the recruitment maneuvers in ARDS. So what is the rationale of doing recruitment maneuvers? You improve the arterial oxygenation with a short lasting increase in intrathoracic pressure. Whatever the current evidence is there, it is against routinely doing recruitment maneuvers in ARDS patients. You do it only in specific conditions when as a rescue maneuver. Okay, I'm gonna just so when suddenly you so these 2 points you should write. I'm really sorry, this should not be in the slide. Whenever there is an evidence of de-recruitment, suddenly some procedure was done. Suppose ventilator circuit was got disconnected accidentally, or you are uh, doing some suction and the patient got sudden desaturation. Okay, so transiently, to just tide over a crisis, you use recruitment maneuvers. Okay, the evidence is only for such short short term use when there is sudden desaturation due to some disconnection in the circuit, or suctioning. Okay, so most of the alveolar recruitment occurs in the first 10 seconds, and this beyond that, your high intrathoracic pressures will ultimately cause a hemodynamic collapse. But it is said in these studies, the BP recovered within 30 seconds after stopping the recruitment maneuver. Now, how do you do these recruitment maneuver? One is a CPAP technique, one is a staircase maneuver, third is a intermittently increase the PEEP, and fourth is periodic size. Size means you apply a few breaths with high inspiratory pressure for a or prolonged inspiratory time. Okay, high inspiratory pressure is as has a 45 centimeter of water. So the first method is CPAP. This was described by Arnal et al. Here, what you do is you raise the pressure support on CPAP to 40 and keep it at 40 for 30 seconds. Okay. If you're using a pressure controlled ventilation, you set the rate to zero, turn off the apnea alarm, and increase the PEEP to 40 for 40 seconds. What will happen is most recruitment will occur in the first 10 seconds, and after this, there might be a hemodynamic compromise, which you might have to tackle. The next is the staircase recruitment maneuver. Here, what they have done is, I'll show it to you in this diagram. Basically, you set you're doing this on pressure control ventilation. You set the pressure at 15, and you stepwise increase the PEEP from 25 to 35 to 45 every 2 minutes. Okay, and then what you do is you start gradually decreasing the PEEP by 33333 every 3 minutes, and then what you see is the saturation. Wherever the saturation desaturates, that level is where your recruitment is lost. So just 2.5 centimeter or 3 centimeter of water above that is your set peak. Okay. So this is one recruitment maneuver along with one strategy of setting peak. What are the contraindications to using recruitment maneuvers? Any untreated pneumothorax or air in the subcutaneous mediastinal pericardial spaces, severe obstructive lung disease, lung hyperinflation, unilateral lung disease, MAP, if you already have hypotension less than 60, intracranial hypertension, or severe call pulmonale. These conditions you never use a recruitment manuals. Most of these have fallen out of practice. Only you can use it when to tide over a transient crisis. That's it. Now coming to the role of VV ECMO in ARDS. So what is VV ECMO? It is basically an extracorporeal life support where you are providing respiratory assistance to the circulating blood uh, through an external machine by adding oxygen, removing carbon dioxide uh, to bypass the lungs in case of a severe reversible respiratory failure. So these are the overall indications of VV ECMO. Any severe ARDS, lung rest if you have pulmonary contusion, smoke inhalation injury, lung transplant as if there is graft failure or just as a bridge. Status asthmaticus, massive hemoptysis, barotrauma, airway obstruction, aspiration syndromes, Murray score we've already seen more than 3, PF ratios less than 100 even despite high PEEP and high FiO2, severe hypercapnia. So specifically in ARDS, the EOLIA trial gave us certain indications. Okay, so these three indications you need to know pit pat. First, PF of less than 50 for 3 hours despite optimal mechanical ventilation and using adjunctive therapies. Second, if the PF is less than 8 for more than 6 hours, despite both of these A and B. And third is if your pH is less than 7.25 or with a PCO2 of more than 60 for more than 6 hours, when your RR is already 33 and your ventilator settings are such that your P plat is less than 32. So these three are the classical indications of using VV ECMO, which is given to us by the EOLIA trial. What are the contraindications? The absolute contraindications are irreversible cardiac or pulmonary disease, any metastatic malignancy, significant brain injury, no, current intracranial hemorrhage, major pharmacological immunosuppression, and relatively higher age, mechanical ventilation at high settings, and multi-trauma patient with a high risk of bleeding. Evidence ECMO has been asked. First is the Caesar trial, ventilation, keyword being ECMO referral. Okay. So though it says a multi-center trial, all of these centers were supposed to put their patient to a single hospital which had ECMO experience. So that was so if they've met this criteria where the PF was less than 200, Murray score is more than equal to 3, uncompensated hypercapnia, and less than second ventilation with respiratory failure, were transferred to this one hospital. Okay, they were referred to either they were random protection. They received ECMO or a control arm that received only conventional management. So what did they see? The primary endpoint was death ability at 6 months. So here I have mentioned both intention to treat and per protocol trial. So what happened is they referred these patients. Many of them were, even though they were in the ECMO arm, they didn't receive ECMO because they just got stabilized later. Okay. And only actually out of the 90 referred, only 68 more protocol results still favored ECMO. Intention to treat analysis said also ECMO. Okay. So after this, it was said that the referral to an ECMO. So that is why over here the keyword being referral to an ECMO center. So what we got from this trial that sending the patient to an ECMO center improved, had some survival benefit. But this was probably just because the efficacy of the center itself. But this was the first RCT that ever showed a survival benefit with ECMO, and this formed the foundation of using ECMO today. After this came the Aeolia trial that actually studied the effects of ECMO versus conventional ventilatory strategies. What they found was that there was a mortality benefit, but this was not statistically significant. Okay, so that is what the ultimate conclusion was, that it did not improve 60-day mortality. But what this study also found is that the crossover of patients from conventional to ECMO was significantly high. So definitely some benefit was there. So just because of the crossover, probably uh, uh, the results were not clinically significant. So definitely, if the patients were being crossed over to an ECMO, that does show that there was some potential benefit in a refractory case. Now, the last part of ARDS is the role of fluids. How do you manage fluids? This is given to us by the FACT trial. The FACT trial basically studied conservative and liberal fluid strategy in ARDS. And what did they find? That the patient had, they achieved a good difference in the fluid balance in both arms, but there was no mortality difference. Okay. Ventilator free days, ICU free days were significantly better. So, though there's no mortality benefit, even if you are having your oxygenation is improving and your ventilator free days, ICU free days are improving, these are also good endpoints to state. So, based on this trial, we usually prefer to keep the patient slightly dry. So, the consensus is to avoid fluid overload, use diuretics very judicially. So, again, over here, keyword being hemodynamically stable patients. You can use diuretics to get a negative fluid balance and improve oxygenation, but you should not. There should be no compromise in renal perfusion. Don't keep on using till your creatinine is going on rising, and it should be tailored to the patient. So if the patient is in shock, now you prioritize fluid resuscitation, restore the perfusion. But once the perfusion has been established, you then transition to a conservative strategy. The next part on airway and mechanical ventilation, I think I better take this in the next session tomorrow. So whatever remaining topics, they're relatively smaller topics, I will cover tomorrow. Okay. So I think at this point, I'll invite Dr. Amrita to take the next session in cardiology.
I think Dr. Amrita will be joined by 6:30. So
Okay.
I'll be taking over the next session. That was an extensive discussion on ARDS.
Okay.
So there was some question regarding the waterfall phenomenon. So regarding the waterfall phenomenon, there are two things. One is the bicarbonate excretion that happens in the kidneys. In decay, what happens is that when the bicarbonate reaches the level of 12, the kidneys almost stop excreting, like almost it is zero. After that point, there is a steep fall. So that is something. And if you're talking about the renal threshold for glycosuria, so in that phenomenon, in that aspect, the renal threshold normally what they say is around 180, beyond which there is a excretion of glucose which begins. So it is not that all nephrons are simultaneously starts excreting. It's heterogeneous phenomenon. So there is a small curve and then there is a steep fall. I mean, there is a gradual increase. So that is also known as a waterfall phenomenon. So let's go to the other topic in thyroid. So, hope everybody is okay to continue, not exhausted. You're able to match with the classes and able to listen to. Yeah, okay. Thank you, Dr. Kushbu. So regarding thyroid hormones, before going into the specific topics, small brush up on the basics. Okay, thyroid hormones normally stimulated by the TRH, which is produced by the hypothalamus, then the TSH, which is produced by the pituitary, which stimulates the thyroid gland uh, to produce T4 from iodine and thyroglobulin. So the T4 is produced in the thyroid gland. In the peripheries, T4 is converted into T3 by deiodinases. Okay, this happens in the peripheral tissues. So most of which is active actually. T3 is the most active form and some of T4 gets converted into reverse T3 as well. So when we are terming the disorder, if the disorder is primarily in the thyroid, it is primary disorder. Secondary, when it is related to the TSH, and tertiary, when it is related to the hypothalamus. So when you're interpreting your thyroid functions, look into free T3 and T4 and your TSH levels. So if your TSH is low and your free T3 and T4 is low, it is problem with the central pituitary, that is central hypothyroidism. If your TSH is high and your T3, T4 is low, then the problem is in your thyroid. Okay, there is a feedback mechanism wherein your TSH is increasing to produce more T3 and T4. So the problem is in the thyroid. So if your free T3 and T4 is high and TSH is low, it is primary hyperthyroidism. If both free T3 and T4 as well as TSH is high, it is secondary, okay, secondary hyperthyroidism. So that is the basics. So these are some values, okay, the TSH value being 2.5 to 5 international units per liter. So T3 is the metabolically active form. So most of it is from T4 due to peripheral conversion. And most of these T3 and T4 are bound to thyroxine binding globulin. Okay, so just remember that aspect. So we'll go into thyroid storm directly. So what is it? It is acute life-threatening form of thyrotoxicosis or a decompensated hyperthyroid state with multi-organ failure. Mortality is up to 7 to 30%. Okay, etiology, it can be due to any precipitating event like infection, trauma, DKA, any thyroid surgery, any accidental or intentional patient will be in tachycardia, tachyarrhythmias, especially atrial fibrillation, ventricular fibrillation. There will be a high cardiac output state, hyperdynamic circulation. And the patient will have high systolic blood pressure, systolic heart failure, leading into pulmonary edema also. Okay, GI, diarrhea, nausea, vomiting, abdominal pain, the liver can be affected. There will be altered liver function test, jaundice, and hepatic failure as well. Patient with chronic features will have weight loss, goiter, exophthalmos, tremors, so all these things. Labs, when we look into the labs, there can be elevated WBC count, there can be mild anemia, thrombocytopenia, not very common, but thrombocytopenia can also be there. And the creatinine kinase can be elevated, resulting in rhabdomyolysis and acute kidney injury. The LFTs will be deranged. There can be abnormal elevation of the liver enzymes and bilirubin also. There can be hypocalcemia, hypercalcemia, there can be hypokalemia associated. Cardiac markers can be elevated. Okay. The thyroid related tests. So when you are looking into T3 and T4, both T3 and T4 levels will be elevated and TSH will be very low or undetectable. Okay. Also, there will be associated hyperglycemia. So how do you diagnose? What is the score or scale that is being used? This is the Bush-Watzowski score or the point scale which has been used. So it involves almost 6 parameters: temperature, any precipitant history, then CNS effects, including psychosis, or is the patient is in coma. Depending on that, mild agitation to coma, they grade it with 10, 20, and 30. Gastrointestinal aspect, diarrhea, nausea, severe symptoms like unexplained jaundice, 10. Tachycardia and atrial fibrillation, so this is graded from 5 to 25. Heart failure with pedal edema, basal rales, and pulmonary edema, 5 to 15. So based on this, you have a score of up to more than 45. So less than 25, thyroid storm is unlikely. 25 to 45, it is impending storm, and more than 45, it is thyroid storm. Okay, so what is the differential diagnosis? Most of the time, you need to make sure if the patient has taken some other medications. Psychotic medications can lead to neuroleptic malignant syndrome, malignant hyperthermia, severe infections, acute mania with catatonia. So those are the differentials. Supportive care. IV fluids, cooling blankets, maintain the temperature, maintain ventilation, oxygen therapy, maintain your electrolytes, then sedation if needed, and drugs. What are the drugs you will give and what are the mechanism? First, propylthiouracil, methimazole, iodine, propranolol, hydrocortisone. So these are the drugs which are commonly used. Propylthiouracil 500 to 1000 milligrams and then that as a loading dose followed by 250 milligram every 4th hourly. So this acts by blocking the new hormone synthesis. It blocks the conversion of T4 to T3 as well. And methimazole, this is 60 to 80 milligram per day. It also blocks the new hormone synthesis. Propranolol, same dose every fourth hourly, 60 to 80 every fourth hourly. The mechanism of which it acts is, one is it blocks the T4 to T3 conversion. Another, it prevents heart failure as well. And iodine 5 drops orally every sixth hourly. So do not start until 1 hour after thyroid drugs are being initiated. So remember, the first drugs will be propylthiouracil, then propranolol, then you can go ahead with iodine. So it also blocks the thyroid hormone release. These patients will also have associated adrenal insufficiency, so supplement with hydrocortisone. 300 milligram IV bolus followed by 100 milligram every 8 hourly. So this, along with supplementing or maintain or supplementing for the insufficiency, it will block the conversion of T4 to T3 conversion as well. So these are the drugs and treatment for thyrotoxicosis or thyroid storm. So next we'll go ahead with myxedema coma. So this is a life-threatening hypothyroid complication with multi-organ dysfunction associated with altered mentation. The mortality ranging from 25, it is variable actually. So it's up to 20 to 25%. And it results from long-standing untreated hypothyroidism. Usually, it can present at any form from mild to severe form as well. The precipitating factors, remember, the any infections, any trauma, not taking proper medications for non-compliance, burns, other cardiac failure, any stroke, or some medications like anti-TNF therapy. Two drugs you need to remember, amiodarone and lithium. The mechanism of amiodarone is that it inhibits T4 to T3 conversion and releases excess iodine. So this is the mechanism of amiodarone induced myxedema coma. Lithium, it causes it inhibits thyroid hormone release and CMP production in response to TSH, so exaggerated TSH response. So these are the various drugs, other drugs like phenytoin, rifampicin, diuretics. So these are the precipitating factors. Clinical features: altered mentation resulting in complete augmentation of the mental status. The skin can be coarse and dry, hypothermia, hypoglycemia, hypotension, bradycardia, other ECG changes like blocks can happen. There can be atonic GI constipation, bladder, bladder disturbances. There can be effusions, pleural, pericardial, peritoneal effusions can be there, and intolerance to cold. So all those are clinical features. Differential diagnosis. So these are the differential diagnosis. Any patient who's septic, hypoglycemic, malnourished. So these are post-cardiac arrest status. So these are differential diagnosis. So how do you diagnose? Okay, there will be a subnormal free T3 and T4 levels with an elevated TSH that will be more than 20 most of the times. Okay, that is kind of confirmatory along with the typical clinical signs and symptoms. How will you treat? Treatment is mainly supportive and supplementation of the thyroid hormone. So what are the complications? So patient will be hypoventilating. So you'll have to maintain the ventilation. Hypothermic, maintain the temperature. Hypoglycemic, supplement glucose. Hyponatremia can be there if the patient's in altered sensorium, supplement with hypotonic saline and treat the underlying precipitative cause. Avoid all if the patient uh, is in altermentation, or try to avoid sedatives. Intubated patient, it depends. Avoid sedatives, hypnotics, and narcotics as much as possible. The ultimate treatment would be supplementing T3 and T4 along with glucocorticoid supplementation. So, because these patients who have a thyroid hormone deficiency also have an associated glucocorticoid deficiency. So, always supplement thyroid along with hydrocortisone. So, which is the preferred one? Preferred one is T3. Okay, a loading dose of 5 to 20 micrograms IV, followed by a maintenance of 2.5 to 10 micrograms eighth hourly. Okay, so this acts early. So the clinical improvement with T3 occurs as early as 3 to 4 hours compared to T4. T4 takes a longer time. So the action begins at 24 hours. So always remember, if T3 is available, that will be a better therapy. But if T3 is not available, either you can begin with T4, a loading dose of 200 to 400 micrograms, followed by 1.6 microgram per kg body weight. So this is the dose that has been recommended. Okay. So along with that, because of coexisting primary or secondary adrenal insufficiency, give hydrocortisone 200 to 400 milligram IV every day. So it can be given every 6 or 8 hourly. So this can be discontinued. So once the patient state is improved, they have to continue with supplemental doses. So that is about myxedema coma. The next topic is sick thyroid syndrome. So this is an acute reversible state occurring in almost 15% of hospitalized patients. It is one of the defense mechanism to prevent catabolic status in an already calorie deficient state. So why does this happen? So it's because of the patient is critically ill. Most of the time in sepsis, there is elevated cytokines, period of starvation, there will be increased cortisol levels. The main issue is with the peripheral conversion of T4 to T3, which is impaired. So this enzyme, the peripheral 5 monodeiodination, is inhibited. So what happens is that T4, almost 70 to 80% of T4 gets converted to T3 in peripheral tissues, and some of which gets converted to reverse T3. So this is the normal phenomenon. This 5-monodeiodinase enzyme is responsible for this conversion. This step is blocked. So most of T4 gets converted into reverse T3. And the clearance of reverse T3 is also impaired. So that is why it is known as low T3 or high reverse T3 syndrome or sick thyroid syndrome. It is also known as non-thyroidal illness. Okay. So rapid decrease in free T3 occurs 4 days, at least 4 days. Increase in reverse T3 occurs at 12 hours and it normalizes. Once the patient state is improved, it normalizes. The degree of illness is proportionate to the degree of suppression of the TSH. And ideally, after the patient condition improves, recovery happens 24 to 1 to 2 days later on. So looking at the mechanism, so why does this happen? It happens at various levels. If you look at hypothalamus, because of malnutrition, sepsis, inflammation, there is decreased TRH. In pituitary, because of cytokines, there is decreased TSH. In plasma, there is decreased thyroid binding globulin. And tissue uptake, there is decreased uptake of the T3 and T4 as well. Okay, and there is abnormality in the transporter expression. Intracellular deiodination occurs. Okay, D1 is the beneficial receptor, whereas D2, but D1 is decreased and there is D2 which is increased. Okay, and the nuclear thyroid receptors are also altered. So these are the various mechanisms that have been described. So this is something very important that you need to understand. So in various degrees, like in sick thyroid syndrome, it can be mild, moderate, severe, and as the patient recovers, most of the hormones normalize. So first look at TSH. So this is TSH and this is the normal range. So when we look at TSH, it is almost in the normal range in mild, moderate, and in severe, there is a mild dip. And then it kind of normalizes. It is almost in the normal range in every point of the severity of illness. You look at T3. The T3 is low. So low T3, that is why it is known as low T3 syndrome. From mild, moderate, severe, there is kind of low T3. So you look at T4. T4 in the mild stage might be normal, but as the severity increases, the T4 level drops down. Severe level T4 drops down. That is why low T4 indicates a poor prognosis. So, and as recovery occurs, T4 normalizes. Look at reverse T3. So, reverse T3 is always in the higher side. So this graph is very important to describe your hormonal levels in every stage of the sick or every stage of your illness. And low T4, I already mentioned, it indicates poor prognosis. The severity of in severely ill patients manifest with low T4 and TSH. So in severe condition, the TSH will be mildly low and the T4 levels will be very low. So if you are having a TSH level in extremes, okay, if it is like most of the time we saw that the TSH is always in the normal range. So there can be a very slight decrease in the TSH, especially during the severe stage, or there can be a mild increase also. But if it is beyond extremes, like less than 0.1 mu per liter or more than 20, then you have to consider either it's hyper or hypo. It's overt hypo or hypothyroidism in that scenario. And do not suggest CQ thyroid status in extremes of TSH levels. Okay, more than 20, suspect overt hypothyroidism. So, is this of any kind of like value because of the low hormone levels? Does it require supplementation? No, it indicates some kind of prognosis, poor prognosis to the patient, but supplementation with thyroxine or T3 does not provide any benefit to the patients. So, in acutely ill patient without clinical signs, do not treat sick thyroid status. There is no reduction in the mortality with thyroid hormone supplementation. Next, we'll go into adrenal disorders. So, some basics about adrenal. So, this is the hypothalamo-pituitary adrenal axis. So, the hypothalamus produces the CRH, pituitary produces ACTH, and the adrenal, okay, produces the cortisol. Primary disorder, adrenal, secondary pituitary, and tertiary hypothalamus. So when you are classifying adrenal insufficiency, it can be primary, secondary, or tertiary. And CERC is a relative adrenal insufficiency. Okay. And it can be classified as acute or chronic depending on the duration of the symptoms. The prevalence, if we see in critical illness, the adrenal insufficiency is up to, relative insufficiency is up to 30%, especially in shock, it increases up to 40%. Absolute insufficiency is very, very rare. So there is always a relative insufficiency. So what are the functions of cortisol? We all know that it's a hormone flight and fright response. Okay, it is mainly involved in gluconeogenesis, anti-inflammatory effect, maintenance of vascular tone, endothelial integrity, and it increases the sensitivity to catecholamines, reduction in nitric oxide mediated vasodilation, and modulation of angiotensin synthesis. Those are the various functions of these hormones. So what is the definition of adrenal crisis? Definition of CERC. So it is defined as adrenal crisis is defined as life-threatening form of adrenal insufficiency where the glands cannot produce enough cortisol to meet the body's demand, especially during stress. What is CERCI? This is occurring in critically ill patients due to dysfunction of the hypothalamo-pituitary axis due to altered metabolism, tissue resistance to corticosteroids. Okay, so this is a relative insufficiency, and in periods of stress, the body response may not be adequate to adequate. Okay, that is CERCI. So etiology broadly classifying into local when you're thinking about adrenal gland. So anything related to the adrenal pituitary, so renal cell carcinoma or Addison's disease, tuberculosis, sarcoid, amyloid, chromatosis. So you can, or any neoplastic invasion, so trauma, so or shock, all those things related to adrenal. So in general, sepsis, infection, meningococcus is something that you should not forget. TB, HIV, meningococcal infections. So all these things you have to remember. Postpartum pituitary is another important thing. Other things, vascular etiology, iodine, material embolize you and suppress the adrenals. Of the corticosteroid as well. So these are the various drugs that cause suppression of the cortisol. So insufficient, if the patient has been on prolonged steroid supplementation and abruptly weaned off, so that is one of the etiology. And it can be an increased demand, which we already saw. So the normal cortisol levels, when we see, it's early, there is a diurnal variation always, and it is advised to take the cortisol between this times. 8 a.m. is the normal time that we have taken. It's are usually 10 to 20 microgram per deciliter. And the normal cortisol levels 10 to 50 nanogram per liter. Normal production of cortisol is between 15 to 20 milligrams per day. And during stress, there can be an increase in requirements up to 50 and 150 per day. Okay, so you will have to exogenously supplement. Okay, there is a sick day rule, something like sick day rule, when there can be an increase in the requirement. In burns, there is some increase in requirement of the cortisol. So clinical features, when we are looking into, you have to know about the acute, chronic, and CERCI relative. So when we are talking, the symptoms can overlap actually, the clinical features. Acute, the patient will be frankly in shock. That hypotension, not responding to fluids. This is very important. Along with other features, hypoglycemia will be there, hyponatremia, hyperkalemia, metabolic acidosis, hypoeosinophilia, hypoglycemia and eosinophilia. So these are the important features you will be able to appreciate. In chronic phase, hyperpigmentation will be there because of increased ACTH secretion. There can be hyperpigmentation in the skin. Okay, and other features, altered consciousness. Okay, normochromic anemia, hyperdynamic circulation, diarrhea. So these are other features. So when in ICU, the typical features are non-venability from vasopressors. That is one of the indications. The patient would have improved from sepsis, recovered almost, but requiring a mild dose of vasopressors. That is one of the features of CERCI. So why does this happen? The mechanisms which is leading to CERCI, there are 4 things that you need to remember. So one is altered synthesis of cortisol that can be due to necrosis, that can be due to production defects, some esterification in the cortisol, inhibition of steroidogenesis. This can be due to DIC, shock, other cytokines, so decrease in synthesis, altered CRH and ACTH. This can be due to again necrosis and due to various other factors. Okay, alteration in metabolism. Okay, decrease cortisol transport, decrease cortisol breakdown. Again, the binding proteins can be deficient. There can be defect in the glucocorticoid inactivator 5 reductase enzymes and tissue resistance. So remember these 4 mechanisms alone. So what happens in CIRSE? There is an acute phase and there is a chronic phase. So the cortisol levels in initial phases of critical illness is elevated because of various factors. It is not just because of ACTH elevation, but because of various other factors like cytokines, marked inflammation, neuropeptides. So all these things cause a elevated cortisol level. So during that acute phase, there will be a transient increase in the ACTH levels, but after some time, the ACTH levels falls down. So there is a dissociation between plasma cortisol and ACTH levels. Then what happens in the chronic phase? Gradually, as the ACTH levels are low, there is persistently low, there is adrenal gland that is less stimulated and atrophy of the adrenal gland, which happens. And gradually, there is a decrease in the cortisol secretion. So this happens in the chronic phase. So the plasma levels of cortisol will be proportional to the duration of critical illness. So these are the two phases. So when we look in detail about this, so prolonged illness, there is initial hypercortisolemia resulting in decreased ACTH, loss of ACTH mediated stimulation of the adrenal cortex. So this gets atrophied. So what are the reasons why hypercortisolemia? Also high bile acids, other exogenous glucocorticoid ligands. So all these things cause negative feedback and sustained inhibition of pituitary as well as CRH. Okay, ACTH as well as CRH will be inhibited, and other drugs, whatever we are giving in the ICU, etomidate, opioids, azoles, rifampicin, phenytoin. So all these inhibit. Okay, so gradually there is a decline in the free cortisol as well as low cortisol levels. There will be other symptoms. Okay, this is the main pathophysiology of CIRSE. So how will you detect it? How will you detect? So if you find a cortisol level that is less than 10, that is diagnostic of CIRSE. Or if you find a random cortisol level that is more than 10, but still the patient has features of hypocortisolism, you do a ACTH, okay, ACTH stimulation test. Okay, how is it being done? So 250 microgram of synactin is given, IM or IV. 30 minutes later, first a baseline cortisol is taken, and then 30 to 60 minutes later, you check the cortisol level. The difference between the cortisol prior to administration and after the stimulation, that is 1 hour after stimulation, if the delta cortisol level is less than 9, that is ACTH fails to stimulate the production of cortisol or increase the production of cortisol. So if your delta cortisol is less than 9, that indicates CIRSE. Okay, so random cortisol less than 10 or a delta cortisol less than 9 by co-synoptin simulation test. So so how do you treat that? Before that, patients who are the patients at risk are at risk of developing this insufficiency, especially For major surgery, usually 25 milligram at induction, 100 milligram per day for the next 2 to 3 days. So this is the advised recommendation in perioperative period. So when you're looking at a critical ill patient, obviously the patient can be in crisis. In that scenario, either it's primary or secondary, you supplement 100 milligrams bolus followed by 200 milligrams IV every day. So how do you taper it? This is on first day. Then you can slowly taper it down to 60 milligram IV per day. So this is and follow up with the endocrinologist. In refractory septic shock, you should not do a stimulation test. Always remember there are various studies that are available starting from NN to adrenal. So we have evidence in septic shock, refractory shock, evidence to supplement with the steroids, stress dose of steroids, so 200 milligram every 24 hourly. We give it at either as an infusion 200 milligram or 56 hourly. Okay. When hemodynamic improvement happens, then you can stop it at 5 to 7 days. So in prolonged illness or critical illness, in SIRC, what is the recommendation? In SIRC, the recommendation is to give 60 milligram IV 24 hourly. That is 40 milligram in the morning and 20 in the evening. Okay. And later on, as the clinical improvement happens, taper off, follow up with the endocrinologist. So that is about our endocrine. So can we move on to metabolic, or Dr. Amrita wants to join?
I think you can complete your part.
Okay. So I'll be doing hypercalcemia and hypokalemia now. So hypercalcemia is defined as an increase in the serum calcium more than 10.5. So whenever you're talking about the serum calcium level, always remember you need to measure the corrected calcium. So for albumin, for every decrease in 1, you will have to increase the calcium by 0.8. The factor is 0.8. So remember that. So serum calcium more than 10.5 milligrams is defined as hypercalcemia. And symptoms become evident when the serum calcium levels is more than 12 milligrams per deciliter, or if the ionized calcium levels are more than 3 millimoles per liter. Okay, the most common etiologies are primary hyperparathyroidism or hypercalcemia of malignancy. So these are the various causes. So primarily think about the parathormone increase. Okay, it can be parathormone production can be high. So when does that happen? It can happen in primary hyperparathyroidism due to any adenoma or hyperplasia of the gland. Tertiary hypoparathyroidism. When does this happen? So patients with renal failure, what happens is that there will be kind of low calcium levels, which causes feedback, and it causes increase in parathormone. Ultimately, there can be hypertrophy leading to high parathormone secretion. Okay, that is one. And patients with alteration in the calcium sensor receptor function and lithium therapy. So these are associated with high parathormone production. Next is hypercalcemia of malignancy. This is due to overproduction of the parathormone related peptide. So this can be produced by many solid tumors, and others like breast, myeloma, all those things can cause lytic lesions in the bone, which can result in bone resorption. So diseases like granulomatous diseases like TB, sarcoid, silicosis, all those things can cause excessive 1,25 dihydroxy vitamin D production. Also, lymphoma can produce. Okay, in vitamin D intoxication, this levels of 125 dihydroxy vitamin D will be elevated. Primary bone disease or bone resorption happens in hyperthyroidism, immobilization, excessive intake of calcium, milk alkali syndrome, TPN. Other thing, remember hyperthyroid, pheochromocytoma can result in hyperthyroidism. And also medications, thiazides, vitamin A, anti-estrogen. So these are the etiological factors. So clinical features, what happens? Mainly neuronal issues or patients will have CNS disturbances. That is the main thing. Why is that? Alteration in the charge balance across the membrane, because the neuronal cells need sodium. Actually, the sodium channels on the neuronal membranes become more resistant to opening because of hypercalcemia. So they have to, the threshold potential goes up actually. So that is the reason why there is a new decrease in neuronal action potential, and then there is sluggish neuronal activity. So the cognitive dysfunction happens and coma. And there is also neuromuscular dysfunction. Okay, junction, there is fatigue and weakness. So calcium can precipitate along with phosphate throughout the body. So anywhere, urinary tract, resulting in renal stones, flank pain, and all that. So calcium inhibits insertion of aquaporin channels in the collective duct membrane. So there is less water that is reabsorbed, and increased, there is natriuresis, there is high volume of urine that is produced, and ultimately dehydration. So these are the effects. One is CNS effects, another stones, and third one is dehydration. So how will you manage? So management, first, get a detailed history. Okay, what is a family history, drugs, and malignancy related. Next is look into the serum parathormone levels. If the serum parathormone levels are elevated, it can be primary hyperthyroidism. If it is normal or low, then evaluate for non-parathormone related hypercalcemia. So look into uh, parathormone related peptide, 125 dihydroxy vitamin D, 25 dihydroxy vitamin D. So these three levels. If parathormone related peptide is elevated, it can be more likely due to malignancy. If it is not, then look into 125 dihydroxy vitamin D. If this is elevated, it is more likely due to some granulomatous disease or lymphoma. If not, look into your 25 hydroxy vitamin D. If this is elevated, it is more likely vitamin D intoxication. If none of the things are contributing, then look into your protein electrophoresis light chain assay. So this can point towards a myeloma, multiple myeloma. So assess for other causes of hyperthyroidism also. Okay, how will you treat hypercalcemia? If it is mild hypercalcemia less than 12, moderate 12 to 14, hydration is the key factor. Okay, avoid other factors that can aggravate hypercalcemia like thiazide diuretics, lithium, avoid volume depletion, and stop any calcium supplements. If severe hypercalcemia, if it is more than 14, then isotonic saline along with diuretics like furosemide you can initiate. So isotonic saline, how much you should give? 200 to 500 ml per hour to maintain a urine output. Target a urine output of 100 to 150 ml per hour to promote renal excretion. So the delivery of calcium to the kidneys will be increased, and it promotes calciuria. Okay, there is osmotic diuresis, and the main mechanism will be kind of treated. In volume overload states like hepatic failure, renal failure, you should be very careful while giving the fluids. Furosemide, the dose is 40 to 80 milligram IV 12th hourly to maintain the urine output of 100 to 150 ml per hour. So the rationale of giving furosemide is it does not correct hypercalcemia, and 70% saline infusion alone does not promote. Furosemide is needed for urinary excretion. So, but it is recommended especially in patients who are at a risk of developing volume overload. So the next medication what we can use is calcitonin. Calcitonin is given as a subcutaneous form, 4 milligram per kg, 12th hourly. It can be increased up to 8 units. It can be increased up to 8 units per kg every 6 to 8 hourly. Normally, we give up to 200 to 250 subcutaneously. But the problem with calcitonin is that tachyphylaxis occurs. So beyond 40 to 48 hours, the effect of calcitonin disappears. So the mechanism by which it acts is it inhibits the bone resorption, increases renal calcium excretion. Next is glucocorticoids. Hydrocortisone can be given 200 to 400 milligrams per day for next 3 to 5 days. It increases the renal excretion of calcium, decreases osteoclastic activity in the bone, and decreases renal production of calcitriol in lymphoma and myeloma. The last one is bisphosphonates, which is very useful in cancer-related hypercalcemia, malignant hypercalcemia, zoledronic acid and pamindronate. So, but the onset of action is going to be too late, 24 to 72 hours, but the duration of action will be 2 to 4 weeks. So it can be kind of given at an intermittent period. Zoledronic acid, 4 to 8 milligrams IV over 15 minutes. Pamindronate, 90 milligrams over 2 hours. So this inhibits bone resorption and interferes with the osteoclast recruitment function. Denosumab. So this is also used where bisphosphonates are contraindicated and refractory hypercalcemia is present. So the dose is 120 milligram once a week subcutaneously. So this inhibits the the receptor activation of nuclear factor kappa beta ligand. So this inhibits the bone resorption. Last option would be to proceed with dialysis. If there are severe symptoms and the concentration is very, very high, proceed with dialysis. So next, we'll be looking into hypokalemia and hyperkalemia. So it's very easy, I suppose. So hypokalemia is mainly potassium. It's a main intracellular component, mainly present 98% in the intracellular compartment. The degrees of hypokalemia, you can term it as mild, moderate, and severe. Mild is 3 to 3.5. Moderate is 2.6 to 2.9. Severe is less than 2.5. So when you're talking about the etiology, you can broadly classify into two. One is decreased intake. Second, redistribution into the cells. Third is increased loss. So decreased intake mostly due to starvation. Redistribution, when you're talking about redistribution, it can happen in various due to various reasons, mainly insulin, insulin, beta 2 activity, especially post MI patients who are receiving post MI, post TBI, alpha adrenergic antagonist, so theophylline, caffeine, metabolic alkalosis, and anabolic states wherein vitamin B12, folate administration, any GCSF administration, TPN, refeeding syndrome, and other factors would be pseudo hypokalemia. When does pseudo hypokalemia happen? Because of high WBC count, high leukocytosis or thrombocytosis also. Increased loss, either renal or non-renal. Non-renal, diarrhea, sweating. Renal, due to diuretic, salt-wasting nephropathies. Increased secretion of potassium also happens in these syndromes: Cons, Cushing's, Barter's, Gittelman's. So other causes, type 1, type 2 RTA as well. So when you're talking about the clinical manifestations, one is cardiac arrhythmias, which is very important. Next, intestinal motility, neuromuscular weakness. hypokalemic periodic paralysis can happen. Other one would be rhabdomyolysis, myopathy related rhabdomyolysis. So cardiac arrhythmias, most common is atrial. So you can find there is T wave inversion and prominent U waves. Okay, this is the most common feature. There can be atrial ventricular arrhythmias and QT prolongation. It predisposes to digoxin toxicity. So when the patient is on digoxin, you need to make sure the potassium levels are normal, because digoxin and potassium share a common binding site on the cardiac membrane, that is sodium potassium ATPase units. Okay, muscle pain, it can result in cramps, myopathy, and rhabdomyolysis. It can cause hyperpolarization of the skeletal muscles, impairing capacity to depolarize and contract, which will result in hypokalemic periodic paralysis as well. And gut, you can have gastroparesis, paralytic ileus, and pseudo obstruction as well. So how will you evaluate hypokalemia? So if the serum levels less than 3.5, first see if it's an emergency. If it's an emergency, patient is having T wave inversions, U waves, then move to therapy. Okay, and rule out pseudo hypokalemia. So if it is pseudo hypokalemia, no further workup. Then examine the patient, get a clear history. And if there is evidence of low intake, supplement. And see in for drugs or any other causes that can cause a transcellular shift. For example, any insulin infusions or TPN or whatever is going on, and treat accordingly. Next step would be look into the urine potassium. If the urine potassium is low, that means there is a extrarenal loss that is going on. Example, diarrhea, or patients with excessive sweating, cystic fibrosis or something, wherein there is a loss of burns. So loss of potassium in the extrarenal part. Urine potassium more than 30, then you look in for your TTKG. So this urine potassium multiplied by your serum osmolality divided by blood potassium, serum potassium into urine osmolality. If this TTKG is more than 4, that means renal wasting is happening. Okay, if renal wasting is increased distal potassium secretion. So this could be due to various etiology. So the etiologies being renal secreting tumor, malignant hypertension, anything that can result in acidosis. Acidosis, especially RTAs like RTA, proximal distal RTA, Gentleman, Cons, and Cushing syndrome. So these will be associated with high blood pressure, malignant hypertension, Cons, Cushing's. So these are the various syndromes that can result in high TTKG. If there is low TTKG, it means increased tubular flow and osmotic diuresis. So if the urine potassium is high, also looking for associated chloriduria. So if the urine chloride is also very high, it is mostly due to diuretic therapy or magnesium depletion. So it means you need to supplement magnesium also. So magnesium is an important factor for reabsorption of potassium. So if the urine potassium and chloride is also high, so supplement with magnesium. If the urine chloride is low, then it could be due to some other loss. So goals of therapy. So prevent arrhythmias, paralysis, rhabdomyolysis, and any respiratory weakness. Correct underlying cause. Eliminate what will be the causative or etiological factors. Mainstay. So remember, whenever there is 1 milliequivalent decrease in the serum potassium levels, the body deficit is going to be huge. The body deficit is going to be almost 200 to 400 milliequivalents. So in mild hypokalemia, what happens usually, it produces no symptoms, but you need to be very careful in patients who have heart disease, digoxin, and antiarrhythmic agents. And in cirrhosis, it can precipitate hepatic encephalopathy. So in patients with GI losses, especially associated with metabolic alkalosis and concomitant potassium chloride depletion. That means the patient is having a high RT aspirate. So that is resulting in contraction alkalosis and chloride deficient. In that scenario, go in for an IV supplement. Okay. So in diarrhea, GI intolerance, IV supplement is needed. Nasogastric or oral supplement 40 to 60 milliequivalent increases the serum levels by 1 to 1.5 milliequivalents per liter. Patients who are on diuretic, chronic diuretic therapy, or patients who have primary hyperaldosteronism, then consider ENaC blockers like amiloride, which can be given at 2.5 to 10 milligram per day, max of 40 milligram. And mineralocorticoid receptor, eplerenone and spironolactone can be considered. So moderate to severe hypokalemia, give IV potassium chloride. You can also consider potassium phosphate if associated phosphate is low. Okay. The potassium phosphate, 1 ml contains 4.4 milliequivalents of potassium and approximately 3 milliequivalents of phosphate. Okay. And how much you should give? Through a central and a peripheral line. So your dilutions, so these are your dilutions, and maximum rate of infusion through your peripheral line should be should not be more than 10, max 20 milliequivalents per hour. So 10 milliequivalents per hour is the recommended infusion rate, wherein through central line 20 milliequivalents per hour, you can go up to a maximum of 40 milliequivalents in emergencies, and never diluted in dextrose-based solutions. Next is hyper moderate to 5.5, 5.5 to 6, and more than 6. So the etiology, redistribution, again, the shift, transcellular shift, inadequate excretion by the. So when we are talking about redistribution, there can be acidosis, which can result in hyperkalemia, hyperosmolality, hyperglycemia, mannitol, beta-2 antagonist, succinylcholine, hyperkalemic periodic paralysis, cell lysis, okay, hemolysis, rhabdomyolysis, tumor lysis syndrome, and blood product transfusions. Drugs like ACE inhibitors, hyperkalemia. Clinical manifestation, you can divide it into, again, cardiac, skeletal muscle, and renal. So cardiac arrhythmias, when you are talking about the various levels, have various impact. For example, 5.5 to 6.5, up to that, there can be peak T waves. Next, it will be progressing to atrium. So there is P wave that is widening, P wave flattening, and PR prolongation, and P waves eventually disappear. So next, beyond 7, there can be bradyarrhythmias and conduction blocks of various grades. Okay. And there is QRS prolongation with bizarre QRS morphology. If it is more than 8, the patient can go into any sine wave pattern, ventricular fibrillation, asystole, or PEA, cardiac arrest. Okay, those are related to the cardiac symptoms. In skeletal muscle, there can be decreased conduction, so muscle weakness and paralysis. So in renal system, less hydrogen ions are excreted due to hyperkalemia. In the proximal tubule, it interferes with glutamate deamination. So thereby, there is decreased H plus excretion, resulting in metabolic acidosis. Thereby, the patient can have high respiratory rate. So how will you diagnose hyperkalemia? If it's more than 5.5, see if it's an emergency. Is the patient having ECG changes? Treat immediately. If it is pseudo hyperkalemia, no further action is recommended. If and careful history taking, physical examination, and other lab tests. So if there is a history of increased potassium load, if the patient is on supplement, reevaluate and stop it. If there is evidence, if some factor is causing transcellular shift, treat that appropriately. Next, look into urine electrolytes. Look into the urine sodium. If the urine sodium is less, it means there is a decreased distal sodium delivery. Okay, this is important because hyperkalemia can be due to decreased sodium delivery to the distal, distal tubules, which can cause decreased elimination of potassium. Okay, this happens because of many extrarenal causes like hypovolemia, dehydration, patients with nephrotic syndrome, cirrhosis, hypoaldosteronism. So, due to decreased sodium delivery to the distal tubule, there can be decreased potassium excretion resulting in hyperkalemia. Then look into your TTKG. Here, if the TTKG is more than 8, that means there is reduced tubular flow. And the cause is being extrarenal here. And if it is less than 5, if TTKG is less than 5, it is renal cause. So it can be acute glomerulonephritis, tubulointerstitial diseases, mineralocorticoid antagonists, or any trimethoprim or adrenal insufficiency. So that's about your diagnosis. Then management of hyperkalemia. So immediate management to prevent cardiac effects is IV calcium because it stabilizes the cardiac membrane. Okay, it increases the cardiac action potential, reduces the excitability without changing the resting membrane potential. Okay, and reversing depolarization block due to hyperkalemia. So these are the mechanisms by which IV calcium acts. So how should it be given? 10% calcium. Be very careful when you're giving IV calcium. So other mechanisms by which you can reduce potassium is by causing transcellular shift. So insulin dextrose infusion. So 25% dextrose with the 10 units of regular insulin, 100 ml. The onset of action will be 15 minutes and the duration will be almost up to 6 hours. So you need to keep on repeating until you correct the etiology. Your sugars can go up, make sure it's kind of maintained. 50% dextrose ideally not recommended because it's hyperosmolar. Next should be beta 2 agonists like salbutamol. So onset of action is 30 minutes, duration is 2 to 4 hours. Side effects being tachycardia and hyperglycemia. In cardiac patients, you need to be very careful. Next drug would be soda bicarb. Is it really recommended? Okay. So currently no role in acute treatment of hyperkalemia, but in patients with concomitant metabolic acidosis, yes, soda bicarb can be given. So 50 to 100 milliequivalents IV over IV or 150 milliequivalents, either an iso bicarb like 150 milliequivalents in 1 liter over 3 to 4 hours can be given. Okay, removal of potassium. So removal of potassium is by 3 mechanisms. One is sodium or calcium polystyrene sulfonate. So it increases the stool excretion, exchanges sodium for potassium in the GI tract. Other resins all those things 15 to 30 grams 6th hourly, onset of action being 1 to 2 hours, and peak action takes long time, like 24 hours. So avoid in patients with ileus or constipation, increased risk of intestinal necrosis. Loop diuretics, 40 milligram IV stat followed by an infusion if it is needed. Onset 5 to 10 minutes, and the duration of the duration of action will be 2 hours. It can be used in volume overload status. Okay. Hemodialysis in severe renal impairment. Okay. This is one of the method for removal of potassium. So next will be a large topic, hyponatremia. I think I'll ask Dr. Amrita to take over. So I'll be doing this in my next session. Dr. Amrita, you're here?
Yes, yes. Can you
Yeah.
hear me?
Yeah. I'm able to hear you.
Yeah, just a second. Let me. Okay. So, can you all see the screen?
Yes, ma'am.
Okay. All right. We have had an extensive discussion on ARDS. We have had nitty-gritties of all the smaller topics by Dr. Priya. We'll address now a very core topic of intensive care, which is cardiology. And I promise I'll keep the slide short and crisp. The last slide of every topic is very important. Please concentrate on that. And we'll start with the elephant in the room, which is acute myocardial infarction. Okay, this is my overview: classification, diagnosis, ECG criteria, pharmacologic therapy, reperfusion therapy, and finally the complications. So, classification. First, we need to know that it is classified based on the angiographic findings, the ECG findings, and the biomarker changes. So the angiographic findings, NSTEMI, it happens to have a partially occlusive thrombus, and STEMI happens to have a complete occlusive thrombus. ECG findings, we have ST segment depression and T-wave inversion in NSTEMI, and STEMI will have ST segment elevation. Biomarkers, troponin will be not elevated in an unstable angina, and STEMI will have a positive cardiac marker, while STEMI will also have a positive cardiac marker. Based on the third universal definition, it is divided into these 5. First is type 1 myocardial infarction, which is the spontaneous MI as a result of plaque rupture or erosion. Type 2 is because of oxygen demand mismatch, example in hypertension, or maybe because of vasospasm. Then type 3 is because of sudden cardiac death. Type 4A is percutaneous intervention. Type 4B because of stent thrombosis, and type 5 is post-CABG. Coming to the clinical presentation. So, patient present with an acute chest discomfort, which is severe, constant, retrosternal. It might spread in the back, neck, jaw, shoulders, epigastric pain. Duration is more than 20 minutes. They might also present with palpitation, syncope, sudden cardiac death, or present with a heart failure. So one should know that cardiac markers, especially the troponin, they will be raised during the first 3 to 4 hours, and then they remain elevated and finally decrease over the course of weeks. ECG criteria. ECG criteria for ST segment elevation. New ST segment elevation at the J point in at least 2 contiguous leads we will get. So based on the sex as well as the age of the patient, we have in leads V2, V3 more than equal to 2.5 millimeter in men. Less than 40 years will have, in less than 40 years, more than 2 millimeter in men more than 40 years, and more than 1.5 mm in women regardless of the age. Also, more than equal to 1 mm in all the other leads in the absence of an LVH or a LBBB. For LBBB, we'll have a Scarbosa criteria for the MI in left bundle branch block, where we have these 3 parameters. Non-ST segment elevation, new horizontal or down sloping. Just a second. Sorry. Unable to see my screen. So, Scarbosa criteria, we have these three criteria: the concordant ST segment elevation more than 1 mm in leads with a positive QRS complex. Then we have the excessively discordant ST segment elevation, and we have the ST segment depression. So, what will be the progression of the ECG changes? First is normal. Second, over the minutes, we'll have a peak T wave. And over minutes to hours, we'll have progression of ST segment elevation. In hours to days, loss of R wave with Q wave formation. Over the course of days, T wave inversion. And finally, within months, the T wave normalization with persisting Q wave. One should clearly know which lead corresponds to which area of the heart. Lead 1 AVL, V5, V6 corresponds to the lateral. Lead 2, 3 and AVF to inferior. V1 and V2 to septal, and V4 and V5 to anterior. Okay. And the 5 unrecognized ECG in ACS also one has to remember. So left main occlusion or TVD, there is ST segment elevation in AVR. LAD occlusion, ST segment elevation in AVL and V2. Upright T wave in AVL and V2. ST segment depression and inverted T waves is seen in 3 and AVF. Posterior wall MI, will have a flat ST segment depression in V1 to V3. Prominent R in V1, V2. Upright T in V1 and V3. And V8 and V9 also can be used, where we'll find ST segment elevation of more than equal to 2 mm. Wellens syndrome will find a biphasic T wave in V1 to V4, or that is type A or type 2, and deep inverted T in V1 to V4, which is type B or 1. Coming to D winters, we will find upsloping of the ST segment depression at the J point in V1 to V4 without the ST segment elevation, tall symmetric T in V1 to V4, or ST segment elevation in AVR. Echocardiographic findings are important. They will help assess for regional valve motion abnormality, any infarct size, any diagnosis and management of the infarction, and can also help with the diagnosis of complication of MI. One should remember on mention in exams regarding the risk stratification tools. Even if you don't remember the entire the classification, remember we have the GRACE risk score, the TIMI risk score for STEMI, as well as unstable angina and NSTEMI. Coming to the management part of it. So the management part consists of initial assessment, which is the history and the physical examination. If there is a suspected ACS, ECG should be received within 10 minutes. That is a class 1 recommendation, and obtain the troponin. That is also a class 1 recommendation. Then if you find a STEMI based on the ECG criteria or the elevated troponin levels, then go to the risk factors, whether it is a low risk, an intermediate risk, or a high risk. And for NSTEMI, it is the same. Pharmacotherapy, reperfusion therapy, whether PCI has to be done or fibrinolytics have to be done versus fibrinolytics, and management of complications. Now, NSTEMI and unstable angina are managed by all of the above except fibrinolytics. STEMI are managed by all of the above, including fibrinolytics. Use of fibrinolytics in STEMI should be within the first 12 hours of the onset of symptoms. Recommendation by the AHA, oxygen therapy. Oxygen therapy is not required if the patient is maintaining above 90%. Okay, this has been recommended by the AVOID trial and the D2OX and the detox and the AMI trial. Analgesic options, we have the nitrates, the morphine, and the fentanyl, which reduce the myocardial oxygen demand, the afterload reduction, coronary vasodilation. It also helps in resolution of the ischemia in coronary vasospasm. Coming to our next topic, which is very important, that is the antiplatelets. Initial loading doses of antiplatelets are recommended, especially aspirin. The daily low dose aspirin is required to reduce the death and the major adverse cardiac events. So I want you to concentrate on this table. Basically, the initial selection. How are you going to select the oral P2Y12 inhibitor? In PCI status, whether it's an NSTEMI or a STEMI, aspirin plus ticagrelor or prasugrel is recommended. It is a class 1 recommendation. Clopidogrel is used only when these two are not available. Post CABG or during CABG, aspirin plus ticagrelor or clopidogrel is the class 1 recommendation. When there is no planned procedure, ticagrelor is used. And in case of use of fibrinolytic, we go with aspirin and clopidogrel. So this is one of the most important important initial choice of the P2V12 inhibitor in patients on oral anticoagulant, not requiring the oral anticoagulant. Now, when we come to weaning from the ACS, basically patient has undergone the procedure, then what will be our strategy? The default strategy is continue the DAPT for more than equal to 12 months. Either ticagrelor or prasugrel is preferred post PCI, that is a class 1 recommendation. When we know that the bleeding risk might be high, the bleeding reduction strategies would be, there are 3 basically. So one is go for a DAPT for at least a month, discontinue aspirin for 1 to 3 months post PCI, and go with a single antiplatelet for a year, that is ticagrelor monotherapy. If the patient is on triple therapy, that is DAPT plus oral anticoagulant, discontinue the aspirin 1 to 4 weeks post PCI after the triple therapy, and then you go for a single antiplatelet with an oral anticoagulant, preferably a clopidogrel monotherapy with an oral anticoagulant, that is a class 1 recommendation. If the patient is on dual antiplatelets, then continue the dual antiplatelets, but we switch from ticagrelor or prasugrel to a clopidogrel, which is a class 2B recommendation. And finally, if there is a very high risk, then DAPT is given for a month and then stop the aspirin and continue with a single antiplatelet, maybe a P2Y12, or you can continue the aspirin monotherapy for a good 1 year. Coming to parenteral anticoagulation, which is recommended for all patients of ACS, irrespective of whatever treatment they are undergoing. And the dosing for the unfractionated heparin is 60 international unit per kg, with an initial infusion of 12 international unit per kg and then adjusted to the therapeutic APTT levels. Bivalirudin, enoxaparin, and fondaparinux, these are other anticoagulants which are used, especially when a patient has HIT, then we go for bivalirudin. Enoxaparin dose is around 1 milligram per kg subcutaneous every 12 hours. We can reduce the dose if there is a creatinine clearance of more than 30 ml per minute. High intensity statin therapy, these are very much mentioned in the recent guidelines, and they mention along with the option of a concurrent non-statin therapy like an ezetimibe. A non-statin lipid-lowering agent is recommended on patients for patients who are on maximally tolerated statin with an LDL level of more than 70 milligram per DL. It is reasonable in this high-risk population to further intensify the lipid-lowering therapy if the LDL cholesterol level is 55 to less than 70 milligram per DL and the patient is on maximally tolerated statin. What are the recommendations for RAS and beta blockers? So RAS inhibitors, the AC inhibitors and the ARB blockers, they are indicated to reduce the all-cause death and the major adverse cardiac events, especially in patients with an ejection fraction of less than equal to 40% or major risk factors like hypertension, diabetes, or STEMI with an anterior location. And for beta blocker therapy, one needs to know that early, that is less than 24 hours initiation of the oral beta blocker therapy has been recommended to reduce the risk of reinfarction and ventricular arrhythmias. Next is the reperfusion therapy. So reperfusion therapy in patients with STEMI who undergo PCI, the recommended goal, first medical contact to device time is 90 minutes for patient presenting in a PCI capable hospital, and in those presenting in a non-PCI capable facility, it can be extended up to 120 minutes. However, one needs to know that this will be based on the risk assessment of the patient. If it is an emergent PCI available within 90 minutes, yes, go for a primary PCI in case of a STEMI. And if it is not available in a non-PCI center, go for a fibrinolytic therapy. For an NSTEMI, we go for a conservative strategy versus an invasive strategy depending on the low risk versus high risk, which is given by all the risk scores that we have discussed before. Strategy of complete revascularization. This is again a recommendation in the updated AHA guidelines, where the choice of revascularization method, whether you go for a CABG versus a multivessel PCI in NSTEMI or a multivessel disease, is dependent on the complexity of the CAD. Now, PCI non-culprit stenosis in a patient with STEMI can be performed either in a single procedure or it can be performed in a staged procedure. But however, if the patient is very sick and has come with a cardiogenic shock, then emergency revascularization of the is indicated first, and then the other vessels should not be done at that time. It can be done later. Fibrinolytics, the thrombolytics, the door to needle time is around 30 minutes. Okay, and it should be done within a 12-hour window. It is done only in case of STEMI. It should not be done in case of NSTEMI. After fibrinolytics are done, reevaluate for the symptom. If the ECG settles, later on patient can go for a regular PCI. If the symptoms still persist, it is called a failed thrombolysis and the patient has to go for a rescue PCI. The drugs are altiplase, retiplase, tenecteplase, dose being of altiplase 15 milligram initial IV bolus followed by 0.5 milligram per kg body weight over the next 30 minutes. Retiplase is given each over 2 minutes and given a 30-minute apart. And then we go for tenecteplase depending on the body weight, less than 60 kg up to 90 kg. Complications of MI. Complications, we need to understand that this is very important. A lot of patients present with this and we need to divide it. Make sure to write every answer in the exam in subheadings. For example, if you're asked a complication, please write in subheadings like mechanical complication, electrical complication, inflammatory, ischemic, or embolic. Mechanical, you can find papillary muscle rupture, contained rupture, a free wall rupture, and or a ventricular septal rupture. Electrical, patient can present with arrhythmias, blocks. Inflammatory, patient can come with a pericarditis or a Dressler's syndrome. Ischemic, post-infarction angina, or embolic complications. Additional points which have been mentioned: the red blood cell transfusion to maintain a hemoglobin level is more than 10 gram per dl. Now, for an MI patient, a lot of uh, trials have been there, but we do not have a single trial which points out that the cutoff should be 7, a cutoff should be 8, or cutoff should be 10. We have the reality and the MINT trial which have given different cutoffs. So we tentatively take it as around 10 gram per dl. After discharge, it is mandatory to focus on the secondary prevention, and the fasting lipid panel is recommended 4 to 8 weeks after initiating the lipid lowering therapy. Cardiac rehabilitation referral is also recommended in the guidelines, and the option for the home-based program should be given to the patient. So this is our most important slide, which is the management guidelines 2025, and we should know the class 1 recommendations. ECG less than 10 minutes, and transport to a PCI center if not, whether fibrinolysis is required. Go for a high sensitivity troponin. We have the rule in and the rule out method. Repeat the troponin in first hour, repeat it after 1 hour. In case there is an increase, you might require to repeat it after 3 hours. Cardiac arrest transport directly to a PCI center. Medical therapy, the MONAB, which is the morphine, oxygen, the nitrates, all those things, antiplatelets are required. Parenteral anticoagulation we have discussed. Then STEMI less than 12 hours. What are the timings that we need to remember? The cath consideration, as we have discussed, ACS complications, in hospital management, and STEMI management, and finally the long-term management. So if you have to write the answer in the exam, these should be the points that should be covered. So this is your star slide for this topic. Next, we have septic cardiomyopathy. Septic cardiomyopathy, a very important topic and a very important question which you might get. The outline consists of key defining features, phenotypes, pathophysiology, clinical features, diagnosis, differentials, and finally treatment. So the key defining features are: we have a patient can come with a global myocardial dysfunction, often a biventricular dysfunction. It can be a left ventricle or a right ventricle, systolic or a diastolic dysfunction. Slight LV dilation with normal or low left ventricular filling pressures might be present. Acute and reversible. It usually occurs within 2 to 3 days of the onset of sepsis and resolves in 7 to 10 days. There is absence of ACS as an etiology. It is triggered usually by a severe infection, typically accompanied by systemic inflammation and circulatory shock. There is a blunted response to fluid resuscitation and catecholamines because there is reduced beta adrenergic receptor sensitivity, which contributes to the failure of the inotropes despite high levels of circulating catecholamines. Here I want you to concentrate on the phenotypes of the septic cardiomyopathy, which is first, resuscitated patient without myocardial dysfunction or fluid responsiveness. Patients can come with a left ventricular systolic dysfunction, hyperkinetic profile, RV failure, and persistent hypovolemia. And these are the features that patients will present with. However, we also have to remember that the prognostication of a hyperkinetic state and a persistent vasoplagia is worse than that of the other phenotypes. Pathophysiology: patient usually presents with an infection and an immune response with high circulating cytokines, increase in the reactive oxygen species, nitric oxide, and lipid mediators like prostaglandins, uh, echinocytes. Okay, and there is increased capillary permeability with increased leak, increase in the neutrophils. This will result in fibrin deposition, tissue edema, vasodilation, and there is decreased perfusion and decreased venous return. Patient also present with change in the calcium handling, increase in the oxidative stress, which results in tissue hypoxia, acidemia, mitochondrial dysfunction, apoptosis, myocardial damage, and they also have an increased troponin level. So, how will you go about it? What will be your clinical and the lab findings? A prior history of heart failure might be present, which may exacerbate in a septic cardiomyopathy. Patient might present with cool extremities depending on the phenotype. If they come with a low cardiac output state, vasopressors might not help in a refractory shock if they have a severe vasoplagia. That it also the reason why there will be preload unresponsiveness in the patient. They might come with profound systemic inflammation, that is the toxic shock syndrome or profound gram-negative septic shock. Elevated biomarkers will be present, abnormal cardiac function in terms of imaging and echo, and if need be, a cardiac MRI might help. Usually we don't go for a cardiac MRI. So the echo findings will depend on the level in which the patient has come to us with. So initially the patient presents with a warm shock, with a hyperdynamic profile, with increased cardiac output, decreased systemic vascular resistance, and increased tachycardia, basically increase in the heart rate. So this is early sepsis, and they may not show signs of a typical prototype of a septic cardiomyopathy. But later on, as it progresses, patient can develop a left ventricular systolic dysfunction, a left ventricular diastolic dysfunction, or an RV dysfunction. So based on the kind of dysfunction, patient can have a decreased cardiac output state, as we'll be seeing with the echocardiography findings. RV dysfunction, the RV LV dilation more than 0.6, TAPSE levels will be less than 16, RV fractional area less than 35%. Same with the LV diastolic dysfunction, we'll have to see the filling pressures, the E by E prime more than 13, and the E by A levels also we'll have to see, and the LV systolic function where the ejection fraction might be low, the global longitudinal strain will be low. Okay. What are the DDs of this patient? DDs is Takotsubo syndrome. Takotsubo syndrome, where the patient comes with a stress and apical hypokinesia, then the left ventricular outflow tract obstruction, pulmonary embolism, where patient might present with an RV dysfunction and an RV failure later on, infective endocarditis, arrhythmias, and acute myocardial infarction. Therapeutic intervention. So if you are supposed to write an exam, you do not have time, just go for this chart. Okay, initially sepsis, then hypertension, and finally septic cardiomyopathy, decreased LV systolic function, decreased RV function. Go for the etiological therapy, avoid aggravating factors, volume management initially, later on go for the vasopressors, norepinephrine. Okay, patient might require whatever is needed for a heart failure case, like a dobutamine, a beta blocker. All right, levosimendan, the inotropes might be required. All right, and there have been evidence of use of methylene blue in septic cardiomyopathy because elevated nitric oxide and mitochondrial dysfunction are believed to contribute to it. And later on, if the patient doesn't settle, might need a mechanical cardiovascular support. So the key points are in this slide: core-defining features, global myocardial dysfunction, bioventricle systolic or diastolic, might come with a slight LV dilation. Onset, it is reversible. Absence of ACS as an etiology triggered by sepsis. Clinical features, as we have discussed. And go, if in exam you do not have time, just present this slide and the previous slide, and that should be done. Okay. We come to our next topic, which is the role of troponin in critically ill. Okay. Role of troponin troponin is a sensitive and specific marker of myocardial ischemia. It is more sensitive and specific than other markers. And following an MI, the troponin rises within 2 to 3 hours. It peaks around 24 to 48 hours. Okay. On the third day, the value vaguely is related to the infarct size. There is slow clearance, which permits the late presentation diagnosis. Regular monitoring might also help to identify a reinfarction. Okay, and gradually over a period of 10 days to weeks, the troponin levels come down. So troponin, we need to understand that if the patient has presented with a normal troponin, then there is no myocardial injury. An elevated troponin, there might be a myocardial injury. An elevated troponin with evidence of myocardial ischemia, there could be a myocardial infarction. And there are examination. However, it can be used to monitor the myocardial ischemia, and it is also used for the late diagnosis to evaluate the infarct size, reinfarction, and prognosis. It has been studied in certain studies, and they have found it to be an independent predictor of a 30-day mortality in case of ACS, and any troponin increase over the period of days increases the risk of death. So how will we do the ischemic evaluation? If the patient has been admitted to the ICU with a non-cardiac problem, suppose the patient has been admitted, you evaluate the patient with the clinical findings, the ECG, the echo, okay? And if they have a positive finding, yes, along with a positive troponin level, we need to find out whether it is a type 1 MI or a type 2 MI. See, troponin will not differentiate between a type 1 and a type 2 MI. Okay, so this differentiation has to be based on the clinical context. And we also need to know the pathobiological mechanism of troponin release, which is for type 1 myocyte necrosis, type 2 apoptosis, type 3 myocyte turnover, type 4 release of proteolytic degradation products, type 5 increase in the cell wall permeability, type 6 formation and release of the membranous blebs. Type 1 is because of the plaque rupture, as we have studied in our ACS slides. Okay, and type 2 is maybe because of atherosclerosis, vasospasm, non-atherosclerotic coronary dissection, or the oxygen supply and the demand imbalance or the mismatch. Clinical interpretation of high sensitivity troponin. So based on the AHA and the ACC and the ESC 2023 guidelines, high sensitivity troponin is actually preferred over TROP-I and TROP-T. The term high sensitivity, what it means, it refers to any assay whose total imprecision, as defined by the coefficient of variance at the 99th percentile value, is less than equal to 10%. Now, compared with conventional, that is the first to fourth generation troponin assay, it has a higher negative predictive value, and it also results in 4% of absolute increase and 20% of relative increase in the detection of type 1 MI. There is a twofold also increased in the detection of type 2 MI. Now, issues with high sensitivity troponin is it is sex specific. Okay, it is sensitive for but not specific for myocardial infarction. That is a single positive value you should not see. We have to see serial assays. All right, it is assay specific, and we have to see the delta change in the elevation of the troponin. If the delta change, that is from one level to another level, is less than 20%, then it is a chronic myocardial injury. Unstable angina is diagnosed much less frequently with a high sensitivity troponin compared to that of type 2 event. Okay, and the rapid high sensitivity troponin algorithm can fail to present if the patient presents too early, that is less than 2 hours, or they present too late. All right, and other caveats, as we have discussed before, that it cannot undifferentiate between other causes of elevated troponin with that of MI. And antibody-based troponin assays use bioetylation, and biotin itself can interfere with the assay. So influence on the prognosis of non-cardiac patients, elevated troponin is associated with increase in the hospital and the 30-day mortality, as well as increase in the risk of long-term mortality at 6 months. In sepsis and septic shock, it increases, it may identify patients with septic cardiomyopathy. It is a predictor of increased mortality. Okay, it may be elevated in post-CABG patient and can help in us thinking whether there is any complication post CABG. So before the procedure, if the troponin is elevated, there might be an adverse prognosis. If the baseline values are low or normal, and then the patient has gone up to have a very elevated post procedural troponin, then it is associated with adverse short and long term prognosis. Okay, and it is also associated with increased risk of in-hospital major adverse cardiac events. CKD patients, these are very challenging to interpret. However, they are associated with increased short-term and long-term cardiac outcomes, irrespective of whether patient goes on dialysis or not. All right. So this is your star slide, and this is something that I want you all to remember. Etiology, but however, it has to be collated with clinical interpretation, ECG, and the serial troponin levels, which is the rule in and the rule out according to the ESC guidelines. Coming to our next topic, which is the infective endocarditis. Okay, these are our outline. So the risk factors for infective endocarditis. When we talk about risk factors, as I've said, always divide your answer in case of systematically. So risk factors, firstly, we'll start with the mouth. Any dental disease or dental procedures can cause, and the organisms involved are alpha hemolytic Streptococcus viridans, Streptococcus mutans, sanguis, oralis, milleri. Okay, and this is more common in case of developing countries. Then we have prolonged indwelling catheters, especially if the catheter is being used for a TPN or an antibiotic use. Then IV drug abusers, especially who use heroin or something else. Okay, the organism involved is Staphylococcus, rarely Candida. Gut and perineum involvement, gut and perineum underlying genitourinary disease or procedures. In fact, prolonged hospitalization stay, organism involved is enterococci. In case of bowel malignancy, they are also prone to infective endocarditis, Streptococcus bovis being the organism. Native and prosthetic valve endocarditis. This is extremely important. Early, if the patient presents early, it is associated with a poor prognosis, occurring within 60 days of the valve surgery and acquired in theater or soon after admitting in the intensive care unit. Organism being Staph aureus and Staph epidermidis. Poor outcomes with MRSA is noted. Late occurring more than 60 days after a valve surgery and presumed to have an acquired in the community. Okay, it is caused by Streptococcus viridans and Staph aureus. Soft tissue infections, especially in diabetics, IV drug abusers, and long-standing IV catheters, organism being Staphylococcus aureus. So whenever you're writing a risk factor, please make sure to write the organism involved. That will fetch you more marks. Okay, and the pathogenesis is these bacteria, they adhere to the damaged valve. There is proliferation of the bacteria, there is neutrophil and macrophage infiltrate, and finally vegetation formation. So what will be the clinical features? Most of the patients, around 95% of the patients might present with a malaise and a fever. Okay. The new onset murmur is a sensitive finding in such patients. Patients can come with a general finding, cardiac murmurs, cardiac failure, arthralgia, pyrexia, skin lesions. Okay. Osler's nodes. Now, what are the Osler's nodes? Okay. So Osler's nodes will have to know that whether they are in subungual area, you have got these nodes. All right, splinter hemorrhages, Genway lesions, non-tender macules which are present on the palm and sole. Rod spot, these are rare retinal hemorrhages which are present in the eye. Patient can present with a conjunctival splinter hemorrhage, splenomegaly, neurological findings. For example, emboli. We recently had a case, a young 15-year-old who presented with a cerebral emboli, and we were trying to find out what is the cause. Ultimately, it was found to be infective endocarditis. And hematuria can also be another cause. Coming to the modified Duke's criteria, okay? So here, most importantly, we need to note the significant changes which has happened in the 2023 guidelines. Microorganisms that are commonly isolated in the infective endocarditis from 2 or more separate blood culture sets, all right? And these are isolated from 3 or more separate blood culture sets. So these two are the microbiologic criteria with a positive lab test, which is positive PCR, and other nucleic acid based tests which are used for usually the blood culture negative organisms. Okay, immunofluorescence has also been included in the microbiologic major criteria. Echocardiographic findings and cardiac CT tomography imaging, these are added. Echocardiography was initially actually a minor criteria, but they have been added as a major criteria in the recent guidelines, and they can show vegetation, valvular leaflet perforation, aneurysm, abscess, pseudoaneurysm, fistula. All right, new cardiac valvular lesion can also be diagnosed in echocardiography, and FDG, PET, and CT imaging. This is one of the new uh, uh, criteria which has been added in the modified criteria. And surgical evidence of infective endocarditis documented by the direct inspection during heart surgery. Uh, Neither major imaging criteria or a histologic criteria or a microbiologic confirmation, but on direct inspection, if we find it during heart surgery, then it is included in the major criteria. So the definitive criteria, we have the pathological criteria, the microorganisms which are detected by the various methods that we have discussed, or presence of a vegetation or an intracardiac abscess, all right, and pathological lesions, vegetation or intracardiac abscess, which are confirmed by the histological examination. So these two are the pathologic criteria. We should have two major criteria, as we have discussed in the previous guidelines. One major criteria and three minor criteria. Minor criteria could be any predisposition to infective endocarditis, fever, temperature more than 38 degrees Celsius, any vascular phenomena, any immunologic phenomena, or a microbiologic evidence. All right, or a 5 minor criteria. So these are the clinical criteria for diagnosis of a definitive or a definite infective endocarditis. Possible infective endocarditis when there is a one major criteria and a one minor criteria, or three minor criteria, and rejected criteria when there is resolution of symptoms suggesting infective endocarditis with antibiotic therapy for more than equal to 4 days, or there is no pathological evidence on autopsy or at surgery with the antibiotic therapy for more than equal to 4 days, or none of the criteria meet a possible infective endocarditis. All right. This has to be at the tip of your tongue. Nobody can help you mug it up. Complications of infective endocarditis, we have cardiac, neurologic, renal, musculoskeletal complications, cardiac being vascular insufficiency, abscess, conduction abnormality, mycotic aneurysm, neurologic abnormality being a stroke, hemorrhage, abscess, or encephalopathy, meningoencephalitis, renal being infarction, glomerulonephritis, any interstitial nephritis from the therapy, musculoskeletal being osteomyelitis, septic arthritis, or musculoskeletal abscess. Now, evaluation. So how are we going to evaluate? Clinical signs, symptoms, microbiologic testing, and cardiac imaging, these are used for the diagnosis, as we have mentioned in the criteria. Echocardiographic findings help very much. Ideally, we go for a transthoracic echo, which are safe, quick, and non-invasive. But we might need the help of transesophageal echo because it has a higher degree of sensitivity, but it is costly and invasive. Other parameters or diagnostic modalities might be useful, especially in the patients with possible IE category. And for patients with a persistent bacteremia where no source has been identified, echocardiogram should be considered in all the patients. Here, I want you to concentrate on this part specially. Okay, so blood cultures we identify by mass spectrometry. Obviously, antibiotic resistance and agar cultures and all are done. In the agar culture, microbiology is identified, and patient might go for further investigation and antibiotic susceptibility testing. However, when it comes to a blood culture negative infective endocarditis, what are the organisms that are there? Coxiella burnetii, Bartonella, Legionella, Brucella, Mycoplasma, Aspergillus. These are the species which might come with a blood culture negative infective endocarditis. Also, patients have been treated before with antibiotics. Prior antibiotics might come with blood culture negative endocarditis. In such patients, we go for a blood PCR, okay, or specific PCR, and we might have to further test with anti-nuclear antibodies or antiphospholipid antibodies. Now, the management. Management should include the following components: prompt diagnosis and institution of effective antimicrobial therapy to reduce the risk of complications and development of indications for surgery. Management of antithrombotic therapy. It is to be noted that even if the patient goes on an antiplatelet or an anticoagulant therapy, it doesn't mean there is a reduction in the risk of thromboembolic complications in case of infective endocarditis. Assessment for the need of removal of any infected implanted devices, okay, or graft or fistula. Then indication of patients with an indication for an early valve surgery, that also has to be seen. All right. And monitoring of response to antibiotic therapy with confirmation with bacteremia. Monitoring of the hemodynamic and cardiac status of the patient, including surveillance of the ECG and evaluation for new conduction abnormalities, follow-up and prevention of recurrent and infective endocarditis, like good dental hygiene, antibiotic prophylaxis, closure of the patent ductus arteriosus or a VSD if present. Coming to the antibiotic profile, antibiotics. For different organisms, we have got the different antibiotics, and this is differentiated into whether patient has a native valve endocarditis or a prosthetic valve endocarditis. Now, for MSSC patient, we go for nafcillin, oxacillin, or cefazolin, and the duration is around 4 weeks. All right. And nafcillin, oxacillin is also recommended in case of prosthetic valve, but the duration increases to 6 weeks. Methicillin-resistant Staph aureus, cefepime plus vancomycin or daptomycin can be given. And similarly, prosthetic valve, the same drugs plus rifampicin. For native valve, we give for 4 weeks. For prosthetic valve, we give for around 6 weeks. Streptococcus viridans, ceftriaxone, duration being 4 weeks. And for prosthetic valve, it is around 6 weeks. Plus, gentamicin therapy is given. Gentamicin is given for 2 weeks in case of both of them. Okay. Then enterococcus species, ampicillin plus gentamicin or ampicillin plus ceftriaxone can be used, and same 4 weeks and 6 weeks therapy. 6 weeks and 6 weeks therapy is given. And those with resistance to penicillin, linezolid or daptomycin is used, and the duration is around 6 weeks. HESEC group of organisms, the ceftriaxone, sodium or ampicillin is used, or ciprofloxacin can be used, duration being 4 weeks for native valve and 6 weeks for a prosthetic valve. But one needs to understand that HESEC group of organisms, these are collective group of organisms which might not come in a conventional culture, and carbon dioxide based cultures might be used to diagnose these organisms. Last but not the least, we have the culture negative endocarditis, which is where we give ampicillin plus gentamicin or ciprofloxacin, and ampicillin plus gentamicin plus vancomycin plus rifampicin is used in case of prosthetic valve, which is given for a good 6 weeks. Surgery in infective endocarditis. Now we have the elective, the emergency, and the urgent indications. All right. So for emergency indications, the aortic or the mitral valve infective endocarditis with severe aortic regurgitation or valve obstruction causing pulmonary edema, aortic or mitral infective valve endocarditis with fistula with a cardiac in the cardiac chamber or pericardium causing refractory pulmonary edema. These are emergency indications. Urgent indications we have with severe acute regurgitation and persisting heart failure or ECG signs of poor hemodynamic tolerance. Electively, aortic of mitral valve infective endocarditis with severe AR but no heart failure. Okay, this is a to be recommendation. Uncontrolled infection, these are urgent indication where the patient has come with a locally uncontrolled infection or a persistent fever with positive blood culture more than 7 to 10 days, or infection caused by multi-resistant organisms or fungi. And then prevention of embolism, these are also urgent indications. All right, where the large vegetation is there more than 10 mm. Despite appropriate antibiotic treatment, then it is an urgent indication. However, if there is an isolated single vegetation of more than 15 mm, then also we go for surgery. Okay, if we have to remember it in short, go for VHUT. That is V for vegetation more than 10 mm. Vegetation is present after an embolic episode with severe valve abnormalities. H for heart failure coming with pulmonary edema or cardiogenic shock. E for extension of perivalvular lesions, that is abscess, fistula, pseudoaneurysm. AV block might be present, mostly left-sided, but aortic, it can be around 36%, mitral around 33%, resistant or difficult to treat organisms, or persistent bacteremia, which represents a treatment failure. And if patient presents with any of these, one should not delay reference to a CTVS team. So timely diagnosis of infective endocarditis is very important. It can cause organ dysfunction. Tricuspid infective endocarditis can cause septic pulmonary emboli. Mitral and aortic can embolize to various organs. And In case a patient presents with a CNS symptom, a fever, and a new heart murmur, infective endocarditis should be suspected, and one should have a low index of suspicion for such patients. Okay, so this is from where my slides have been taken. We'll go with the next topic, which is the diastolic heart failure. And here we'll go about these, that is the definition, pathophysiology, signs, symptom, differentials, approach, and treatment. So what is a diastolic heart failure? We have the entity called heart failure, and we have the entity called the diastolic heart failure. Now, diastolic heart failure is also called as heart failure with preserved ejection fraction. Diastolic heart failure was a previous term, actually. Now we call it as heart failure with preserved ejection fraction. It is a clinical syndrome in which the patients with current or prior symptoms of the heart failure with an ejection fraction, left ventricular ejection fraction of more than equal to 50%, with evidence of a cardiac dysfunction as cause of the symptoms, that is abnormal filling pressures or abnormal filling pattern might be present, but these are not attributable to any of the underlying cause like infiltrative cardiomyopathy or any kind of valvular disease, pericardial disease, or high cardiac output state. So we should have the symptoms, the signs, in the the ejection fraction of more than equal to 50%, all right, but with the cardiac marker criteria, the BNP levels of more than 35, NT-proBNP of more than equal to 135 picogram per ml. All right. This along not attributable to other causes of heart failure. Okay. And one should be really very we are diagnosing this. Pathophysiology begins with the hypertrophy of the left ventricle. There is increase in the thickness or the left ventricle mass, end diastolic volume, myomelonia normal. Because of this hypertrophy, structure Adrian Ronnie. Is more than there is elevated intracardiac, okay, especially on exertion or on exercise intolerance. When we come to the micromechanics, there is increase in aldosterone, increase in the TNF alpha, increase in the TGF beta 1, increased inflammatory state with decrease in tropic incompetence. Signs and symptoms. Signs and symptoms patient will present in 98% of the cases with fatigue, edema, orthopnea, all the other signs of heart failure patient might present with. Okay, common risk factors involve CAD, diabetes, hypertension, female sex, obesity, older age, and presence. One should rule out other causes apart from other cardiac causes like cardiomyopathy, CAD, valvular disease, pericardial disease, arrhythmias. Among pulmonary causes, obstructive lung disease, restrictive disease, pleural disease, pulmonary embolism needs to be ruled out. In fact, apart from these two, other sources like anemia, deconditioning, anxiety, and neuromuscular disease also needs to be ruled out. So these are the differentials for dyspnea for any case that patient comes with. How will you approach the patient with heart failure with preserved ejection fraction? Now, for approach, whether all of these are present, one or more of the symptoms of or signs of the heart failure will be present with ejection fraction more than 50%, and there is no apparent cause. So this is the clinical definition criteria. If this is present, what we do is we calculate the H2FPEF score. Okay, so what is the H2FPEF score? It comprises of an increased BMI more than 30 kg per meter square, which has a point of 2, or patient is on more than equal to 2 antihypertensives, point being 1, having atrial fibrillation, point being 3, pulmonary hypertension on Doppler echocardiography, 1 point, elderly age more than 60 years, 1 point, and filling pressures, which is high, that is 1 point. So if the patient fulfills more than equal to 6 points, then they are highly diagnostic of heart failure with preserved ejection fraction. Other than that, there is one more score, which is the HFA-PEFF score, which comprises of the functional, morphological, biomarker classification. Okay, no need to mug up this score, but one needs to understand that if the point is more than equal to 5 points, then the patient has probably a the probability of a heart failure with preserved ejection fraction is increased. So the following features, the clinical criteria is actually the most important criteria for the diagnosis of heart failure with preserved ejection fraction. Initial evaluation, lab testing, rule out anemia. Anemia can also be a risk factor for heart failure with preserved ejection fraction. Hyponatremia, hypochloremia are strong adverse prognostic indicators. Elevated CKD, elevated creatinine, blood urea nitrogen, CKD can negatively impact the clinical outcomes. Diabetes is an underlying risk factor. Dysregulation of the lipid metabolism is also a pathophysiology and can contribute to heart failure with preserved ejection fraction. Metabolic dysfunction associated steatotic liver disease, which is also the NASH related liver disease, has been associated with increase in the development and progression of this heart failure with preserved ejection fraction. Hypothyroid, hyperthyroid states are the risk factors. And last but not the least, BNP levels, they will be elevated. So interpretation, we have excessively discussed regarding the heart failure symptoms and signs. That is the elevated BNP levels more than 35 and NT-proBNP more than 125 picogram per ml, preserved ejection fraction. Additionally, there might be increase in the left atrial volume index, left ventricular mass index, E by E prime, that is the increase in the filling pressures, and one also has to look at the E by A. So we need to know the interpretation of this grading of the filling pressures, which is grade 0, grade 1, grade 2, and grade 3. Grade 0, that is normal, okay, where the E by A is more than equal to 0.8 and the E by E prime is less than 8. Grade 1, which is the impaired relaxation, E by A is less than 0.8, then and the E by E prime is less than 8. Grade 2, which is pseudomonormal, E by A is more than equal to 0.8 and E by E prime is between 8 to 15. And grade 3, which is restrictive, where there is increase in the E, however, much less decrease in the A, and that is E by A being more than equal to 2 and E by E prime being more than 15. And one should by now know how to perform this filling pressure when you do an echocardiography. Chest X-ray, signs of pulmonary edema may be present, or patient sometimes might even present with a normal chest X-ray. ECG is usually non-specific, but AF might be observed in 40 to 50% of the cases, and echocardiography, as we have mentioned. Treatment goal. So what is the treatment goal? Our treatment goal is to reduce the heart failure symptoms, to improve the functional status of the patient, and it also requires a lifestyle modification, exercise, diet, weight loss, and cardiac rehabilitation. Okay. And if you want to fetch more marks, please write involvement of multidisciplinary team, for example, the primary care clinician, involvement of cardiologist when the diagnosis of a heart failure is confirmed. Okay. In indication, involvement of a heart failure specialist and multidisciplinary specialist. So please produce these diagrams in exam. Okay. And appropriate ventilatory support and diuresis are the cornerstones of therapy for decompensated heart failure with preserved ejection fraction. There is no difference between bolus or continuous IV loop diuretics as given by the dose trial. Okay, loop diuretics are preferred to thiazide diuretics. However, one might add a thiazide diuretics if the patient is acutely decompensated. Coming to SGLT2 inhibitors, I believe in the previous classes you have had a detailed discussion on SGLT2 inhibitors. I'll just go in short. Initial therapy, empagliflozin and dapagliflozin 10 milligram daily is used. Based on the trials Emperor and Deliver, they have been significantly found to reduce the heart failure hospitalization and improve the composite outcome of heart failure with preserved ejection fraction. Now,
This meeting is being recorded.
this is the one slide that I would want you to produce in exams when you have a HFpEF treatment. Okay, what is this? Go for a SGLT2 inhibitor. All right. However, for individuals with fluid retention, titrate the Those with ejection fraction of less than 55 to 60%, one can add because of cost, one can go for ARBs. So SGLT2, loop diuretic, MRA, ERNI, and ARBs. These needs to be mentioned in the exams. Apart from that, also go for treatment of the comorbids. That is, atrial fibrillation has to be managed, rate versus rhythm control. Okay, whether beta blockers are required, calcium channel blockers are required, digoxin if needed, anticoagulant if not contraindicated. Hypertension, BP less than 130/80 needs to be maintained. Diuretic agents and other agents have to be used. Coronary artery disease, follow through. We have discussed in detail. Type 2 diabetes, please maintain a HbA1c level of less than 7.5. Nowadays, SGLT2 inhibitor is the first line in such cases, okay? But we can add GLP-1 uh, receptors, acting drugs, okay, if there is an obesity. Chronic kidney disease, we need to go for RAS inhibitors, and SGLT2, they may slow the progression. ERNI might be need to be added. Please manage the sleep apnea as well as obesity. So this slide is very important and it needs to be produced in the exam. Coming to additional therapy for obesity, GLP-1, that is semaglutide. There is a rage of semaglutide, that is Ozempic, that is going on right now. So where do we use this? In patients with a BMI of more than 30 kg per meter square, and if there is no contraindication to this drug, okay, apart from the SGLT2 inhibitors, this drug can be used. Okay, these are GLP-1 agonist, and they are used in the dose of 0.25 milligrams subcutaneously weekly. Okay, followed by every 4-week dose. Tirzepatide is another drug which can be used. Secondary therapies. So where do we use MRA? MRAs are used usually in patients who come with a NEHA class 2, class 3 heart failure symptoms. There we add MRAs, okay, mineral corticoid receptor antagonist, and this in TopCat trial, spironolactone was found to reduce the heart failure hospitalization. However, it was not found to reduce death in the patients of heart failure with preserved ejection fraction. Other drugs, sacubitril valsartan, that is the ERNIs, all right? We found that the Paragon HF trial has shown that when used in NEHA class 2 to class 4 heart failure patients with an ejection fraction of more than 45% and increased BNP level, there was a non-significant reduction in the heart failure hospitalization. Apart from that, the other therapies, as we have discussed, AC inhibitors or ARBs, not the first line, but may be used for hypertension in CKD, beta blockers used for hypertension, rate control in case of AF, calcium channel blockers, ineffective therapies, therapies which probably cause more harm in heart failure with preserved ejection fraction are organic nitrates, phosphodiesterase inhibitors, and digoxin. All right, so this is the star slide for you. Newer recommendations as GLT2 inhibitors, MRAs, which is a 2B recommendation, ERNIs, which is a 2B recommendation, and other drugs for atrial fibrillation, hypertension, which we have mentioned in detail. Those with an advanced heart failure who wish to prolong survival, please refer to a team specializing or multidisciplinary team management has to be done, and give options for palliative care when there is a advanced heart failure patient that has come to you. This is also involved in the patient goal care. Okay, so this is the 2023 ACC guidelines for heart failure with preserved ejection fraction if you want to go through. Coming to another major topic, which is the heart failure. This will be our flow of topics. So heart failure is a complex clinical syndrome, all right, with signs and symptoms resulting from the structural and functional impairment of ventricular filling or ejection of blood. And acute decompensated heart failure is a clinical syndrome with new or worsening signs and symptoms of the heart failure, which leads to hospitalization or emergency department visit. Okay, so coming to the classification. Classification is divided into stage A, B, C, and D. A is at risk, B is pre-heart failure, C is symptomatic, and D is the advanced heart failure. At risk patient has a risk of heart failure, okay, but without the current or previous symptoms of the heart failure, and they usually have all the risk factors which are present. Stage B is the pre-heart failure, without current or previous symptoms of the heart failure, but evidence of one of the following, that is structural heart disease, increased filling pressures, and presence of risk factors with increase in the biomarkers in the absence of a competing diagnosis. Symptomatic patients will come with current or previous symptoms and signs of the heart failure and the marked heart failure symptoms which interfere with the daily life and recurrent hospitalization with attempts to go for a goal directed therapy, medical therapy will be the advanced heart failure. So we also have the New York Heart Association classification, which categorizes symptoms and functional capacity of the patient and is divided into new onset or de novo heart failure, which is the newly diagnosed heart failure, the resolution of symptoms, which is resolution of symptoms and signs. Basically, it includes the stage C patients with the previous symptoms of heart failure or heart failure in remission. Okay, with resolution of the previous structural and functional heart disease, persistent heart failure with ongoing signs and symptoms, and worsening heart failure. It is very similar to the previous ABCD classification. Finally, we have the newer classification which has been presented, okay, which is the serial assessment and reclassification, the heart failure with reduced ejection fraction, moderately reduced ejection fraction, and reduced ejection fraction. Here, one of the classification is the pointers included is the heart failure with improved ejection fraction. So who are these patients? Basically, who had come with a previously reduced ejection fraction and now has a slightly improved ejection fraction. So these patients are called as heart failure with improved ejection fraction. And then we have less than 40%, 41 to 49%, and more than 49% involvement. Okay. So etiology and triggers. So what are the etiology and triggers of the patient? The causes being diseased myocardium, abnormal loading, okay, and arrhythmias. So such patients, they can come with all these, and a patient can come with an ischemic heart disease, toxins, immune-mediated infiltrative metabolic nutritional causes, genetic abnormalities. Abdominal loading can involve hypertension, valve problems, pericardial issues, volume overload state, high output state, arrhythmias like tachyarrhythmias and bradyarrhythmias. These can be etiology, but they can also be the triggers to cause a heart failure. Symptoms, one should know the symptoms of the right side and the left side. Patient can come with fatigue, exertional dyspnea, decreased exercise tolerance, orthopnea, PNDs, and ankle swelling. They can also come with an increased JVP, laterally displaced apex heart, bibasal crackles, third heart sound, heart murmurs, and pitting edema. So one should, what are the recommendations of the investigation that has been given by the AHA, that is the American Heart Association? BNP and NT-proBNP levels have to be done. 12-lead ECG, transthoracic echocardiography, chest radiography, and the routine blood test, that is the full blood count, urea, electrolytes, thyroid function, fasting glucose, HbA1c, lipid, iron status, including the transferrin saturation and the ferritin levels need to be done. These are all class 1 recommendations and have to be mentioned in your exams. Approach to the diagnosis of heart failure. So for the approach in the diagnosis, we have discussed the definition right and left. So that definition, if the patient fulfills that criteria, along with one of the findings. So we have the low specificity findings where the patient will come with only the signs, symptoms, and age more than 60 years. Intermediate specificity where the patient will come with these signs, symptoms like rales, cardiomegaly, pleural effusion. The ECG can show certain features like AF, pathological Q waves, LVH, okay, left atrial enlargement. BNP levels will depend on the age of the patient, that is less than 50, 50 to 75, and more than 75. NT-proBNP levels of 125 to 450, 450 to 900, and 900 to 1800. Please make sure that you see the age of the patient while seeing the NT-proBNP levels. Okay, clinical features being patient can come with a coronary artery disease or moderate valvular lesion. They can come with severe stenosis or severe valvular lesion. All right, and ECG, the echocardiography findings also have to be looked upon, where we will see the heart failure status and the ejection fraction. Goals of therapy for the heart failure with reduced ejection fraction. Now, the goals of therapy are to reduce the morbidity of the patient by reducing the symptoms, improving the health related issues, okay, improving the quality of life, the functional status, and decrease in the rate of hospitalization. These are to reduce the morbidity and also to reduce the mortality of the patient. Please produce this picture whenever you are presenting a heart failure, the 4 pillars of the heart failure. Initiate, optimize, and reassess. So what are you going to initiate? ERNIs, beta blockers, the MRAs, and the SGLT2 inhibitors. Okay, the doses are given and you can always go and read up the doses from your books. And finally, consider additional therapies. So management of heart failure with reduced ejection fraction. So Ernie, these 4 pillars, why are these called 4 pillars? Because they have been found to reduce the mortality in the patient. Okay, and they are all class 1 recommendations, which have been given in the guidelines for management of heart failure with reduced ejection fraction. And these are the trials that one should go through. Please write the trials in exams to fetch more marks. Ernie, Paradigm HF trial, SGLT2, DAPA, HF and Emperor trial. Okay. And AC inhibitors, solved and consensus trial. If you want to fetch even more marks, then you can write the outcomes of these studies as well. However, all have been found to reduce the mortality in patients of heart failure with reduced ejection fraction. So these are the class 1 indications along with the loop diuretic, which is given for fluid retention. If the patient has a less than 35% EF with a QRS of less than 130 millisecond, wherever appropriate, ICD is recommended. Okay. For non-ischemic patients, it is a class 2A recommendation. For ischemic patient, it is a class 1 recommendation. Okay. And where is the CRT recommended? CRT is recommended in case of sinus rhythm where the ejection fraction is less than 35% and the QRS is more than equal to 130 millisecond. Okay. So if it is QRS is more than 150, then it is a class 1 recommendation. Between 130 to 149, it is a class 2A recommendation. And if symptoms persist, consider therapies of the class 2 recommendation. Okay. So how are you going to manage the heart failure? We have discussed the 4 pillars which reduce the heart failure hospitalization and mortality. Go for volume reduction. CRT, we have already discussed the indications of CRD, ICDs, all right, discussed in the previous slide. Also manage the atrial fibrillation, the coronary artery disease, managed with CAVG, Ivabradine, heart failures, the sinus rhythm more than 70, Ivabradine, the funny calcium channel, this Ivabradine is also mentioned. Then we have the a special mention of black trace where the hydrolazine and nitrates are used. Ernie intolerance and AC ARBs are used, and for selected patients we have further, which we'll be discussing in the further slides. So loop diuretics, ARBs, uh, um, the funny calcium inhibitors, which is the ivabradine, which should be considered for ejection fraction less than 35% and heart rate of more than 70 beats per minute. Then we have for suppose a patient has come with a pulmonary hypertension. Okay, this might be considered where patient has a NIHA of class 2 to class 4, in spite of being treatment with other pillars of the heart failure treatment. And the hydrolazine isosorbide less than EF of less than 35% or an EF of 45% with dilated LA, digoxin, symptomatic heart failure with reduced ejection fraction. In these patients, in spite of other treatment, if it is not settling, then this can be used. Indication of ICD and CRT, as I have mentioned in the previous slides, it is used mainly as a secondary prevention. Okay, in patients with documented ventricular fibrillation or hemodynamically not tolerated patient with a VT. All right. Absence or reversible causes or within 48 hours after myocardial infarction, this can be considered. And reasonable expectation of survival with a good functional status is found for more than a year. Primary prevention is used where the NIHA grading is 2 to 4A with an impaired ejection fraction of less than equal to 35%. In spite of being on an optimal medical treatment for more than equal to 3 months. Okay. This is considered. And for ischemic patient, as discussed in the previous slide, 1A indication. For non-ischemic patient, it is a 1B indication. Indication of CRT, we have mentioned in the previous slide, so we'll not discuss it further. Pharmacology, this also we have discussed in detail in the previous slides. Coming to advanced heart failure, advanced heart failure. Okay, all of the following criteria must be present despite the optical management. What are the management? Class 3 or 4 NIHA grading with severe and persistent symptoms of the heart failure, severe cardiac dysfunction defined by at least one of the following, that is ejection fraction of less than 30%, isolated RV failure, non-operable severe valve abnormalities, non-operable congenital abnormalities, persistently high BNP levels with severe LV diastolic dysfunction or structural abnormalities, episodes of pulmonary or venous congestion requiring high-dose diuretics or vasoactive agents, and severe impairment in the exercise capacity with inability to exercise or low 6-minute walk test. In such cases, the indication is to go for mechanical circulatory support. Okay, so if it is one slide that I want you to produce in exams, it is this with the heart failure categories, the goals of therapy, the pharmacotherapy with the classification and the individual pharmacotherapy. All right, so this is what needs to be produced in the exam. Coming to the etiology and management of right heart failure, would Dr. Priya want to continue with her topic? Should we give a break to cardiology or should I continue? Hello?
Yeah, I'm okay to continue. There are a few questions actually. How do you differentiate between septic and stress cardiomyopathy?
Mm-hmm.
And another one, can you please repeat serial tropi measurement part?
Okay. Difference between the septic and as I mentioned, that the septic cardiomyopathy and stress cardiomyopathy, it will be very difficult, okay, to basically differentiate. So one has to go by the clinical judgment first of all. All right. In case of stress cardiomyopathy, one has to go by the clinical judgment whether there is any trigger for the stress. What is the trigger for the stress? Sometimes there might be overlapping symptoms also for the septic versus the Takotsubo cardiomyopathy. However, when we come to the Takotsubo cardiomyopathy, okay, patient will come with an apical hypokinesia. All right, the key difference is the apical hypokinesia or the apical ballooning. Whereas in septic cardiomyopathy, patient comes with a global LV dysfunction. All right, so the two things that one needs to understand is for septic cardiomyopathy, sepsis is the trigger. For a Takotsubo cardiomyopathy, it could be sepsis, but it could be other causes also. All right, any kind of trigger can result in a stress cardiomyopathy. All right, for example, some people call it a broken heart syndrome, right? So patient might come with a some kind of those kind of stressors as well. And the second thing would be a global hypokinesia, and for Takotsubo, it will be a apical hypokinesia. The symptoms are mostly the same in both of the patients, and both can mimic a heart attack. So it will be very difficult to differentiate, but the management will be slightly different. Okay, so the management for septic cardiomyopathy, patient will have a septic, like the history will be suggestive of sepsis. So we'll have to go by the definition of sepsis in case of a septic cardiomyopathy, and we'll be focusing on the management like antibiotic therapy. But in case of stress cardiomyopathy, we have to support the heart function, but we will also have to address by managing the stresses. So this is the first. And the second will be, I think somebody has mentioned regarding troponin, right? So troponin, high sensitivity troponin. So what there is actually a very good uh, uh, table which is given in case of um, in the ESC guidelines. Actually, I was trying. I wanted to include that in the slide, but I have not. So basically, it is the rule in and the rule out criteria. So if you all want, I can explain that towards the end of the program today. All right, the troponin levels, basically you start with 1 hour, and after 1 hour you repeat, and if it is within the slot of 2 hours and the clinical symptoms are still persisting, you repeat it again after 3 hours within a period of 6 hours. So this is the algorithm, but I think it will be better if I teach you the algorithm by showing you the slide. So I'll do it probably towards the end of my presentation after Dr. Priya has finished. Anything else?
I think those were the questions you
Yeah,
had answered
there is a very good
already.
algorithm given, which I have not included in my slides. But if once, I think when you are doing your topic, I will show that algorithm to the, after you have finished your slides, I'll show that algorithm to the students, so that that is the one algorithm that they need to know for
Sure.
troponin levels. Yeah.
That will be useful, yeah, for everybody. Okay, I'll proceed with again electrolyte imbalances.
Yes. So I'll
Thank
just
you.
stop sharing my, yeah. Okay.
So hyponatremia, this is one another important topic. So normal levels, 135 to 140 is the normal, 145 up to. Hyponatremia is defined as a serum sodium concentration that is less than 135 milliequivalents per liter. So this is a very frequent electrolyte abnormality in a hospitalized patient, and it is a very important predictor of death. Okay, and that is very important. So severity, we can divide it into mild, moderate, and severe. Mild is when the sodium levels are between 125 to 134. Moderate, 120 to 124. Severe, less than 120. But it is not the numerical values that we are looking at when we are defining hyponatremia. It is very important in terms of the symptoms the patient is presenting with, especially the neurological symptoms. Mild when the patient has mild headache, nausea, vomiting, some kind of confusional status. Severe when the patient has delirium, significant delirium, restless seizures. Okay, the patient can go into brainstem function, respiratory arrest, coma, and death. So that is about the severity. In terms of duration, can divide it into acute, less than 48 hours, of principal cation in the extracellular fluid. Looking into the water compartment, so 40 liters, that is 60% of the body weight, the total body water volume. So 40 liters, 25, almost 25 liters are present in the intracellular. In interstitial, approximately 12, and the plasma volume is just 3 liter, that is 20% of the extracellular fluid volume. And the total body sodium is going to be almost 50 milliequivalents per kg, 95% of which is present in the extracellular fluid, and only 15% is going to be distributed in the intracellular space. So, what are the main functions balance, nerve conduction, and remember the most osmotic sensitive organ is the brain. And sodium is an important component which contributes to the osmolality of blood. So classification, you can divide based on the levels, based on symptoms as moderately severe, mild, and severe. Time, acute and chronic. Based on osmolality, you can the normal osmolality is 250 to 295, wherein hypotonic, isotonic, or hypertonic. Based on the volume status, you can divide it into hypovolemic, hypervolemic, or euvolemic hyponatremia. A small word on the regulation of sodium. So when there is a volume deficit or when there is hyponatremia, the osmolality of the blood changes. So what contributes to the osmolarity? So we all know the formula for osmolarity is 2 times sodium plus blood glucose divided by 18 plus 1 divided by 2.8. So the normal osmolality is 280 to 294. So this is contributed majority by the sodium, okay, because it is 2 times the serum sodium. So as the osmolarity of the blood changes, and also if there is a change in the volume, that is hypovolemia or hypotension, the hemodynamic status of the patient changes, the baroreceptors which are present in the aortic and the carotid bodies get stimulated, as well as the osmoreceptors which are present in the hypothalamus respond. Okay, the hypothalamus responds in the form of thirst, increasing the thirst and thereby increasing the water consumption. Other thing would be it will increase the production of ADP or arginine vasopressin, okay, or antidiuretic hormone, which is released from the posterior pituitary. So the action of this antidiuretic hormone would be on the kidneys. It mainly acts on the collecting duct. Okay, it causes water retention. So the other systems that will be activated or response to the low volume status would be the RAS and the sympathetic nervous system. So all these two systems help in conserving the water as well as increasing the sodium levels. Okay, so this is the main regulation of the sodium. So the three things that are involved is the arginine vasopressin or the antidiuretic hormone, the renin-angiotensin-aldosterone system, and the sympathetic nervous system. So whenever we are talking about the serum sodium level, always it depends on not only the absolute content of the sodium in the body, it also depends on the relative status of the total body water. Okay, it depends both on the sodium as well as the water. So dysnatremias are related to water intake. Okay, if it is hyponatremia, it could be due to water intake which exceeds the renal diluting capacity, whereas hypernatremia, inadequate water intake coupled with renal concentrating defects. So these are the reasons for dysnatremia. So when we are talking about hyponatremia, we can broadly classify based on the tonicity to hypotonic, isotonic, and from intracellular space to the extracellular space, thereby falsely resulting in a low sodium level. So what is pseudo-hyponatremia? Pseudo-hyponatremia is due to there are certain lab measurements which is artificially low because of the presence of certain molecules like paraproteinemias, high lipid triglyceridemias and all that. So what happens is that it measures the value in a wrong manner. So artificially low sodium values due to indirect ion selective electrodes. So if you're going to do it by a direct ion selective electrodes, the real value of the sodium will be known. So this is known as pseudo hyponatremia, and true hyponatremia is hypotonic hyponatremia. So here you can divide it into euvolemic, hypervolemic, and hypovolemic. So when you're talking about hypovolemic, the actual body content of the water is also reduced and the sodium content is also reduced. Hypervolemic, the body content of the water is increased and sodium may be maintained or low. Okay, euvolemic hyponatremia, the body water content is normal, whereas the sodium content is low. So when going into the causes of hyponatremia, so normal, low, and high osmolality. So normal is isotonic hyponatremia that we talked about, the translocational hyponatremias, that is paraproteinemia, hyperlipidemia like chylomicrons, triglycerides, and rarely cholesterol can cause. So high osmolality due to hypertonic hyponatremia. This happens due to hyperglycemia, mannitol, sorbitol, glycerol, maltose, okay, and some radio contrast agents also. Hypotonic, depending on the volume status, we can determine. So hypovolemic, wherein Hypovolemic, here you look into the serum sodium levels. So if the urine sodium levels, if the urine sodium is less than 10, it means the patient is having an extrarenal salt loss, that is dehydration, diarrhea, or vomiting. If the urine sodium is more than 20, it means the kidney is excreting more salt, maybe due to diuretics, ACE inhibitors, nephropathies, mineralocorticoid deficiency, cerebral salt wasting syndrome. Euvolemic, when there is SIADH, postoperative hyponatremia, generally hypothyroidism, SIADH, and adrenocorticotropin deficiency. So these are the causes mainly. Beer, protomania, and all these are the causes for euvolemic hyponatremia. So in hypervolemic, there are three main causes: congestive cardiac failure, liver disease, nephrotic syndrome, and sometimes in advanced renal failure. So based on the first, when you're evaluating a patient with hyponatremia, always assess the volume status. So in the absence of pseudo hyponatremia, you see you first rule out pseudo hyponatremia and translocational hyponatremia. Then you assess for the extra volume status of the patient. Look for signs of dehydration, either or is there is pedal edema, a JVP that is elevated, IVC that is collapsing, or if it's non-collapsing, tachycardia, dry mucous membrane. So all these denote either the patient. By assessing all these variables, you can know whether the patient is hypovolemic or hypervolemic. Okay. So the next step in hypotonic hyponatremia will be you should look at the urine osmolality. So if the urine osmolality is less than 100, it can be due to a high volume intake. Okay, so there is a dilute urine that's passing on. So it could be due to primary polydipsia, low solute intake, or beer protomania. If the urine osmolality is more than 100, it could be due to either it could be due to mainly many of these factors, like urine sodium. Next step would be to check the urine sodium. So urine spot sodium more than 30, less than 30. Less than 30, it could be due to extrarenal losses like diarrhea, vomiting, third space, and other and remote use of diuretics. And other causes would be heart failure, liver failure, nephrotic syndrome. If the urine sodium concentration is more than 30, it means diuretics or renal failure, which could be the main cause. If there is no diuretic use, it could be due to cerebral salt wasting, SIADH, or primary adrenal insufficiency. It could be due to hypothyroidism, okay, or secondary adrenal insufficiency. So that is how you proceed with your diagnosis of the etiology of hyponatremia. So next, specific criteria for SIADH. This is the Barter and Schwartz criteria for SIADH, wherein you have the serum osmolality. It is hypotonic, the osmolality is less than 275, and there is clinical euvolemia, okay? And the urine and the impaired urine dilution. So that is, urine osmolality is more than 1000 milliosmoles per kg. Urine spot sodium will be more than 30 in the absence of any other diseases like advanced kidney disease, cirrhosis, or heart failure. Absence of any alternate causes like hypothyroidism, glucocorticoid deficiency. So rule out other causes. Serum sodium is low, euvolemia, urine osmolality is high, and then urine sodium is high. So these are the major criteria. So additional criteria, your serum uric acid can be low, your fractional excretion of uric acid can be more than 10%. There is vasopressin or copeptin that can be elevated, and if you're going to give saline to this patient, there will be worsening of normal saline, can worsen hyponatremia. An abnormal response to volume water loading. So this is the diagnostic criteria. What are the causes of SIADH? Okay, multiple causes are there, starting from infective, respiratory, medications, malignancy, and neurosurgical etiology. The neurosurgical etiology, we know any patient who has had a subarachnoid subdural hemorrhage, GBS, meningitis, encephalitis, okay, HIV, sarcoidosis, tuberculosis by itself can cause SIADH, or any pneumonia can cause. Drugs, most of the anticonvulsants, carbamazepine, levetiracetam, try antidepressants like sertraline, antipsychotics, okay, cyclophosphamide, some chemo drugs. And ectopic ADH production can be due to all these tumors like nasopharyngeal, mesothelial carcinoma, lymphoma, okay, and non-ADH diuretic peptide release in prolactinomas. So these are the various causes. When we are going ahead with the management of euvolemic hyponatremia, that is confirm the diagnosis by, we saw the criteria already. Then how do you manage symptomatic, asymptomatic? If the patient is asymptomatic, proceed with fluid restriction. Symptomatic patient, if it is acute symptoms less than 48 hours, severe symptoms, give 3% bolus, and then look for improvement in the neurological status. If it's more than 48 hours, still severe neurological symptoms, administered 3%. If there are minor symptoms, just proceed with fluid restriction. So what about cerebral salt wasting? This is also one of the complications of neurosurgery or some bleeding, SAH related. So what happens is that there is non-osmotic release of ADH and ANP. There can be this ANP and BNP that is elevated. So what happens after a neurological event? There is increased natriuresis and diuresis resulting in hypovolemia that actually stimulates ADH, and ADH results in water absorption. Thereby, there can be a clinical volume deficit plus a sodium that is low. Okay. So, and there is a loss of sympathetic tone also in the juxtaglomerular apparatus. So, the patients with cerebral salt wasting classically present with a high volume urine. Actually, the urine output is very much elevated. When you look into the investigations, the serum sodium will be low serum osmolality, okay, and the urine spot sodium is going to be more than 40. Okay, it will be even in hundreds in patients with cerebral salt wasting. Because of high sodium as well as water loss, your urine osmolality will be high, more than 100. Okay, so that is about cerebral salt wasting. How can you differentiate between SIADH and cerebral salt wasting? The main clinical difference that you can appreciate between SIADH and cerebral salt wasting is that patient will be hypovolemic, whereas in SIADH, patients will be euvolemic. Okay, the urine output will be very, very high. So if you measure the CVP in these patients with cerebral salt wasting, it will be very, very low. That is the major difference between SIADH and cerebral salt wasting. Rest of the other parameters, serum sodium will be low, urine sodium will be very, very high in cerebral salt wasting, osmolality will be high, volume, yes, definitely in cerebral salt wasting, urate will be normal or it can be low also. So other features may not be differentiated. So why is hyponatremia important? Okay, we already saw brain is the osmotically very sensitive organ. So what happens when the sodium level drops? So when the sodium level drops, the osmolality in blood comes down. So the brain tries to adapt. Okay, there is low osmolality in the blood, in the brain, which is happening. So what happens? There is a period of rapid adaptation which happens in the initial 6 to 12 hours. So because of low sodium, there is expulsion of potassium as well as chloride also, and some electrolytes out of the brain, so that it tries to match actually loss of sodium, potassium and chloride. So it tries to match resulting in a low osmolarity. So this happens in a initial 6 to 12 hour period, which is ionic loss. The next period in the 24 to 48 hours, there is a period of slow adaptation, loss of organic osmolytes, that is glutamine, taurine, that is most of the amino acids and the polyols, myoinositol, all those things reduces intracellular osmolality and allows water to leave the cells. So if these are there, this will be osmotically more osmotic. So what happens is that water will diffuse from blood into brain, that will result in cerebral edema. So it's a compensatory or adaptive mechanism. Thereby it loses almost all of these amino acids to prevent edema. So this slow adaptation takes place over a period of 24 to 48 hours. So if, meanwhile, if you're correcting sodium, if you rapidly correct, what happens is that osmotic demyelination can happen. If you appropriately correct, there will be no cerebral edema that is developing. So the most important thing regarding hyponatremia that you're worried about is cerebral edema, and the complication of rapid correction will be osmotic demyelination. And that is why you classify the 48-hour time period into acute and chronic. So management of hyponatremia based on the symptoms you'll have to treat. Okay, if the patient has severe symptoms, moderately severe symptoms, what you have to do? Then again, without moderate or severe symptoms, then in chronic hyponatremia, how you can treat? Chronic hyponatremia with expanded extracellular fluid, that is hypervolemic, euvolemic, reduced volume, circulatory volume. So we'll see in all these categories. So we'll look into what are the different guidelines, what is the recommendations. Okay, when we are looking into severe in the sense, I'm not mentioning the numerical value, it is the symptoms: seizures, coma, risk of brainstem herniation. So severe, according to the European guidelines, they recommend 150 milligram of 3% saline bolus and repeat sodium within 20 minutes. Okay, when you give a bolus after 20 minutes, over 20 minutes, and check the serum sodium after 20 minutes, and you target and you look in for two things. One is you look into the neurological status, whether the patient's sensorium has improved or not. Next is you look into the serum sodium. If the sodium has improved to more than 5 millimoles per liter. So that is one aspect you're looking. So if there's no improvement, or if your target of 5 is not reached, again, you can give a bolus. So maximum you can give twice. Okay, this is as per the European. Whereas as per the American guidelines, they suggest 100 ml over 10 minutes thrice. Okay, in case of moderately severe, you can give 150 milligram over 20 minutes once. In American guidelines, moderately severe, 3% infusion can be given at a rate of 0.5 to 2 ml per kg per hour. So that's the recommendation for severe symptomatic hyponatremia. So next, the correction rates, okay, over the next 24 hours, what should you aim at? Okay, in European, the correction rates for severe, it's not been mentioned. Limit of 10 in a day is what is recommended. As per American, it's 8 to 6. In patients with high risk of osmotic demyelination. So there are a certain category of patients who are at high risk of osmotic demyelination that we look into it in the next few slides. So in the patients, high risk patients, 6 will be your target. Other patients, 8. Moderately severe, 10 to 12. Okay, 8 in patients with osmotic demyelination risk. Okay, the goals of correction would be to prevent cerebral edema, prevent brain herniation, and prevent further severe symptoms. So if the symptoms have improved and you have reached a certain amount target, then you stop 3%, measure your sodium 6th or 12th hourly daily. If the symptoms not improved, you need to continue an infusion and then look in for your aim for increasing at least 0.5 to 1 millimole per liter per hour, and then check for the serum sodium levels. So there's a formula to calculate the deficit, and you can actually titrate the rate of your infusion as well. So the sodium deficit is the difference between your desired and the actual sodium. So, and then you multiply it by 0.6 into total body, that is weight. This will be your total body. 0.6 into body weight will be your body water, and your actual desired sodium and actual sodium levels. So this will be a total sodium deficit in the body. And 1 liter of 3% contains how much? 530 milliequivalents. So you can calculate how much is the desired volume of 3% that you need to give, and the rate of correction if you're targeting 10 milliequivalents per day, and how much rate you should give it, so that you can decide based on this formula and the content in the fluid as well as your duration of correction. So next will be another formula. So the sodium infusate minus the serum sodium and the total body water plus 1. So if you're going to give 1 liter, so how much change in the serum sodium you can expect? So 513 milliequivalents in the infused set, and serum sodium, for example, if it's 120, and 42 will be your total body water plus 1. So somewhere around 390 divided by 43. So you can get a serum change almost kind of 10. 390 by 42, almost like 9 to 10 milliequivalents. So that will be your serum change in sodium if you are going to give 1 liter of 3%. So how much duration you want to give this 1 liter to attain 10 milliequivalents, that you will have to calculate. So any patient with acute without severe or moderately severe symptoms. So what will be your target? So you can give a 3% to get this is as per the European guidelines. Okay, so you can target a 10 milliequivalent correction. There's no target limit, but you can give a bolus to improve the symptoms if there are mild symptoms also. But as such, there are no recommendations for this. In chronic hyponatremia, as per European guidelines, so chronic you divide it into 3 categories. One is hypovolemic, euvolemic, that is SIADH, and hypervolemic. So SIADH, just fluid restriction is recommended. Solute intake, that is urea, no lithium or demiclocycline, Vaptans against, okay, if the sodium is less than 125 and less than 130, does not recommend. In American guidelines, if you see for SIADH, that is euvolemic hyponatremia, Vaptans and demiclocycline along with fluid restriction. So this is recommended. Hypovolemic, normal saline or balanced salt solution as per European, American, normal saline. So hyponatremia with hyperolemia, fluid restriction, American guidelines, Vaptans. A small note on osmotic demyelination syndrome. So this is because of rapid correction of sodium. It can be central pontine myelinosis or extrapontine myelinosis. So extrapontine myelinosis can happen in thalamus, cerebral white matter, basal ganglia, and hippocampus. So the risk factors, so malnourished patient, alcoholism, hypokalemia, advanced liver disease, and chronic hyponatremia. So these are the risk factors for osmotic demyelination. So it can happen not immediately, 3 to 10 days after treatment also. So the main symptoms or the difference between central and extrapontine. In pontine myelinosis, the patient can be in locked-in syndrome, paresis, dysarthria, dysphagia. Okay, the patient cannot talk and will be kind of quadriplegic. So there is paresis, locked-in syndrome. The patient's sensorium can become low, loss of reflexes, pupillary, ocular, and motility disorders can be there. So this is about central pontine. Extrapontine myelinosis, there will be movement disorders, there can be neurobehavioral and general symptoms also. So movement disorders, there will be tremors, dystonia, chorea, athetosis, myoclonus, opsoclonus, gait disturbances, akinetic, rigid symptoms. Okay. And ataxia can be there. Behavioral, the patient can become just mute. Okay. Mutism, catatonia, depression, and epileptic seizures can also be there. There can be frontal lobe disinhibition, emotional instability, dementia, and primitive reflexes. So this is about osmotic demyelination. So there have been questions on vaptins also. So we'll be covering that. So AVP, so arginine vasopressin, the receptors V1A, B, and 2. V1A is in smooth muscles of blood, vasoconstrictive action. V1B, anterior pituitary, regulate ACTH secretion. V2, collecting ducts, cells. So it acts as antidiuretic effects. So this is secreted from the pituitary. So in response to osmolality and intravascular volume, that is low intravascular volume. So these are the primary stimulants. It acts on V1A, increasing the vascular tone. V2, regulate resorption of water from the collecting ducts. So what are the vaptins that are available? So the vaptins cause free water excretion. These are V1A, vasoconstriction, reclovaptin, V1B, nelivaptin, V2 is tolvaptan, satavaptan, moxavaptan, lixi. So these cause free water excretion. So when we are looking into the use in terms of hyponatremia, we are talking about tolvaptan and conivaptan. So tolvaptan is usually oral route, whereas conivaptan is both oral as well as IV. So the half-life is 12 hours, can be used in euvolemic or hypervolemic hyponatremia. Conivaptan, euvolemic or hypovolemic, and it can be used for a maximum of only 4 days. And do not contraindication is when the serum creatinine is more than 2.5, advised not to use it. When you're using tolvaptan, always make sure you monitor the liver function test. Okay. So we looked at the indication and mechanism of action. So it inhibits the ADH, that is V2 receptor, which act on the V2 receptors. Normal action of ADH is that antidiuretic hormone. It acts on the aquaporin 2 channels in the luminal surface, and thereby in the luminal surface it causes more absorption, the cyclic AMP pathway, more absorption of water, prevent diuresis. So it blocks ADH acting on the V2 receptors, and the aquaporin translocating or into the apical membrane. So it blocks this aquaporin too also. So water absorption does not happen. So there is more free water excretion. So that is the action of vaptins as such. So the next topic will be hypomagnesemia. So the normal magnesium level is 1.4 to 2.6 milligram per deciliter. Most of the magnesium is present in the bone, 60%, and 40% in the soft tissue. Usually, we will not get any symptoms unless the magnesium level is less than 1 milliequivalent per liter. Functions, when we are looking into the functions, it is an important intracellular cation, a cofactor in many biochemical reaction, a cofactor in many enzymatic reactions, and then platelet function, clotting and thrombus formation, maintenance of vascular tone, muscle contraction and relaxation, insulin regulation, neurotransmission, cardiac conduction. So these are the main functions of sodium. So etiology of hypomagnesemia. It can be due to decreased intake, redistribution, gastrointestinal or renal losses. So decreased intake can happen due to starvation, alcohol use disorder, anorexia, a terminally ill cancer patient or critically ill patient who is on total parenteral nutrition. Redistribution happens due to insulin, okay? Anabolic effects of insulin, refeeding syndrome, acute pancreatitis, ethanol withdrawal syndrome. Okay, gastrointestinal or renal diarrhea due to acute tubular necrosis, any diuretics. So normally we don't measure the ionized calcium level, but you can calculate just like the entire thing in terms of percentage. If this percentage okay, the drugs which can cause hypomagnesemia include proton pump inhibitors. You know that amphotericin B causes hypokalemia, also hypomagnesemia. Pentamidine, proton pump inhibitors, loop and thiazide diuretics, digitalis, any chemotherapeutic drugs like cisplatin, cyclophosphamide, antibodies to EGF receptor blockers, okay, laxatives. So all those things. Clinical features of hypomania. So mainly cardiac, neurological, and then biochemical abnormalities. So cardiac wise, what you can see is interval, prolonged QT interval, widening of QRS complexes. There can be atrial fibrillary cardia. More important would be Taussig's D points. Okay, high magnesium, hypomagnesemia, magnesium also. On the facial nerve causes twitching of the facial muscle, that is chaustic. Trousers is carpopedal spasm due to an inflated BP cuff. Other signs would be confusion, tremors, seizures. Okay, associated abnormalities will be hypocalcemia, hypokalemia, and hypoparathyroidism. These can be always associated with hypomagnesemia. Why is that? Parathormone release is regulated by low magnesium. So low magnesium impairs the release of parathormone. So thereby the patient hypocalcemia. And into increased potassium excretion. So thereby hypokalemia. So in the kidneys, it causes hypokalemia. Hypoparathyroidism can also occur because of impaired release of parathormone. So these are the other electrolyte abnormalities. When you're evaluating, check in for other electrolyte levels as well. ECG to look in for arrhythmias. Fractional excretion of magnesium more than 2 denotes renal losses. It will help to distinguish between GI and renal losses. Genetic testing in terms of you're suspecting any other syndrome, genetic testing is advised. Treatment of hypomagnesemia. For acute symptomatic severe hypomagnesemia, unstable patients, 1 to 2 gram of IV magnesium sulfate over 15 minutes can be given. In unstable patients, I think you can supplement followed by that. Okay, the elemental, so 1 gram contains 96 milligrams of elemental magnesium sulfate, which is equal elemental magnesium that is equal to 8 milliequivalents. So 6 gram in 1 liter over 24 hours can be given, okay, in terms of severe symptoms. But when you're giving this, always monitor the deep tendon reflexes. Non-emergent, you can give 4 to 8 grams over a period of 24 hours. Okay. In terms of oral supplementation, you have medications that contain 64 to 71 milligrams of magnesium. A maximum elemental dose can be 240 in divided doses per day, up to a max of 720 per day in divided doses. Okay. When you are replenishing the magnesium levels, it should be done over a period of time, 2 days. Okay, usually it takes some time to replenish, especially when you're giving the oral formulations. And make sure if there is a renal dysfunction, you reduce the dose of magnesium supplementation. If the patient is on potassium-sparing diuretics, so in case if the patient is severely hypomagnesiamic, you can also consider amiloride or triantin. So the next topic we'll be seeing, we'll start with the miscellaneous topics. I'll be covering 2 topics now. The ROSE protocol for deresuscitation. So what is fluid overload, first of all, and what is deresuscitation? Fluid overload is nothing but the percentage of fluid accumulation that can be defined by dividing the cumulative fluid balance in liters by the patient's body weight. So cumulative fluid balance divided by the patient's body weight multiplied by 100. So that gives the percentage. More than 10% is defined as fluid overload. Okay. Deresuscitation is defined as active fluid removal in patients with fluid overload using drugs or any other methods like ultrafiltration. So what should be a target? A goal of 0 to negative fluid balance by day 3 to keep a cumulative fluid balance on day 7. Okay, so you should start 0 balance by day 3 to attain a negative balance by day 7. So what are the trials actually which support deresuscitation? So we know that fluid overload increases mortality. This is as per the SOAP trial. And the FACT trial mentioned there is a prolonged recovery in patients with ARDS and ALI. And if they can attain a negative fluid balance, it improves the mechanical ventilatory days. So that is as per the FACT trial. The vast trial mentioned worse mortality in septic shock patients. Okay, and this article by Dr. Malbrain, 2014, mentioned that there is an increased risk of IAP in the patients who have a volume overload. So what are the signs of volume overload that you can look into? Every organ by organ, skin turgor, pitting edema, and then your capillary refill time again will go up. So your CVP will go up. The patient will become encephalopathic, absence of thirst. In fact, your blood pressures will be on the higher side. CVP will be high. Gastroparesis, renal blood flow will be decreased. There can be congestive nephropathy resulting in AKI. Okay, and pitting pedal edema, and you're looking at the splanchnic, the circulation will be affected, decreased blood flow to your splanchnic vessel, celiac and SMA. Congestive hepatopathy, there can be Rales orthopnea. So patient can have pleural effusions. There can be metabolic disturbances and NSACA. So every organ by organ, you'll have to describe. So coming from renal, your perfusion pressure will go up. Interstitial pressure will, your venous pressure will go up. Interstitial pressure goes up. Blood flow decreases. Your GFR decreases. Hepatic congestion, cholestasis can happen. Hepatic compartment syndrome. GI, there is ascites, increase IAP, abdominal compartment syndrome. Your perfusion pressure will come down. Increase bacterial translocation, and microcirculatory flow will also come down. Cardiovascular, myocardial edema, conduction disturbances, diastolic dysfunction, as your your myocardial depression can be there, pericardial effusion, your global end diastolic volume. So all these things can go up. Respiratory wise, the compliance of the chest wall can decrease because of the increase in intra-abdominal pressure. There can be pulmonary edema, pleural effusions. Your lung volumes can go down. There can be increased work of breathing. Central nervous system, cerebral edema, impaired cognition, delirium, increased ICP, decreased perfusion pressure, increased intraocular pressure, intracranial hypertension. So all these features in the CNS, abdominal wall, tissue edema, poor healing, wound infection, pressure ulcers, and decreased compliance. So clinical signs we saw lab parameters, mostly hemodilution related, radiological signs, so X-ray effusions, B lines on ultrasound, and VEXs. High-grade VEXs is something that you need to look in for. Okay, assessment of the pulmonary function, your perfusion pressures and your pulse pressure variation, everything will be on the higher side. So this is a very important slide. It has a lot of details in it. So we'll go one by one. So what is the ROSE protocol? R stands for resuscitation phase. The initial few minutes of shock, okay, that is a phase wherein you focus on resuscitating the patient, the early adequate fluid management, or this is the early adequate fluid resuscitation. So this phase, we give volume to the patient. Start at 20 to 30 ml per kg in an hour, followed by boluses depending on many variables. Okay, what are the triggers that you're looking for? Patient will be frankly in shock, mean arterial pressure less than 65, global end diastolic volume index less than 640, CVP less than 8, PAOP less than 10, cardiac index less than 2.5, pulse pressure, systolic pressure variation, stroke volume variation more than 12 to 15, PLR positive, lactate more than 3. Okay, all these things denote hypovolemia, and you start with early adequate fluid resuscitation, that is first few minutes, and that is considered as the first insult or the initial insult. Okay, in the period of shock. Next phase, that is in the next hours. This is minutes. Next hours is a period of optimization. From hours, it goes to days. So this optimization phase focuses on organ rescue and maintenance, avoiding fluid overload. That is, you avoid fluid creep, aiming for a neutral balance. So here you're trying not to over resuscitate and just optimize your organ function. Here, stop if the patient is unresponsive. If the lactate normalized, PLR negative, if your MAP is a 10, so then your targets are almost achieved. So you stopped over resuscitating. Don't always be mindful of fluid creep, and aim for maintaining a neutral balance. So this phase is known as late conservative fluid management. Okay, and this is a phase wherein the period of days to hours wherein ischemic reperfusion injury can happen. That is the second hit. Okay, the next phase followed by days later, wherein you enter after a period of stabilization from days to week. So this period is stabilization. You focus on organ support and hemostasis. Okay, you maintain late conservative fluid management. Okay, stabilization. So this phase, late conservative fluid management and organ support, defined by 2 consecutive negative fluid balance within the first week. So as your first week ends, you target, so day 3 0 balance, day 7 target negative balance. Okay, and then evacuation is after your stabilization phase. So that is when you aim for late goal directed fluid removal. So this late goal directed fluid removal is your deresuscitation phase, wherein you focus on organ recovery, resolving fluid overload with active goal directed removal of fluid with negative fluid balance. So when you have kind of attend your targets and your values go up, triggers of fluid removal start when there is a high global end diastolic volume more than 850, your PLR is negative, and then you look into your intra-abdominal pressure, your high Vexus score. So these are the parameters wherein you look in for, and then you start doing a active fluid removal. And the last phase is when to stop removal. So stop removal, again, the patient's lactate can go up, PLR can become positive, PPV and SVV can again become positive more than 15, and the patient can have a low map. So this is when you have to stop fluid removal. So these are the things you need to remember. First is resuscitation, optimization, stabilization, evacuation, early adequate fluid resuscitation, late conservative fluid management, late goal-directed fluid removal. First hit is the initial insult, second hit is the ischemia reperfusion, third hit is the global increased permeability syndrome, fourth wherein you need to stop de-resuscitation is when there is a risk of hyperperfusion. So this first few days is known as the ebb phase. From days to the time of recovery, that is known as the flow phase. So this is your ROSE protocol for de-resuscitation. You can mention the when do you have to consider fluid removal. So Vexus, you can also mention Vexus in that, wherein you're looking for your IVC, then hepatic vein, portal vein, and renal vein Doppler. Okay, the hepatic vein reversal and the pulsatility in the portal vein, as well as the renal vein Doppler. So when your grades are high, then you think of fluid removal. So these are one of the criteria. Also, there has been questions on the 4Ds: drug dosing, duration, and de-escalation. Okay, it's not only for antibiotics, but also for fluid therapy. So what fluid to use? So saline versus balanced crystalloids. So you think of hyperchloremic metabolic acidosis with normal saline, appropriate therapy. So when do you start resuscitation? When do you stop? Combination of different agents, okay? Appropriate timing. So when you have to give and when you have to stop. So these are the various things that you can mention. Dosing. So how much you have to give based on your fluid responsiveness and tolerance, and what fluid you're going to give, like how much percentage of intravascular compartment that will be replenished, crystalloids versus colloids, pharmacodynamics you need to mention, and then toxicity. In case of colloids, we avoid HES because of renal injury. So duration, how long you want to give until the patient is responding and responding to fluids, and no signs of volume overload or not tolerating fluids. So that is when you stop. So other things is when your parameters are achieved, your goals of resuscitation are achieved. When do you start de-escalation? We saw, okay, resuscitation, de-escalation. So that is about the 4Ds also. You can write it up. So how do you actively do the de-resuscitation? So actively by starting diuretics. One is restriction of fluid intake, avoid fluid creep. Then start diuretics. Diuretics, the dose actually 20 to 80 if it is a naive patient. And then if it's already exposed to diuretics, you can give 2 to 2.5 times. Expect a urine output of more than 100 to 150 ml per hour. You can double the dose of diuretics and put the patient on infusion as well. Target a negative balance, okay? Target a negative balance until your goals are achieved, okay? Other method is the PAL approach defined by the Codman et al. In 2012. So the PAL approach is keeping a high PEEP for 30 minutes. That is equivalent to the intra-abdominal pressure. And then giving an albumin. So albumin, 20% albumin, 100 ml. You can give up to 200 ml on day 1. And you titrate the albumin to almost 3 grams per deciliter, so 30 grams per liter, made to make sure the fluid is drawn from the from the circulation from the interstitial compartment to your plasma, and then try diuretics. Okay, PEEP, albumin, and diuretics. Diuretics you can give an infusion as well. So this approach has been initially tried in acute lung injury patients, and then they targeted a negative fluid balance to and found a reduction in the extravascular lung volume water index. Okay, and the intra-abdominal pressure had also come down. So this is beneficial by decreasing the duration of mechanical ventilator days without compromising on the organ function. So this is your PAL approach. So these are the indices wherein you need to look into. Other thing would be renal replacement or a sled. You can do either a sled with ultrafiltrate or scuff. Okay. Or venovenous hemofiltration with ultrafiltrate removal. So when do you start fluid, stop fluid, remove fluid, and stop removal? So I mentioned all these targets. So you can remember this slide as well. Next topic is post-intensive care syndrome. So the definition of so our interests do not limit to the ICU, extends to post-intensive care also. Okay, so the definition was given by in 2012. So new or worsening impairments in 3 domains: physical, cognitive, and mental health status arising after critical illness persisting beyond acute care hospitalization. So just remember, a patient admitted in our ICU has a surge response. Okay, always whenever there is a systemic inflammation response that is going on, the body tries to compensate. Okay, a compensatory anti-inflammatory response sets in, and that usually is very strong and it is kind of prolonged. Okay, so when the patient recovers, okay, when the surge response come down, and usually the cars also come down, and there is a phase of recovery. Most of the time, the patients, either if the surge response is overwhelming, there will be multi-organ failure and fulminant death that can happen. But if these 2 responses can resolve completely also, there can be a rapid recovery that can happen. But most of the patients, especially in patients who have a prolonged stay, have a prolonged inflammatory state, a state of persistent inflammation, and a state of persistent compensatory anti-inflammatory response that goes on for days to months. Okay, so what happens during this persistent inflammation? There is no return to homeostasis. Kind of the body becomes cachexic. There is more catabolism. There is progressive immunosuppression. Okay, and this affects the patient in a long term without returning to baseline at all. And there is indolent death. So how our main aims should start not after the patient recovery. It should be targeted even when the patient is in the ICU having a uh, acute phase of critical illness. Okay, so we need to be aware of this post-intensive care syndrome. So the three domains, that is physical, cognitive, and mental domain. Physical is due to weakness, disuse atrophy, reduced exercise tolerance, impairment of activities. Okay, lung diffusion volumes and capacity will come down. The patient memory will go down, attention deficit, okay, mental speed, visual, spatial ability, all those things will go down. Mentally, the patient can be depressed. The patient can have post-traumatic stress disorder, anxiety, sleep disturbance, sexual dysfunction, and all that. Risk factors begin in the ICU: prolonged ventilatory days, more than 7 days, sepsis, multi-organ failure, hyperglycemia, systemic corticosteroids, And cognitive impairment, delirium is a very important thing. Sedation, use of sedation, delirium, pre-existing cognitive impairment, and post-ICU mental illness like sedation, delirium, agitation, use of physical restraints, okay, contributes to all these things. So the main factor in post-intensive care syndrome, not only it is for the survivors, it extends to the family as well. Okay, this is PIC S. So this extends to the family. So in terms of survivals, you look into the physical impairment, cognitive impairments, and mental impairments, and long-term prognosis. So the main barriers, when we look into the barriers, it depends on many factors, okay? The patient has to be rehabilitated. When you evaluate the patient, there will be multiple issues with the patient, the clinical features where we mentioned. So these will be the clinical manifestations. And the patient has to come for follow-up. Either the patient can be at home or in a subacute care center, but the patient has to come to the hospital for follow-up. There can be physical immobility, lack of health, transportation difficulty, and all that, distance from clinic to home. So all these are barriers to follow-up. So physical impairments, the main physical impairments will be acquired weakness in terms of critical illness polyneuropathy, okay, and critical illness neuromyopathy and myopathy. So bilateral symmetrical weakness will be there, defined by the Medical Research Council scale, a combined score of less than 48 in all of the testable muscle groups done twice 24 hours apart. So that is the definition of ICU acquired weakness. Pathology, it is due to microvascular ischemia, catabolism, immobility, and it can lead to skeletal muscle wasting, microvascular injury resulting in nerve ischemia, dysfunction of sodium channels, and injury to nerve mitochondria, okay, resulting in neuropathy, myopathy, or both. It usually takes a long time, several weeks to months to recover. Next is cognitive impairments, 3 domains: delirium, dementia, depression. So impaired memory, executive function, language, attention, and visual spatial abilities will be impaired. And this is mainly due to hypoglycemia, hyperglycemia, fluctuations in glucose, delirium in hospital, stress symptoms. Okay, there is a strong evidence that patients with ICU delirium has a stronger risk of long-term cognitive dysfunction. Okay, dementia also is one of the component of cognitive dysfunction, and there has been an association between dementia and ICU treatment as well. Pathophysiology not known, mainly a manifestation of brain dysfunction. So in terms of the patients, most of the survivors, actually 30% have anxiety, almost 70% end up with post-traumatic stress disorder. Pre-existing all these symptoms, alcohol abuse, are more contributory to the mental illness. When we come to the family, usually the families of survivors also face anxiety, depression, acute stress. A cluster of such psychological reactions is called post-intensive care syndrome family. So the cluster of all these educational status, having a critically ill spouse, having more comorbids, being an unmarried parent, being unmarried, or a parent of a critically ill child. So these are the main risk factors of PICS F family. Okay, so in pediatrics, another component. So family we saw, another thing is pediatrics. survived child and the family of the survived child. So instead of mental health, it is emotional health and social health. So that is the difference in pediatrics. So how do we prevent PICS? This can be done by ABCDEFGH approach. So we all know the ABCDE bundle. So same applies here. A for AV management, assess, prevent, and manage pain. B for breathing trials, including daily interruptions of mechanical ventilation, spontaneous breathing trials, spontaneous awakening trials, choice of analgesia, sedation, coordinated care and communication, delirium prevention, assessment and management, early mobility and exercise. So also involve the family, follow referrals, functional reconciliation, and good handoff communication, hand out materials on PICS and PICSF. Next is nutrition. So always make sure the nutritional status is appropriate and maintained. Okay, energy delivery, protein intake necessary for muscle synthesis. If there is energy depth because of catabolism, always try to supplement with parenteral nutrition if the enteral nutrition is not adequate. Overfeeding can also induce autophagy and impairment. Okay, appropriate energy delivery, avoid overfeeding. So other aspects, so we looked in for A, B, C, D, E, F, G, H. Next is nutrition, environment managing management for healing. This is also important. So make sure in the ICU itself, earplugs, music therapy, improved quality of sleep, avoid noise reduction devices. Nursing care for pigs. So nurses are the people who are like remaining with the patient, close to the patient. So they need to know the priorities, living condition, prior living condition of the patient, they can help in early rehabilitation. Intensive diaries that is, so there can be a member or a medical person writes and can have this would follow up kicks and pics months to rehabilitate. So this is can I Amrita to
This meeting is being
do
recorded.
it after
Absolutely. So I'll share my presentation.
okay.
Can you see my screen?
Yeah, I'm able to.
Just a second. Okay. Yeah. So the query that regarding high sensitivity cardiac troponin levels and how to check and what is the guideline regarding at what levels to check. So rule in and rule out is what was the protocol which was given by by the European Society of Cardiology. Okay. So initially, previously, what the 2015 guidelines had suggested was the 0 and 1 hour rule. Okay. And then an additional testing at 3 to 6 hours. So that was what was the class 1B recommendation in 2015. But nowadays that has changed a bit. Okay. Sorry, I can't move my slides. Hello.
20
Hello. I'm not able.
2020 slide is visible. If you can, yeah,
Uh,
now I'm able
just a
to see
second.
the next slide. Yeah, cool.
Yeah. I was not able to move my slides. Okay. All right. So here is the basically the guideline that is given. So we have chest pain. A patient has come with a chest pain. Okay. So whether there is a history of or the physical examination which is suggestive of ACS, the new ischemic signs are present on the ECG or not. Okay. And the troponin levels, the baseline troponin levels, whether it is less than 5 nanogram per liter or it is less than 12 nanogram per liter, and after 1 hour the increase is less than 3 nanogram per liter. Okay, so here is the 0 2 hour, the 0 1 hour rule. All right, please listen carefully. 0 1 hour rule. If it is less than 3 nanogram per liter, all right, yes, sample after 24 hours. See if the patient's symptom, whether the symptom onset, whether you have taken the troponin levels after 2 hours or not. So 0 hour, 1 hour. Okay, 1 hour increase less than 3 nanogram per liter. Then you see whether the sample has been taken after 2 hours or within 2 hours. Okay? If the symptoms does not exist, then it is a low risk ACS. That means no further testing is needed. But after 2 hours of symptom onset, if it still persists, then go for an additional 0 hour and 2 hour test. Okay? And here you check whether the troponin levels are less than 12 or the increase is less than 3 nanogram per liter. If it is less, then you have successfully ruled out ACS and it is a low risk ACS. All right. Remember, we are not just seeing the high sensitivity troponin, we are also seeing the clinical physical criteria as well. Okay, so this is low risk management of the ACS. However, if these are not ruled out and patient has the symptoms and the ECG signs as well as the troponin levels, okay, when we have the troponin levels more than 52, okay, plus or there is a high risk history and physical examination with a high sensitive troponin level of more than 14. So it is either an individual level of more than 52 or a level more than 14 with the history of physical examination that we have, or the new onset angina, or the ischemic signs of ECG, then there is a high risk of ACS, which is the recommended management, and measure the additional high sensitivity troponin at 6 hours after 0 hours. Okay? So here is the 0 6 hour rule. When you have a high risk of ACS, you are suspecting. Okay? If this criteria is also not fulfilled and you know it is not a low risk, then we classify it as an intermediate criteria. And in the intermediate criteria, you consider the differential diagnosis, as we have seen that there are multiple differentials of high troponin levels. So consider those differentials. Additionally, test the troponin between 3 to 6 hours. Check the troponin levels after the 0 hour. That means you check at 0 hour and you check between 3 to 6 hours, unless there is no longer any suspicion of ACS, but it has to be further evaluated with other tests. Okay, I hope there is no confusion. So we have the 0 hour, 1 hour rule or the 0 hour, 2 hour rule if patient has come within 2 hours, okay, or after 2 hours. Then we have the 0 hour rule, which is followed by the 6 hour rule. And then we have the 0 hours and the 3 hour. Earlier, it was only 0 hour and 3 hour rule. So as we see 2015 class 1B recommendation, rule in, rule out, 0 1 hour and then 3 6 hours. This was the only rule. But now we have divided it based on the risk factors, and the ESC 0 1 hour algorithm at 0 and 1 hour is considered. Okay, that is a class 1B recommendation. Additional testing after 3 hours is recommended if the first two cardiac troponin levels of the 0 1 hour algorithm are not conclusive and the clinical condition is still suggestive of ACS. Okay, that is the intermediate one where we said 0 1 or 0 2, and then you do it between 3 to 6 hours. As an alternative to the ESC 01 algorithm, it is recommended to use ESC 02 algorithm with blood sampling at 02 hours. This is mainly for patients who have come after 1 hour. Okay, so 0 hour and 2 hours. And then as an alternative to this algorithm, rapid rule out and rule in protocol with blood sampling at 03 hours should be considered if the troponin level with validated 03 hours algorithm is available. So basically, if you really want to simplify, just follow this protocol. Okay, so the 0 hour rule, 0 hour, 1 hour, 0 hour, 2 hour rule. If there is a high chances of an ACS, you can repeat after 6 hours. And if there is an intermediate chance, repeat after 3 hours, 3 to 6 hours. Okay. I hope I'm clear on this. We'll go with the next topic, which is the etiology and the management of right heart failure. This will be the flow of the discussion of right heart failure. Introduction. Right heart failure, it is a clinical syndrome which is caused by dysfunction of the right heart structure, right ventricle predominantly, or the tricuspid apparatus, which results in the impaired ability of the right heart to perfuse lungs at normal CVP. Acute right heart failure, it is a syndrome which is characterized by the inability of the right ventricle to generate enough stroke volume, thereby resulting in systemic venous congestion, underfilling of the left ventricle, and in most advanced cases, cardiogenic shock. And the estimated mortality in such cases is around 6 to 14%. Coming to the etiology, so the etiology can be divided based on the physiology of the patient. Okay, so physiology of the patient, impaired RV contractility, increased RV preload, and decreased RV preload as well. So increased RV afterload, pulmonary artery hypertension, secondary causes of pulmonary hypertension, pulmonary venous hypertension, pulmonary embolism, HPV, mechanical ventilation, post-cardiothoracic surgery, acute chest syndrome as in sickle cell disease, they can also come with this, pulmonary stenosis and tumor emboli. Impaired right ventricle contractility when patient has come with a RV infarction, cardiomyopathy, sepsis, okay, arrhythmogenic RV dysplasia. Then increased RV preload, it can happen in TR, in PR, in post-left ventricular assist device, and in septal defects. Decreased RV preload in superior vena cava syndrome, tricuspid stenosis, cardiac tamponade, hypovolemia, and even capillary leak. So why is the RV unique? Okay, what is it about RV that is different from the LV? So first of all, the morphology wise, it is a low pressure, low resistance, high capacitance system. That means much less power is needed for the RV, and it is much thinner, around 1/3 less the muscular capacity than that of the LV. There is a thin valve with 2 muscle layers, but in case of an LV, it is a thick valve with a 3 muscle layer. Okay. Then RV is more compliant. It can accumulate large variation of venous return as compared to that of the LV. Okay. Without altering the end diastolic pressure. Each systolic contraction for the RV there is a longitudinal shortening, but in case of an LV, it is a circumferential shortening. Okay. 40% of the RV systolic function is dependent on the septal contraction. Then, because of its thinner wall and higher dependence on the coronary perfusion, as we said, mostly it depends on the septal contraction, the RV perfusion is more vulnerable to an increase in the RV size and the systemic hypertension. So there is greater sensitivity to changes in the afterload. Okay, as stroke volume rises, the change in that of the pressure in that of the right ventricle, okay, the change in the afterload of the right ventricle, that is, it decreases immediately compared to that of the left ventricle. And there is also ventricular interdependence, where an excessive RV volume loading will constrain the pericardium, and it results in compression and the D-shaping of the LV volume overload in the RV, thereby indirectly which leads to decrease in the LV stroke volume. Pathophysiology. So pathophysiology wise, whenever there is an RV right ventricular failure, okay, it can happen due to various causes, as we mentioned, excessive preload, reduced inotropy, reduced lucitropy. All right, it can happen because of various factors. All these factors can contribute to what? So because of the excessive preload, what can happen? There will be a leftward septal shift. Whenever there is a leftward septal shift, there is increase in ventricular interdependence. So this is one of the most important mechanism of heart-lung interaction, and this can result in decrease in the coronary perfusion pressure, worsening the myocardial ischemia. All right. So whenever there is initially, when the right ventricular failure is happening, it starts with a right ventricular dilation. All right. There is a right ventricular dilation which results in the leftward shift of the left ventricle. All right. So this is one of the mechanism. Right ventricular dilation also worsens the tricuspid regurgitation, resulting in the congestion of the right side, which is the hepatic venous congestion, renal venous congestion, which further worsens the fluid and sodium retention and worsens the pulmonary pressures, resulting in a lower pulmonary compliance. Okay, and this also worsens the ventricular interdependence. On the left side, what happens? So basically, on the left side, all this can further be worsened by the ventricular remodeling, hypertrophy, and fibrosis. So these are all interdependent, and each of them can cause a vicious cycle to occur, resulting in ventricular remodeling, ventricular dilation, right ventricular dilation, worsening of tricuspid regurgitation, and finally hypertrophy and fibrosis. At the end of the day, all of these will result in a decreased right ventricular output, decrease in the LV preload, and decrease in the LV output, resulting in shock. Okay. Molecular mechanisms consist of hypertrophy, apoptosis, okay, ischemia, metabolic dysfunction, fibrosis, with increase in the inflammatory cytokine and collagen synthesis, increase in the reactive oxygen species, reduced oxidants, neurohormonal activation, and reduced fatty acid oxidation with increased glycolysis. So how are we going to diagnose? It is diagnosed, first of all, initial evaluation, symptoms of the right heart failure. Patient will come with dyspnea, abdominal fullness, lower extremity edema, right upper quadrant tenderness, exercise intolerance, and fatigue. Associated disease need to be ruled out. There might be a social history as well. Okay, and family history of PH and left heart failure, sudden cardiac death, ARVC also need to be ruled out. Physical examination, raised JVP, with a right ventricular heave, loud P2, tricuspid regurgitation murmur, pulsatile liver, hepatojugular reflex, ascites, and pedal edema might be present. Laboratory findings, patient can come with increased BNP levels, ABG, blood lactate levels which might be high, chest X-ray suggestive of maybe an edema, and a D-dimer level. Right axis deviation on the ECG is common, and patient might come with a P pulmonale, with atrial flutter or atrial fibrillation. Cardiac catheterization is indicated when non-invasive testing is inconclusive. It helps to directly quantify the right and the left heart failure. PA pressures and cardiac output can also be measured. So echocardiography findings, there might be pericardial fluid more than 5 mm during diastole. RV valve thickness is increased more than 5 mm. There is dilation of the IVC. Okay. Tricuspid regurgitation, peak systolic velocity more than 2.8 meter per second. TAPC less than 17. RV dilation. So RV is to LV ratio more than 1. So the size ratio, RA-RV dilation is seen. RV fractional area change of less than 35%. Okay. Then ventricular interdependence with shifting of the ventricle towards the left, causing a D-shaped ventricle. And then we have the systolic velocity of the tricuspid annular less than 9.5 centimeter per second, which is and then we have the longitudinal strain of the RV free valve less than 20%. So on and so forth. So majority you have to, the things that you shouldn't forget are the RV valve thickness, the tricuspid regurgitation velocity, the TAPC, the dilation, the fractional area change, interdependence. At least these ones you should not miss. Also, so look out for the causes of the right heart failure, whether there is any pulmonary embolism, whether there is any right heart mobile thrombus, whether 60-60 sign is present as in case of embolism. So all those things should not be missed out. Management, 5 pillars of the management of right heart failure are etiology and specific treatment, optimization of fluid administration with diuretic therapy and RRT, hemodynamic support with vasopressors and inotropes and inhaled vasodilators, ventilation, conventional or high flow NIV and mechanical ventilation, last but not the least, mechanical circulatory support. Coming to the first pillar, which is optimization of the fluid administration. Now, in case of RV, very much unlike the LV, we have preload reduction is required, okay, but vigorous fluid administration may result in decrease in the left ventricular output, and cause hypotension through ventricular interdependence. And they might require, in case of an overload state, removal with loop diuretics like furosemide, or even sometimes RRT may be required. However, there is one particular condition like the right ventricular MI. Okay, the primary problem here is the decrease in the RV contractility and not the RV afterload, in contrast to the pulmonary embolism. So in this situation, the fluid increases the pressure ahead and consequently improves the cardiac output. So whether to give the fluid or not to give the fluid, one has to decide. Coming to the second point, which is the hemodynamic support. So hemodynamic support, maintenance of the MAP by the vasopressors. Norepinephrine, epinephrine, vasopressin, anyone can be used. What is mostly the vasopressor of choice is the norepinephrine for all such cases, which targets alpha 1 to 3, basically alpha and beta. Increase in the systemic vascular resistance. It increases the peripheral vascular resistance and increases the heart rate contractility. Epinephrine, it increases the systemic vascular resistance, decreases the peripheral vascular resistance, and increases the heart, basically causes tachycardia. Vasopressin, it increases the systemic vascular resistance, decreases the pulmonary vascular resistance, okay, and decreases the heart rate and the contractility. Inotropes. So basically, inotropes, we have the dobutamine, milrinone, and here I have not mentioned the levosimendan. But in case of cases where there is hypotension, we usually do not use levosimendan or milrinone. We go with dobutamine. They cause decrease in the systemic vascular resistance, the peripheral vascular resistance, and increase in the heart rate and the contractility. Okay. Then obviously the phosphodiesterase inhibitor, we have the milrinone, and then we have the levosimendan, which is the calcium sensitizer. Another important entity is the inhaled vasodilators, which decreases the pulmonary vascular resistance. It may include inhaled nitric oxide, epoprostenol, milrinone, and nitroglycerin, and these are the drug doses. Etiology or the specific treatment. For example, pulmonary hypertension needs to be treated with all these endothelin receptor antagonists, prostacyclin analogs, calcium channel blockers, inhaled vasodilators, phosphodiesterase 5 inhibitors. Okay. Apart from that, mechanical obstruction alleviation, aortopulmonary shunting, lung transplantation might also be needed as a specific treatment. Correct the hypoxia, hypercarbia, acidosis. They worsen the HPV. Okay. So these things should be corrected. Rhythm stabilization in case of any arrhythmias is important, and correction of the underlying condition. Lung protective mechanical ventilation with a tidal volume of 4 to 6 ml per kg of predicted body weight, low peak pressure, and the PEEP plat of less than equal to 30 millimeter of mercury is needed. The minimum PEEP is recommended. So what happens is when you give PEEP, the positive pressure reduces the venous return and the RV preload. At the same time, acidemia and ventilator-induced rise in the transpulmonary pressure increase the peripheral vascular resistance and the RV afterload. So PEEP is like a double-edged sword, okay? And as we say, optimum PEEP is needed, but for the right heart, keep it as minimum as possible. The intracorporeal microaxial pump, all the MCS devices are needed in case all the other therapies do not work. So manage the primary cause, all right? Pathophysiology is important, whether it is a pressure overload, volume overload, or a myocardial disease, that is also important. Causes, we have to remember, go with the volume adjustment, the inotropy, the perfusion, reduce the afterload, and the etiological treatment by treating the specific causes. In case of a refractory situation, go with the MCS devices. So this is the star slide for this topic. Coming to our next talk, which is on pulmonary hypertension. Okay, so pulmonary hypertension, first of all, the clinical classification of pulmonary hypertension. We have the class 1, 2, 3, 4, and 5. So first are the causes of pulmonary arterial hypertension, the idiopathic, heritable, drug and toxin, okay, associated with certain diseases like connective tissue disease, HIV, portal hypertension, then schistosomiasis. All these are the causes of pulmonary arterial hypertension. Left heart disease, which is the most common out of the lot. We have the heart failure with preserved ejection fraction, reduced ejection fraction, valvular diseases, congenital diseases, then those with lung disease like restrictive obstructive lung diseases, okay, hyperventilation syndrome, hypoxia. So these are important. Those associated with pulmonary obstruction, and last but not the least, unclear mechanisms. So we also have the hemodynamic classification of definition of pulmonary hypertension, which is obtained by the right heart catheterization, and it includes the mean pulmonary arterial pressure of more than 20 millimeter of mercury, pulmonary artery wedge pressure of less than equal to 15 millimeter of mercury, and peripheral vascular resistance of more than 2 watt units. So important here is the precapillary, the postcapillary, and the combined. So these three are important. Anyways, pulmonary hypertension, you will have a pulmonary artery pressure of more than 20, but for precapillary and postcapillary, the differentiating point probably will be the pulmonary artery wedge pressure, which is less than 15 for precapillary, and for postcapillary more than 15, and the peripheral vascular resistance more than 2 watt unit for the precapillary, and for the postcapillary it is less than 2 watt unit. Coming to the pathophysiology. So the pathophysiology, there is a pulmonary vasculopathy. Okay. Pulmonary vasculopathy, basically we have the pulmonary, the right side of the heart, which has the increase in the pressure. So there is an increase in the pressure causing the vascular changes in the pulmonary vessels. So basically pulmonary vasculopathy resulting in hypertrophy, intimal proliferation, fibrosis, thrombosis, vasoconstriction. Okay, all those things worsen the proliferation and the fibrosis, which results in the PH, hypertrophy and dilation of the right ventricle, and further regurgitation of the tricuspid valve, increasing the pressure of the right side, resulting in a congestive cardiac failure. At the same mitral valve, increase causing the pulmonary vascular pathology of the aortic valve increases the left ventricular end diastolic pressure, and they can also result in right ventricular failure. If we go by the micro or the micro pathology, okay, there is medial hyperplasia, intimal proliferation, and plexiform lesions resulting in vascular obstructions basically. And the even micro pathway involves the endothelin pathway, the nitric oxide cyclic GMP pathway, and the prostacyclin pathway. Symptoms, we have the early symptoms and the late symptoms. So dyspnea on exertion, fatigue, dyspnea on bending forward, that is the bandopnea, palpitation, hemoptysis, all syncope, weight gain due to fluid retention, all these are the early symptoms. Later on, patient can develop hoarseness, the Ortner's syndrome, exertional chest pain, all right, wheezing, coughing, all those things they can have. Then coming to the signs of pulmonary hypertension, patient can come with mixed cyanosis, right ventricular third heart sound, systolic murmur of the tricuspid regurgitation, diastolic murmur of the pulmonary regurgitation. Okay, they can come with right ventricular backward failure, that is due to back pressure. They can have all the congestion on the right side, hepatomegaly, ascites, edema, distension, raised JVP. Signs pointing towards the underlying cause of the pulmonary hypertension, where we have the cyanotic heart diseases, bronchiectasis, Eisenmenger syndrome. So all of these might come with an underlying pathology sign. And the right ventricle forward failure, patient can come with dizziness, pallor, cool extremities, peripheral cyanosis, and prolonged capillary refill time. Now, the ECG findings, P pulmonale, patient can have right axis deviation, right ventricular hypertrophy, bundle branch block, right ventricular strain pattern, and prolonged QTC can also be found. Features of the pulmonary hypertension, left heart disease, and lung disease can also be found in the chest X-ray. Okay. Other functions which are recommended are pulmonary function test, lung scintigraphy, ABG, chest CT, cardiopulmonary exercise testing, right heart catheterization, and cardiac MRI. Echo findings. So echo findings, very much like the previous findings, there is an enlarged right ventricle, okay, RV by LV ratio of more than 1, flattened septum, distended inferior vena cava, okay. Then the right ventricular fractional change area of less than 35%, TAPSE of less than 18, peak systolic velocity of the tricuspid annulus of less than 9.5, enlarged right atrial area of more than 18 centimeters square, the peak TRV of more than 2.8 meter per second, and presence of pericardial effusion can also be found. So what is the goal of therapy? The goal of therapy is defined by the risk category. So the risk category is defined by the WHO functional classification, the 6-minute walk, the distance test, the BNP, and the NT-proBNP. The goal of the test is to achieve the goal of therapy is to achieve a low risk state from the intermediate or the high risk state. Okay. So the low risk, meaning WHO functional class of 1 or 2, 6-minute walking distance of more than 440 meters, and the BNP levels of less than 50 or NT-proBNP of less than 300. The ultimate treatment goal is sometimes described as achieving a cure, signifying complete remission of the pulmonary hypertension without the necessity of ongoing treatment. So we have the specific or the definitive treatment in terms of the pharmacotherapy when it comes to the pulmonary hypertension. And basically, these include calcium channel blockers, endothelin receptor antagonist, the phosphodiesterase 5 inhibitors with sildenafil and tadalafil. We have to remember some of them, including the doses, prostacyclin analogs with inhalational iloprost of 2.5 microgram, 6 to 9 times per day, and the remaining are subcat or IV. Okay, treprostinil is also given as an inhalational dose. Then we have the prostacyclin receptor agonists, or the analogs, which are given orally, that is selexipag, and then the recent sotatercept, which is the activin receptor ligand. So these are the pharmacotherapies which are available. And what is vasoreactivity and calcium channel blocker? So it is a physiological response of the pulmonary artery, pulmonary vasodilator, a response that identifies the patient's of this calcium channel blockers. Okay, and it is recommended in idiopathic, hereditary, associated PAH. So responders are who? Responders are basically those which fall in the mean pulmonary artery pressure of more than 10 millimeter of mercury to a value of less than 40 millimeter of mercury. And there is increased or unchanged cardiac output. The common doses are epoprostenol, adenosine, and nitric oxide. So these are the drugs which are used for vasoreactivity testing. But vasoreactivity testing can only be done at a tertiary center where there is high monitoring. Normally, these days, it is not done, where patients with a positive vasoreactive reactive state, they respond to high dose calcium channel blockers. However, calcium channel is not used as a uh, uh, testing marker for vasoreactivity testing. So whenever a patient, so this is the important algorithm that one has to know, and a lot of people are confused with this algorithm. So pulmonary hypertension, arterial hypertension, uh, whether the acute vasoreactivity testing is needed or not needed. Okay, so if it is needed, as we have seen in the idiopathic, hereditary, and drug classification, if they are responders, then go for high dose oral calcium channels. Okay, if it is a sustained response, then continue with the calcium channel blockers. If no, then determine the WHO class. And if the vasoreactive testing is not indicated in such patients, then directly define the WHO class, which is WHO class 1, 2, 3, 4, which is nothing but the functional class of 1, 2, 3, 4, which we have studied in the first slide. Okay, for class 1 patient, observation contributing factors. For class 2, that is the left heart failure patients, go for what is the preferred? The preferred treatment is an ambrisentan plus a tadalafil. Okay. Other combinations may be combined, single agent therapy may be given, but this is the preferred, ambrisentan with tadalafil. This is the first line. For WHO class 3, okay, ambrisentan and tadalafil is the first line, but alternatives for a rapidly progressive disease can be epoprostenol, inhaled iloprost, or treprostinil, which is the prostacyclin analogs. Okay, and class 4, you directly go for a prostacyclin analog. If no improvement or deterioration is noted, then double or triple therapy is combined. If still no improvement is noted, then go for a lung transplant or an atrial septostomy. Apart from that, the baseline parameters of right heart failure, all of those will persist to treat hypoxemia, inhaled pulmonary vasodilators, treat hypotension, vasopressors are needed, dysrhythmia, treat arrhythmias, avoid hypoxia, hypercapnia, acidemia, inotropic support, uh, all those things, whatever we have learned in the right heart failure will be needed here as well. And this is the star slide where you know the classification. Okay. And then we have the therapeutic strategies for each of them. Our next topic is a pulmonary embolism. Okay. So this you cannot not read. You have to know the risk stratification of pulmonary embolism. Acute pulmonary embolism can be divided into low risk, intermediate risk, or high risk. Sometimes people divide it as low risk, submassive, and massive. So submassive is nothing but these two parameters. Submassive is divided into intermediate low risk and intermediate high risk. And then you have the massive, which is the high risk. So the low risk patient is normotensive. The simplified PESI score is equal to 0. What are these scoring systems? We will read in the subsequent slides. Okay. So simplified PESI score is 0. Patient does not come with a dysfunction. The RV is normal in size and function, and there is normal cardiac biomarkers with no myocardial strain. The mortality is around 1.1% only. Intermediate risk. Now, intermediate risk is divided into two. Okay, we have the intermediate low risk and the high risk. But what differentiates the intermediate and the low risk and high risk is the last one. So basically, simplified PESI is more than equal to 1 and patient comes with a normotension. However, in the first one, presence of an RV dysfunction or myocardial strain, which is the elevated cardiac biomarkers, any one of them may be present. But in the intermediate high risk, both of them are present. That is elevated cardiac biomarkers with the presence of an RV dysfunction. In a high risk or a massive risk, apart from the RV dysfunction, patient has come in a state of shock, that is hypotension of less than 90 millimeter of mercury of systolic blood pressure with a drop or a drop of more than 40 millimeter of mercury from the baseline for at least 15 minutes, requirement of vasopressor support, simplified PESI more than equal to 1, and the presence of an RV strain, dilation, dysfunction, myocardial strain with elevated cardiac markers. Everything is present in the high risk. Now, the 30-day mortality for the submassive is around 15.5%, and for a high risk or a massive is around 65%. Coming to what we read as the PESI score. Okay. So even if you don't remember the entire original PESI score, please try remembering at least the simplified PESI score. So simplified PESI consists of what? It consists of age comprising of 1 point, cancer comprising of 1 point. Then we have this chronic heart failure, chronic pulmonary disease comprising of 1 point, tachycardia of more than 110 comprising of 1 point, hypotension 1 point, and arterial oxygenation, the hemoglobin oxyhemoglobin saturation of less than 90%, that is 1 point. So even if you don't remember this, please make sure to read this. And as we said, 0 point, okay, and more than equal to 1 point. In the previous slide, you have seen, apart from the low risk, the rest of them all have more than equal to 1 simplified PESI score. So 0 points has a 30-day mortality of 1%, and more than equal to 1 point, 30-day mortality is around 10.9%. Pathophysiology here very similar to what we have been studying before. The increase in the RV afterload, RV dilation, increase in the right ventricular tension, myocardial inflammation, demand increases, there is ischemia, hypoxic injury, decrease in the contractility, decrease in the RV output, decrease in the LV preload, decrease in the cardiac output, hypotension. So basically whatever we have studied for a right heart failure, you can just put it here. In the end, patient comes with can develop an obstructive shock and death. Now, decision to test in outpatient testing for pulmonary embolism. Again, this is very, very important. Okay. So, first of all, one has to have a high sense of suspicion for pulmonary embolism in the outpatient department. Okay. Which comes to our pulmonary embolism rule out criteria. So, pulmonary embolism rule out criteria, patient has to have a very high, this we will be again discussing in the subsequent slides. So, if there is a high likelihood, that is more than 15%, then we choose to do the next set of basically scoring systems for the patient. If there is a less than 15% likelihood of pulmonary embolism or an implicit sense of pulmonary embolism, and the PERC is positive, we can still choose one of these chosen strategies, okay, to decide on whether the patient has a pulmonary embolism or not. However, if the pulmonary embolism rule out criteria is negative and the judgment of the clinician is also negative, estimated likelihood, then you rule out the pulmonary embolism. Okay, so we have to have a combination of symptoms and clinical findings with predisposing factors to have the clinical or the pre-testing probability. So that the pre-test assessment can be done either by implicit clinical judgment or by using prediction rules. As I said, this is the implicit clinical judgment, but if we are still unsure, we go for the prediction rules. Okay, the prediction rules, basically what it comprises of, we have the Wells or the Geneva score. The Wells score of less than 4, revised Geneva score of less than equal to 10, and simplified Geneva score of less than equal to 4. Okay, along with a D-dimer option. If the D-dimer levels are less than 1000 or it is less than the age adjusted cutoff or the manufacturer recommended cutoff, if this is there, okay, then P is ruled out. However, if the Wells score is more than equal to 4, the Geneva score is more than equal to 10, and the simplified Geneva score is more than 4, this along with a D-dimer cutoff which is higher than the specified threshold, then we have to have a high suspicion of PE and we have to follow the next set of investigations. Okay. What are the risk factors? So a lot of people again are confused with the risk factors, whether it is a low risk or a high risk. So this has been by the AHA guidelines. The risk factor for pulmonary embolism, low threshold or the low risk, the major transient or reversible factors associated with more than 10-fold increase for the index of venous thrombosis as well. Okay, so examples are surgery with general anesthesia for more than 30 minutes, confined to bed in the hospital for more than equal to 3 days due to acute illness or acute exacerbation of any chronic illness, trauma with fractures. Okay, this is a low risk. Coming to intermediate risk are we can divide it into transient or reversible factors, the non-malignant persistent risk factors, or no identifiable risk factor. So the transient factors are minor surgery, less than 30 minutes. Okay. Then we have admission to hospital for less than 3 days with acute illness, estrogen therapy, pregnancy, confined to hospital days for more than equal to 3 days with an acute illness, leg injury. Leg injury is important. Okay. Any leg injury associated with reduced mobility for more than equal to 3 days. Please do not confuse it with trauma with fractures. And long haul flight. Patient has taken a flight from New York to India. Okay. Long haul flight. Then new non-malignant persistent risk factors like inflammatory bowel disease, active autoimmune disease. These are all intermediate risk factors, and the high risk factors are active cancer when patient has had a previous history of VTE, antiphospholipid syndrome. So these are the risk factors. Coming to either you can remember that or you can directly remember the scores. So the scoring system, there is no in and out. You just have to remember these scoring systems. So we have the Wells score. The Wells score, what are the pointers? The P, most likely diagnosis 3. Signs and symptoms of DVT 3 points. Tachycardia more than 100, 1.5 points. Previous 4-week immobilization for more than 3 days or surgery 1.5 points. Previous DVT or PE 1.5 points. Hemoptysis and cancer 1 point. So these are the criteria, and as we have seen in the previous slide, the Wells score of 4 is the cutoff for the Wells score. Okay. Likewise, you need to read off the Geneva score as well as the PERC score. This is all mugging up. No one can give you a shortcut for it. So just read it, and at least if you cannot remember all the scores, remember at least the well score, okay, and the simplified Geneva score. So diagnostics, we have CTPA, okay. Then the VQ scanning, VQ SPECT, pulmonary angiography, D-dimer testing, compression ultrasonography, and MRA. So MRA is not recommended for the diagnosis, but it is still one of the diagnostics that can be used in case other things don't help. Echo, we have discussed time and again, so I will not dwell into the detail of it. One thing you need to remember is the 60-60 sign, okay, and the McConnell sign. The McConnell sign, which is the the McConnell sign, this one, which is the free floating of the septum, and this one, the right ventricle, and the 60-60 sign, where you have the coexistence of the acceleration time of the pulmonary ejection of less than 60, and the mid systolic notch with mildly elevated peak systolic gradient of less than 60 millimeter of mercury. So at least these two you have to remember, with the remaining of them, which is very similar to the right heart failure. Chest X-ray, focal oligemia. Then you have the Pallas sign, the Fleshner sign, and the Chang sign with Hampton's hump. ECG findings of right ventricular stain S1Q3 T3, not found in all the patients, found in only 10 to 15% of the patients. Then RBPB and P pulmonale might also be present. Patient can also present with atrial fibrillation and low voltage QRS, and the laboratory markers. Now coming to the approach to the treatment of acute pulmonary embolism. So in the above slides, we have established basically the approach to the decision making of a pulmonary embolism, whether pulmonary patient has a pulmonary embolism or not. Now what we are doing is what next needs to be done. So if the assess for the stability of the patient, okay, if the patient is hemodynamically stable, all right, anticoagulation or inferior vena filter can be considered. But before that, you need to assess for the right ventricular dysfunction. Right ventricular dysfunction, go for echocardiography, multi-detector CT. While you know that CTPA is what needs to be done, but there are times when you cannot do a CTPA, and at that time, patient has to undergo other things. For example, a bedside echocardiography, you'll have to depend on. You will have to depend on a VQ scan. All right. Plus, assessment for the RV injury with elevated cardiac biomarkers. So that is what we have to see. In case of hemodynamically unstable patient, as I said, CTPA might not help. A more helpful parameter probably would be an echocardiography. All right. So if there is no dysfunction or injury, basically patient has come in a low state, okay, continue the regular treatment. All right. You can consider anticoagulation. If the patient has come with a dysfunction, so the main confusion is between the intermediate low risk and intermediate high risk state. So when there is an intermediate low risk state, we go for an anticoagulation. When there is an intermediate high risk state, we go for an anticoagulation with a thrombolysis. And when there is a dysfunction and an injury together, then you go for all the other parameters. Okay. Apart from that, go for the regular support, volume optimization, vasopressors and inotropes, mechanical circulatory support, and the advanced life support. The drugs for anticoagulation are as follows. Okay, enoxaparin, dalteparin, doses you have to remember, and the deperfusion therapy with IV thrombolysis. One needs to know the trials for them. Altiplase 100 milligram over 2 hours is given. Retiplase 10 milligram bolus, which is repeat after 30 minutes, and tenecteplase dose depending on the weight is 30 to 50 milligram bolus. Now here one has to remember the trials. For Altiplase, the trial was MOPED trial. Okay, heparin with Altiplase versus heparin with placebo. It was found that heparin with Altiplase decreases the hospital mortality and also the clinical deterioration in the patient. And tenecteplase, we have the types, the top coat and the patho trial. The types and the top coat showed favorable composite outcome. The patho trial showed non-significant reduction in the mortality. That is, the hemodynamic decompensation or the death within 7 days was 2.6% versus 5.6% for the placebo. However, there was more bleeding found in the interventional group compared to the placebo group. Other treatment modalities are catheter-directed therapies. We have the catheter-directed thrombolysis, the ultrasound-assisted thrombolysis, which is set. These two together are set to help attain the hemodynamic stability, as seen in the Ultima and the Seattle trial. Rheolytic thrombectomy, suction thrombectomy, and rotational thrombectomy and aspiration, which has the flare and the flame trial. Remembering the names of the trials are enough. Okay, so this is the single line, the single page, if you have to read before the exams: diagnostics and risk assessment, anticoagulation, thrombolysis, okay, systemic thrombolysis, catheter directed thrombolysis, or embolectomy, one has to know. All right, risk prognostication with low risk, intermediate risk, and high risk, which we have studied all the risk scores along with RV dysfunction, biomarkers, hemodynamics, and finally the treatment. Okay, do not forget to mention all the other treatment for the pulmonary embolism. IABP and mechanical circulatory devices. So within this framework, we have uh, an overview of the mechanical circulatory devices with appropriate device selection, escalation strategies, management in intensive care, and de-escalating of the MCS. So if we see the definition of cardiogenic shock, if we have to see, it comprises of hypotension state with low cardiac output with signs of organ hypoperfusion. Okay, signs of organ hypoperfusion being cool extremities, altered mental status, oliguria, elevated serum lactate levels, hypotension, and obviously a cardiac index of less than 1.8 liter per minute per meter square without support, and less than 2.2 liter per minute with support. Okay, then it is divided into the three classification, which is the SKY classification, beginning with at risk, beginning, classical, deterioration, and extremis. Then we have the hemodynamic profile, which is the LV congestion, biventricular congestion. Then we have the hypovolemic and the RV congestion, and the phenotypic classification involving the biventricular failure, involving the liver, or involving the kidneys. So these stages of classification, the SKY, the hemodynamic, and the phenotypic classification, everyone has to know. So why are we reading about cardiogenic shock? Because MCS is one of the things that is used in the cardiogenic shock, okay, as uh, a bridge to recovery, bridge to transplant, bridge to device, and bridge to decision making. And the goals for these devices should be optimize the tissue congestion and improve the left and right ventricular failure, that is decongest the patient. Then ventricular unloading, which is decrease in the ventricular mechanical power, reduction in the oxygen demand, reducing the valve stress, minimizing complications like the effective dose of the inotropes and the vasopressors, and the end organ perfusion by reducing the organ injury, optimizing the tissue perfusion, and the oxygen delivery. So the causes of cardiogenic shock which might warrant the escalation to these are the complications for the acute myocardial infarction, acute cardiomyopathy, advanced right-sided or left-sided heart failure, allograft failure, post-transplant RV failure, post-cardiotomy shock, refractory arrhythmias, drug overdoses causing these massive pulmonary embolism and cardiac arrest. Principles of escalation include patients with ongoing severe cardiogenic shock with persistently low cardiac index, cardiac power output of which is low, less than 0.6 watt, hypotension, inadequate lactate clearance, evidence of RV failure, profound hypoxemia, and recurrent ventricular tachycardia or ventricular fibrillation. Now coming to IABP. So IABP, the principle is the balloon is inflated during the diastole to increase the coronary perfusion and then deflated during systole to decrease the afterload. It aims to improve the myocardial oxygenation, increase the cardiac output, organ perfusion with reduction in the ventricular the workload. Indications mainly cardiogenic shock, post bypass, post MI, mainly all the ones which we have studied in the previous slide. However, what more than indications, what we need to know is the contraindication, where it is not used: aortic regurgitation, aortic dissection, severe aortoiliac or peripheral vascular disease, aneurysm or other anatomical disease of aorta, prosthetic aortic tree grafts, local sepsis, lack of experience with management, severe coagulopathy, and not effective in the setting of cardiac index of less than 1.2, and tachyarrhythmias. IABP has two parts. Basically, there is a large bore catheter. So where one needs to know that there is a large bore catheter. Okay, so catheter with like a sausage with a distal tip, and there is a balloon, and this is connected to a console. Okay, so there's a helium tube which is ends with a balloon and a distal tip, and there is a console. Okay, and the balloon is made of a polyurethane membrane. The catheter sizes can be varied with the balloon size chosen according to the height. It can be between 25 to 50 cc. They may be shorter or longer depending on the left ventricle capacity. And the balloon is timed to inflate and deflate with respect to the cardiac cycle. Okay, so what happens during the inflation? So the balloon is timed to inflate and deflate with respect to the cardiac cycle. And the trigger options, one is the ECG. So ECG using the RVF sensor can be triggered by the left ventricle capacity. The deflation occur depending on the when the R waves are sensed. And if the rhythm is paced, then pacing spikes can be used to detect the cardiac cycle event. Okay, so what happens during the inflation, during the diastole? There is augmentation of diastolic pressure, increase in the coronary perfusion, and increase in the myocardial oxygen supply. During the deflation, during systole, there is decrease in the afterload, decrease in the cardiac work, decrease in the myocardial oxygen consumption, and increase in the cardiac output. So very important, the waveform of the IABP. So we have first the unassisted aortic end diastolic pressure. Okay, the non-augmented systolic pressure. All right. Ideally, we have this kind of a waveform, right? So this is our arterial waveform. But when you have in the IABP, when you have the augmentation, then you have the augmented diastolic waveform. All right. Then the reduced aortic end diastolic pressure and the reduced systolic pressure. Okay. So the end aortic end diastolic pressure, it is lower than that of the unassisted aortic end diastolic pressure. Okay. The augmented diastolic pressure is always the peak and it is up than that of the non-augmented systolic pressure, and the reduced the systolic pressure, that will always be lower than the non-augmented systolic pressure. So these are the features of the IABP waveform that one has to remember. And the correct positioning, the balloon, it is just distal to the left subclavian artery 2 centimeter above the left main bronchus. So and the slope of the augmented diastolic wave is straight and parallel to the systolic upstroke. Coming to the troubleshooting. So, what are the problems with the IABP waveforms? So, we can have an early inflation where the IABP is inflated well before the actual diastolic notch. Okay, so dicrotic notch, the inflation occurs early. So, what will happen? There is premature closure of the aortic wall, reduction in the stroke volume, increase in the left ventricular end diastolic volume, and increase in the left ventricular wall tension. So, the treatment for this is delay the onset of the IAB inflation. Okay. Then we have the late inflation. So here what is happening is the diachronic notch is visible much later than that of the actual area of the diacrotic notch. So the augmentation is less optimum. As you can see, the augmentation of the diastolic, the augmented diastole is much less than that of what it should have happened. And there is decrease in the perfusion pressure and volume to the coronaries. So adjust the timing such that the IABP inflates at the diacrotic notch. Early deflation, what is happening is there is no afterload reduction, and the assisted systole, the peak is the same as that of the unassisted systole. Ideally, it should be less, right? It should be lower down, but it comes very at the same level as that of the systole. So this is one of the parameters which is glitching for early deflation, and we have to prolong the IABP inflation time. And last but not the least, we have the late deflation, okay, which causes the increase in the workload of the left ventricle and increase in the myocardial ventricle, the myocardial oxygen demand. So shorten the IABP inflation time in such cases. IABP Shock 2 trial, there was no difference in the 30-day, 1 year, or 6-year mortality, and there was no benefit with respect to the hemodynamic parameters, lactate levels, catecholamine doses, or kidney function. So basically, for cardiogenic support, it is just an adjunct without any mortality benefit. What are the other parameters, the other tools that we have apart from the IABP? So it can be divided into left ventricular assist device and the right ventricular assist device. So left ventricular assist device can again be divided based on the pulsatility, the axial flow, and the centrifugal flow, based on whether it is a continuous pump or a pulsatile pump, whether it is intracorporeal or whether it is extracorporeal. So when you write your answers, you can divide based, or you can just put this slide. And we have IABP, Impella CP. Okay, we have the tandem heart, and we have the VA ECMO. And similarly, we have the right ventricular assist devices, where we have the axial flow with Impella RP and the centrifugal flow with the VA ECMO, and the tandem RVIT and Protect Oxy RVIT. Okay, so what happens? IABP we have studied in detail. Tandem heart is what? You don't have to know the deep details of this, but what you need to know it is independent of the rhythm. It is less artificial service area than that of the ECMO. It is suitable for patients with aortic stenosis and prosthetic aortic valve. But however, it is and it is usable in the LV dysfunction. All right. And however, it compared to these two devices, Impella and IABP, it is much more invasive. Okay, because the atrial septum is basically catheter passes to the atrial septum in case of tandem heart. Then we have the Impella. It is independent of ECG and pulse. It is relatively easy insertion in the cath lab, and no extracorporeal blood is used here. And ECMO will be discussing in details regarding the VA ECMO in the next few topics. Coming to the various features of each of these devices. So first of all, one has to remember that IABP, it provides only up to 1 liter. Okay, 0.5 on the type of Impella used. You have the 2.5, you have the Impella liters per minute depending on the type of Impella used. And the mechanism of the the flow that happens. Tandem heart 2.5 to 5 liters per minute, and the flow happens from LV to via delay to right. And last is the VO, which can give up to minimum Impella for 7 and VA ECMO, of course. It can be continued weeks. Then we have the sheath size, the femoral size. These are all you'll have to mug up, unfortunately. Cardiac synchrony or the stable rhythm. Impella cannot be used, tandem heart cannot be used, and via ECMO, they might not provide this cardiac synchrony. Then afterload, afterload increase is more in case of tandem heart, and in case of VA ECMO, it is the highest. The decrease happens in case of IABP and Impella. MAP is maintained and highest in case of Impella, tandem heart, and the VA ECMO. Cardiac flow is maximum in case of Impella, the tandem heart, and the VA ECMO, and the cardiac power also is highest in these cases. Okay, and the left ventricle, unfortunately, VA ECMO does not offload the left ventricle. Okay, and left ventricle preload, however, is decreased by the VA ECMO, not so much. It is more by the Impella and that of the tandem heart. Coronary perfusion is highest with Impella and with IAB. Oxygen demand is decreased most in case of an Impella. Okay, complications of these devices, you can divide it as pre-procedure, during procedure, and after procedure, early versus late, or you can divide it in this form: mechanical, cardiovascular, hematological, neurological, and infectious disease. So these are the complications where there can be device migration, device malfunction, valvular injury, chamber perforation, vascular injury, limb ischemia, access site hemorrhage in case of IABP, you can have a balloon rupture, hematological hemolysis, thrombocytopenia, thromboembolism, hemorrhage, cerebrovascular accident, peripheral nerve injury, infection like sepsis, and access site infection. Okay, so this is what. Uh, and then we have the weaning strategies. The weaning strategies, I think the only thing that you need is this. Basically, the IABP can be weaned from 1:1 to 1:2 to 1:3, and gradually or alternatively may decrease the volume serially by 10 to 25%. Okay, and we can the standard weaning is every 2 to 3 hours, and lowest level before the decannulation for the IABP is 1:3. Okay, this is the it slide that you have to remember. Cardiogenic shock, cardiac index is less, hypotension, vasopressor requirement, organ perfusion, increase in the left ventricular end diastolic pressure, screen for the MCS depending on hemodynamic assessment, underlying diagnosis, goals, exit strategy, contraindication, organ failures. Okay, and then we will have for RV failure, the devices are you have the Protect Duo with oxygenator. Okay, no respiratory failure. If it is there, you can go with Impella and Protect Duo. If there is no respiratory failure for a biventricular failure, can go with a Bipella, Protect Duo plus Impella. Respiratory failure, if it exists along with a cardiogenic shock, then we have to go for a VA ECMO or a Protect TO with oxygenator plus Impella. In case of mild impairment in LV failure, go over an IABP. If no respiratory failure, with a very low cardiac index, go for Impella or Tandem Heart. If a respiratory failure is there along with a cardiogenic shock, then one has to go for a VA ECMO. So this is the star slide in among all the slides that we have discussed. So I think I will stop here because we have two more topics by Dr. Priya, and then we are having sessions tomorrow. So we'll start with this tomorrow. Dr. Priya, are you there?
Yeah, I'm there. Yeah, I'll take
Yeah.
over from here.
Yeah. I think you can take over and finish off today because cardiac is a huge topic and we'll continue tomorrow. Okay.
Sure.
So from my side, I think this is the end for today. We have discussed around 10 topics today. If there are any queries, please do write up and let us know. Okay, we'll try to cover as much as possible. If not tomorrow, we will share the slides and share the articles with you so that you can read up and brush up all the topics before the exams. Thank you.
Yeah, thank you, Dr. Amrita. I'll be sharing my slides now. So is it okay with everybody to go ahead? I think we are almost reaching 10 o'clock. So I know it's too late, just two more topics to go. Okay, obesity, ICU management in an obese patient. And the next topic will be ABG, different methods of measurement, okay, analysis. So what is obesity? The definition of obesity is a body weight that exceeds the expected or ideal body weight by more than 10%. So the alternative definition, what you can consider is when somebody weighs more than 25% of the weight, normal ideal body weight, okay, and there is excess of fat content in the patient when there is more than 25% of the body weight in males and 30% of in females is attributable to fat. Okay, normally 15 to 80% of the body weight is fat. Okay, this is the definition of obesity. Morbid obesity is defined as exceeding twice the ideal body weight, and these are certain formulas that you need to know. So what is ideal body weight? Adjusted body weight. Adjusted body weight is equal to ideal body weight plus 0.5 times the difference between the total and the ideal body weight. What is predicted body weight? This is mainly used in terms of ventilatory strategies when you are. So Dr. Jasmine had already mentioned in men 50 plus 0.9 into height in centimeters minus 152 in kgs. So in women 45.5 plus 0.9 times height in centimeters minus 152. So this you'll get in the kgs. This is mainly when you're looking into ventilatory strategies. So, what is the classification of obesity? So, this is mainly based on the body weight divided by height in meters squared. So, underweight is less than, when the BMI is less than 18.5, it is underweight. Normal is 18.5 to 24.9. Overweight is when 25 to 29. Class 1 obesity is 30 to 34. Class 2 is 35 to 39. Class 3 is more than 40. So what is obesity paradox? So most large cohort studies in general population demonstrated there is an increased risk in both overweight and obese individuals. However, more recent data in hospitalized patients suggest that chronic illness has shown a J-shaped relation between BMI and mortality. So with overweight and moderate obesity, it has been associated with lower mortality. So this J-shaped relationship between BMI and mortality is known as obesity paradox. So we initially thought obesity increases the risk of mortality, but paradoxically, it is associated with increased survival. So that is known as obesity paradox. So what are the obesity associated complications? So because of increased adiposity, there is increased adipokine synthesis, more macrophages, inflammatory process that go cytokines, insulin resistance, and type 2 diabetes. And due to increased lipid production, the hydrolysis of triglycerides, increased release of free fatty acid, lipotoxicity, dyslipidemia, resulting in non-alcoholic fatty liver, steatohepatosis, and cirrhosis. In cardiac, there is a high risk of coronary artery disease. There is increased activity of the sympathetic nervous system that will result in high pulmonary arterial pressures. So that also proposes a risk of congestive cardiac failure, also stroke and chronic kidney disease. There is increase in activation of the renin-angiotensin system, which can lead to acute kidney injury and chronic kidney disease in the long term. Mechanical stress, because of the weight as such, there can be more pressure on the joints, resulting in osteoarthritis, increase in the pharyngeal soft tissue, causing obstructive sleep apnea, increase intra-abdominal pressure, risk of GERD, and esophageal Barrett's esophagus. So the challenges we can face when managing with obese patients: airway related, respiratory and cardiovascular consideration, nutritional, thromboembolism prophylaxis, monitoring and investigation difficulties, difficult vascular access, nursing difficulties in terms of skin management, bed sores, and drug dosing in terms of lipophilic as well as hydrophilic drugs. So physiological difference, when we look into obese patients, they have high oxygen consumption, CO2 production, increased work of breathing because of the high intra-abdominal pressure. The compliance of the respiratory system is as such decreased. The FRC is also decreased. They are at risk of obstructive sleep apnea syndrome. And more important is the difficult airway component that we need to manage when the patient is really decompensating. Paradoxically, in a perioperative mortality in obese patients have not been very high. This is also one of the terms of obesity paradox. And prognosis in terms of ARDS compared to non-obese patients, again, it is better in obese patients. So difficult airway related, we all know the Mallampati score, mouth opening, cervical mobility, everything can be restricted. When you're having a patient who needs intubation and mechanical ventilation, pre-oxygenation, always attempt with an NIV with a little higher pressure support and PEEP, and a CPAP which is slightly higher. HFNC can also be used, okay, and a moderate PEEP. So ARDS better survival. And when ventilating these patients, reverse Trendelenburg can be tried. Prone position is not a contraindication, but if prone is not going to be possible in the ICU, consider VV ECMO early. Okay, what are the strategies that you have to do? So maintaining a ramping position. Ramping position is placing increasing the height of the shoulder and the head, so that your targus almost is equal to the ear, to the sternal notch is almost in the same horizontal line. So you elevate the head by placing a ramp under the head and shoulders. So this position is very important when you do the laryngoscopy and intubation. And pre-oxygenation, I already mentioned, you can try with a little higher PEEP with NIV or with HFNC. So ventilatory strategies in non-ARDS patients and ARDS patients. So your tidal volume for your ideal body weight. So just note the body weights for each and everything. For nutrition, it's going to be different. So everything for drug dosing, it's going to be different. So for ventilation, for your tidal volume, it's going to be ideal body weight, 6 ml per kg, ideal body weight. So your targets are almost same as you do for a normal patient. Your PEEP, you titrate according to optimal oxygenation, your driving pressures, plateau pressures, so less than 30, less than 50. But this is something that you need to understand. Your plateau pressures may not denote your lung compliance, because your chest wall compliance is going to be more contributory to your plateau pressures. Ideally, if possible, these are candidates who can benefit from titration of PEEP with a transpulmonary pressure monitoring. So that is something different that you need to remember. So prone position, go ahead if the PF ratios are low. So your ventilatory targets, you have to mention about the transpulmonary pressure that can be more beneficial in these patients. Cardiovascular system, again, the fat mass related pathology, increased blood volume, cardiac output, ventricular hypertrophy because of the increased sympathetic drive, and diastolic dysfunction, ventricular dilatation causing obesity, cardiomyopathy. Also, these patients are prone to have pulmonary OSA, hypertension related to secondary to OSA, hypoventilation syndrome, and they are also prone to thromboembolism. Okay, and the metabolic syndrome, which also proposes a cardiac risk in terms of coronary artery disease. So monitoring the hemodynamics is very crucial in these patients. Oscillometry method may be less accurate. Arterial line needs to be placed. In fact, sometimes you have to need a lengthy line in some scenarios, and also placement might be a little difficult, including the central venous catheters. Ideally, the peripheral venous access might be difficult in these patients. You'll have to go in for a central venous access. The transthoracic echo, there will be a poor window. So if there is a real need, transesophageal echo needs to be considered. Cardiac monitoring, esophageal Doppler, so those can be useful. So adjusted body weight. So your fluid resuscitation should be done based on your adjusted body weight. So we already saw what is adjusted body weight. It is nothing but ideal body weight plus 0.45 times total body weight minus your ideal body weight. So this you can do your fluid resuscitation based on that. Had better outcome compared to actual body weight and ideal body weight. So vasopressors should be titrated to your clinical effect, to clinical effect. In terms of renal, there is obesity related nephropathy. There is increased intraglomerular pressure. There is a high metabolic demand. Renal tubular sodium resorption is increased, and obesity related glomerulomegaly can be there. Focal or segmental sclerosis can also be present. Okay, other thing going into, again, obesity paradox. There's lower mortality in these patients with AKI and CKD. Okay, there is improved hemodynamic stability during RRT, and the fat tissue serving as a buffer for uremic toxins. Though encephalopathy, uremia related symptoms can be less in these patients. So, but the difficulty we might face in patients with AKI is that the criteria that we apply, that is oliguria criteria and all that, can be falsely positive in this patient because there is no ideal mention of which body weight we need to follow. Also, in addition, whether during CRRT, the dose of CRRT, whether it's the actual adjusted or ideal body weight, has no mention of it. So this is a cavity in the guidelines as well. So there's no recommendation for obesity. In terms of immunity and nutrition, so adipose tissue has some regulation in physiological and pathological process in immunity and inflammation. So several hormones like adipokines and classical inflammatory mediators result in a state of chronic inflammation. So their baseline CRP levels will itself be high. And there is a high rate of development of insulin resistant and more cardiovascular complications. The innate immunity as well as adaptive immunity is affected in obese patients. There is perturbations in the T cell immunity as well. But still, though we understand they are at risk of infection, there is obesity paradox, which has been described in these patients in relative to pneumonia and sepsis. So the outcome is good in these patients. Again, venous thromboembolism, a very high risk of DVT and PE. Abdominal compartment syndrome can occur. Skin-related issues, it's a serious problem. Bed sores can frequently be there. Visceral obesity is also predisposing to high cardiovascular risk. It's a pro-inflammatory state, pro-thrombotic state, hyperfibrinogenic, okay? And regarding to prophylaxis, DVT prophylaxis, whether compression stockings, there is no recommendation for pneumatic compression devices, as well as the low molecular weight heparin, the dosing what we give may not be adequate for these patients. Okay. And ultrasound, in terms of investigations, echo, ultrasound, so all those may be impaired by the increase in soft tissue thickness. And coming to the drug dosing, hydrophilic or lipophilic. So depending on the nature of the drugs, the volume of distribution is going to vary. For lipophilic drugs, because of the high adipose tissue content, the volume of distribution is going to be very high. But which body weight you have to follow is that the adjusted body weight, it is more relevant than the ideal body weight. So you follow the adjusted body weight for both hydrophilic and lipophilic drugs. So this is, we have mentioned this already. So every organ, what are the changes? Brain-related, mood disorders can be there, social stigma, cardiovascular, chronic cardiovascular, ischemic heart disease, cardiomyopathy, increased cardiac output, okay? And risk of insufficient fluid resuscitation. Outcome, obesity paradox again. Respiratory wise, decrease glomerulomegaly, focal glomerular sclerosis, and chronic increased risk of AKI and CKD. Okay, so hyperglycemia, dyslipidemia, so hidden sarcopenia, increased fat mass. So these are the various organ impact of obesity on various organ systems. When coming to the nutritional aspect, this is something very important that you need to understand, mainly because the different guidelines suggest different kilocalories, different protein, and whatever the body weight they consider is different. So international guidelines recommend using measuring resting energy expenditure. with indirect calorimeter, but this is going to be something very, very difficult. Aspen guidelines recommend 65 to 70% of the resting energy expenditure. So if you are taking the actual body weight, the kilocalories that you need to be giving is going to be 11 to 14 kilocalorie per kg of the actual body weight per day. And if the BMI is between 30 to 50. If the BMI is more than 50, then you consider 22 to 25 kilocalorie per kg ideal body weight. So based on the BMI, you have to choose between actual body weight and ideal body weight. And if it's actual body weight, 11 to 14, ideal body weight, 22 to 25. And hypocaloric high protein diet with 2 to 2.5 grams per kg. This is as per the Aspen guidelines. It is based on urea concentration. So this is the Aspen guideline. Aspen guidelines suggest that 20 to 25 kilocalorie of adjusted body weight per day, and no further adjustments below resting energy requirements. And the protein is 1.3 grams per kg of the adjusted. So Aspen suggests for both calorie and for protein, the adjusted body weight. So this is obesity related. Next topic, we'll be looking into the acid-base disturbances, the different methods of measurement. So we know there are 3 methods, okay? I have just made a table mentioning the core concepts and the principles of and the differences between the 3 methods. So the first method, the traditional method, what we normally use is the physiological method or the Boston approach. That is the Henderson-Hasselbalch approach. So this was first introduced in US in 1916, okay? And the core concept is that it takes into account the respiratory and the metabolic components using the bicarbonate buffer system. This is based on this formula, the Henderson-Hasselbalch equation, where pH is equal to pKa plus log of bicarbonate divided by PCO2. So the key variables here are pH, PCO2, and bicarbonate. The strengths of this is it's very simple to use, widely used in most of the ICUs, and everybody is trained to use. We always follow the 7 steps. And it oversimplifies. Limitations is that it oversimplifies, it ignores the unmeasured ions and other buffers like albumin, phosphate, hemoglobin, all those buffers, it actually ignores. So, and the cause for the acid-base disturbance, you will not be able to mention with the Henderson-Hasselbalch approach. Next is the base excess approach, also known as the standard bicarbonate approach. This was a European approach from Copenhagen, primarily used in polio epidemics and all that. There was an issue because of the measurement of base excess component alone, ignoring the respiratory variation. So this quantifies the metabolic component independent of the respiratory influences by calculating the base excess. So what is base excess? Base excess is the amount of strong acid or base required to return the blood pH to 7.4 at a PCO2 of 40 millimeters of mercury at 37 degrees. So this considers the base excess. A base excess of -2 to +2 is normal, wherein a more negative value is acidic and more positive value is considered to be alkalotic. Okay, also pH and PCO2 are taken into consideration. So this considers the whole body. The standard base excess method is actually considers the whole body influence and the influence of hemoglobin as such. But whether it's validated in all metabolic disturbances, no, it is a single value for metabolic disturbance. And primarily it is used in trauma. A high base, a negative base deficit has a prognostic significance in shock severity and need for resuscitation. In trauma patients, a high base deficit denotes increase in bleeding or increase in need for volume replacement and blood product replacement. So in trauma, you have the classification of shock wherein base deficit is one of the components. So remember that. So trauma sepsis, yes, it has a value. And abnormal, it assumes usually the standard base exists, what they are calculating is for a hemoglobin of 5, and then it is normalized, and then it is actually adjusted. It assumes normal hemoglobin and one compartment model. Okay, this is the disadvantage of it. The Stewart or the physiochemical method, this was proposed by Peter Stewart in 1981 in Canada, actually. So this is based on the principle of laws of electroneutrality, laws of conservation of mass and mass action. So when you have positive and negative ions, both should be equal in a system. So that is the basic concept of this physiochemical approach. So they consider two variables, the independent variables and the dependent variables. So these both are going to be the variables which are going to affect the pH. The three independent variables are PCO2, strong ion difference, and A dot, where the dependent variables are pH and bicarbonate. Okay, so the dependent variables vary based on the independent variables. So what is the strong ion difference? What are the strong anions and cations? Sodium, potassium, calcium, and magnesium minus chloride and lactate. So this is the strong ion difference. Whereas it considers the pH PCO2, strong ion A dot, and strong ion gap. So what is the strong ion gap? We'll see that later. Strengths is that it takes into account the unmeasured anions and all, like albumin, phosphate, lactate effects, fluid effects. So everything it takes into account. So it is very complex, but still you will be able to identify what is the pathology or what is the reason for the acid base abnormality. So it is very important in kind of explaining the reason or etiology of the acid base problem. But it is very complex. The equation is going to be very difficult. You'll have to have a lot of variables that are available. You'll have to have the phosphate level, albumin level, lactate level, sulfate, and you'll have to look into various amount of contributory factors. And whether the measurement, every lab, the measurement of some of the electrolytes can vary. So that can influence the strong ion difference as well. Okay, so validity is something, and the strong ion difference is something that depicts the plasma only, not the entire component, the entire body component. So when we are looking into the traditional approach, that is the Boston approach or the Henderson-Hasselbalch approach, here the pH is defined by the balance between the respiratory and the metabolic components. So bicarbonate and PCO2 are the buffer systems, important buffer systems. So as this equation goes, you calculate the pKa as well as you know the pH by bicarbonate and carbon dioxide. How will you interpret it? First, there are several steps of interpretation, wherein first step being know whether it's acidemia or alkalemia, looking at the pH, look at the PCO2, you know whether it's respiratory alkalosis or respiratory acidosis. Then you look at the pH and the PCO2, whether it moves in the opposite direction or same direction. So if it moves in opposite, it's respiratory acidosis. It moves in the same direction, both are low, metabolic acidosis, and looking for the compensation. For example, the primary disorder, if it's kidney, whether the PCO2 is going to be compensating for the bicarbonate or not, or if the primary pathology is in the lungs, whether the kidneys are going to be compensating. So use the compensatory formulas and the rules to know whether there is associated mixed disorder. So for metabolic acidosis, you have the formula 1.5 times bicarbonate plus 8 plus or minus 2, and for alkalosis 0.7 into bicarbonate. So similarly for respiratory alkalosis and acidosis, for every change in the pH, for every change, 10 millimeters change in the carbon dioxide level, your bicarbonate will vary. For respiratory acidosis acute setting, it is going to be 1, and for chronic, it's going to be 3. Alkalosis acting for chronic alkalosis. So based on, you can add to your bicarbonate whether it's and comparisons bicarbonate. The next step would anion gap, calculating the anion gap, whether the anion gap is normal. Anion gap, the factor is 2.5 or deficit in the so 2.5 times your albumin 4 minus your serotonin and added to the albumin gap. So that will give you a corrected albumin anion gap. Next step will be looking at the delta ratio gap, delta anion gap divided by delta bicarbonate gap. So if it's less than 0.4, it's pure anion gap metabolic acidosis. If it is between 0.4 to 0.8, it's mixed NAGMA and HAGMA. If it's 0.8 to 2, it's pure high anion gap. And if it's more than 5, it's HAGMA. Either a metabolic alkalosis can be associated also. Okay, that is our traditional approach or the Boston approach. Next is the base excess approach. So here, metabolic component mainly. So the base excess is actually the amount of strong acid or base that needs to be added to a liter of blood to return the pH to 7.5 at a PCO2 of 40 and temperature of 37 degrees. And this mentioned in millimoles per liter. Okay, the amount of strong acid mentioned in millimoles per liter. The interpretation: less than, more negative metabolic acidosis, more positive metabolic alkalosis. So usually the modern acid-base analyzers calculate the base excess based on actually several algorithms or normograms that have been used, mainly the Vance-like, something known as the Vance-like equation. And this is done at a standard. When we get the standard base excess, it is for hemoglobin of 5. The actual is actually calculated for the patient's calculated for the patient's hemoglobin. So the simplified formula, okay, this is the base excess formula wherein it notes the bicarbonate, hemoglobin, and pH. Okay, it takes into account the 3 variables. And the base excess is calculated under the assumption that respiratory PCO2 are standardized. Okay, PCO2 are standardized, only the metabolic component remains. So this is similar to the steps we had looked into the Henderson-Hesselbank approach. These are the various steps that we can use to make sure whether it's a acidosis or whether the compensation is there, whether there is an associated, that is a mixed acid-base disorder that is also going on, anion gap corrected with albumin, and then interpret based on the findings. So we'll look into it one by one. Acidemia when the pH is less than 7.38. So you look at the base excess. If the base excess is negative, less than more negative, then you go into the compensatory formula for the secondary respiratory compensation, your delta PCO2 and your base excess. There are formulas for this. So, and you look into your expected PCO2 and you calculate it. If it is lower, then additional respiratory alkalosis is there. If the PCO2 higher than the expected PCO2, additional respiratory acidosis is there. Then calculate the anion gap corrected for albumin. Then normal anion gap, evaluate for the etiology. High anion gap, again, consider your differential diagnosis, and in case of Mixed acid-base disturbances, you look into the etiology. Last step would be to calculate the osmolar gap also. In case of respiratory acidosis, secondary metabolic compensation, there are formulas for this actually. So the base excess, you need to know. Base excess, the formula is 0.4 times the delta PCO2 in terms of chronic respiratory acidosis. And last step would be anion gap, albumin correction. So these are the various compensatory formulas that are available. It is difficult to remember, but if you want to, you can, but you need to understand this is how the steps are being done. For alkalemia, similar, the metabolic alkalosis, base excess is more than 2. pH is increased, PCO2 is increased, base excess is increased, and the secondary respiratory response, your PCO2, if you want to calculate, it is 0.6 times the standard base excess. So if the PCO2 is lower than the expected, it is additional respiratory alkalosis. If PaCO2 is higher than expected, additional respiratory acidosis. So evaluate for metabolic alkalosis. Okay, often what are the causes for metabolic alkalosis? You can identify. For respiratory alkalosis, then you go into the compensatory formula, secondary metabolic response. So standard base excess is equal to 0.4 times your delta PCO2 for chronic respiratory alkalosis. Then again 0.4 times. If it is less, then you need to actually interpret based on your values. Last step would be anion gap calculation. So that is about the Henderson-Hasselbalch and base excess approach. Next is the Stewart approach, that is the physiochemical approach. So it is based on the fundamental principles, 3 laws of chemistry, that is law of conservation of mass, law of electronegative neutrality, and law of mass action. So based on these, that is neutrality. So total positive is equivalent to the total negative charges. So this is very important. So there are 3 independent variables that are considered, and all the others are considered to be dependent variables. The independent variables are PCO2, strong ion difference, and ATOT. ATOT is weak acid. So PCO2, it is controlled by the lungs. Strong ions, what are the strong anions and strong cations? Strong anions are sodium, potassium, calcium, and magnesium, minus your chloride and lactate. So these are strong ions. The normal strong ion difference is almost 35 to 40. So 40 is something that you consider. If the strong ion difference decreases, that means it is acidosis. Then your anions are high. So that is acidosis. If your strong ion difference is high, that means your cations are high. That is alkalosis. Okay, you interpret based on your strong ion difference. The total concentration of the weak acids. So here it is not taking into account the weak acids. So the weak acids are albumin and phosphate, which are very important. So the weak acids increase in albumin or phosphate can cause acidosis, and your albumin and phosphate decrease will result in alkalosis. So the pH is determined primarily by the independent variables. The pH is determined by these 3 factors, and the secondary effect is by the dependent variables. Okay, so the dependent variables are bicarbonate and all. So how will you calculate the strong ion gap? So what is the strong ion gap? So first you calculate the strong ion difference. So this is how you calculate the strong ion difference. And when you measure it, there is something on, if you calculate it with this and you measure and you actually get the effective strong ion difference, measure it, and the calculated one, there is a difference between the measured and the apparent effective strong ion difference. That is the strong ion gap. So that denotes the hidden metabolic acidosis that is contributed by the unmeasured anions. So what are the unmeasured anions? Can be sulfates, there can be aluminum or some other ketones. So this can contribute to the strong ion gap. So clinical application. So you check for the strong ion difference. You'll get to know what other contributory factors can be there. Check for the HATOT. So albumin and phosphate, the compensatory, and you calculate the strong ion gap. It can reveal the unmeasured anions. Okay, the main difference between the Henderson-Hasselbalch and the Stewart approach. Here they are looking into only two components. In the Stewart approach, here the metabolic component, the difference between the strong anions and strong cations is going to be your strong ion difference. Your ATOT is nothing but it is similar to the weak acids that is contributed by your phosphates and albumin. Okay, it's slightly it is almost similar to your albumin, but beyond this, your effective strong ion and your actual strong ion difference, if you are going to find a difference, there will be some strong ion gap that is mentioned. So the strong ion gap is is contributed by the unmeasured anions. So this you can see. If the strong ion difference is more negative, it is more acidosis. If it is more positive, it is due to alkalosis. So whenever there is a variation in water content in the body, whether it's excess or low, whenever there is a change in the sodium levels, so that can change the strong ion difference. So this explains the concept of normal saline induced acidosis. So when you actually give normal saline to the patient, you increase the sodium content, okay, and you increase the volume as such. So that will actually affect the strong ion. The strong ion of the saline is going to be low. Strong ion difference is going to be low. Whereas the strong ion difference of the other balanced salt solutions is going to be almost similar to our plasma. So how do you calculate which variable is attributing to the strong ion difference? So this is something that has been mentioned for the Stewart approach. So the variables which is more contributory, if you look into the difference between the sodium and chloride, it is considered 35. So if there is a excess deficit, that means the sodium chloride base excess effect. So how much effect each variable is contributing. So if the difference is more, that much effect is contributed by sodium chloride base excess effect. If lactate, 1 minus measured lactate, that is lactate base excess effect. For albumin, 42 minus the measured albumin into 0.25 times. So that is albumin base excess effect. And overall base excess effect is addition of all three variables. And this is your that is your unmeasured and acids, actually your unmeasured acids. This is the calculated one. The actual measured one, if you look into that, this will be your unmeasured anions. This will be the contribution. So this is the simplified way to base excess approach. So we come to the end of today's session. I hope things are clear to everybody. If it is complicated, just remember this table. So if you are asked such a question, you can mention the core concepts, actually, what every method is taking into account, and then the equations and what is the main principles, core principles, and major strengths and limitations. And there is a good paper in NEGM. I'll share it based on the base excess method. You can go through it in detail. It's very complex, but you can go through it. So these are the various methods of ABG measurements. Any doubts or anything? I know it's a very busy day and we have extended beyond by half an hour. I guess almost 12 of you are staying back. any additional material that you need in these or anything that is not clear, we can share additional material on this. Is it okay? If there's nothing, can we wind up? Okay. Thank you, Dr. Manoj, for replying. Okay, thank you all. Good night and go ahead with your preparations. Bye.